Hello students. Hi everyone. Good morning all of you. Yes. Please check my voice. If everything is okay, please give me thumbs up. Yes. Yes. Hi Dr. Khan. Hi Debanjan. Please check my voice. Yes. If everything is okay, please give. Okay. So good morning all of you. Welcome to a FMG Marathon series. We'll discuss the important topics from the biochemistry. All of you know that the preclinical subjects, the phase 1 subjects, they are very, very important for the any entrance examination, whether it is FMG, INICT or NEET PG entrance examination. और FMG कोई easy exam नहीं है. FMG is equally competitive exam when it is compared to INICT and the NEET PG entrance examination. So we'll discuss the important topics from the biochemistry and these topics are generally asked in the examination, frequently asked in the entrance examination. That topics generally includes the clinical cases from the vitamins and minerals, the vitamins, the water soluble, fat soluble vitamins and the minerals, trace elements and the major elements. Okay, so the frequently asked questions on the zinc, the vitamin C, this niacin, it is frequently asked topic, niacin. Then vitamin B1, that is thiamine, frequently asked topic. Then B12 and the folic acid. It is repeatedly, there is question on the B12 and folic acid. From the mineral topic, the zinc, iron, selenium, these are the frequently asked minerals in the entrance examination. Then we'll focus on the metabolic pathways, the rate limiting enzyme, the energetics and the disorders related with the metabolic pathway we'll discuss. We'll discuss the uncouplers and inhibitors of electron transport chain and oxidative phosphorylation. We'll discuss the uncouplers and we'll discuss the inhibitors of electron transport chain. Complex 1, complex 2, complex 3, complex 4 of electron transport chain. We'll discuss the effect of competitive inhibitor on Km and Vmax. Km means the substrate concentration to produce half of the maximum velocity, and the Vmax, the effect of concentration, means effect of the concentration of competitive inhibitor, non-competitive inhibitor and uncompetitive inhibitor. The Lineweaver-Burke plot, the double reciprocal plot, X shape, V shape and the parallel line we will discuss. We'll discuss the important use of the Vacutainers. For example, for the ABG analysis, we use the green top tube, that is heparinized tube. In that way, this is the trending topic, Vacutainers. Amino acid and their derivatives, for example, the products given by the tyrosine, product given by the tryptophan, cysteine and the product given by the glycine. These are the important topics from the amino acid derivatives. Also the classification of amino acid based on their metabolic classification, then essential, non-essential criteria, essential and non-essential amino acids and polar and non-polar amino acid. This is important, the trending topics. Then match the pair topic, for example, the diseases, inborn errors of metabolism and the enzyme deficiency, or the blotting techniques, southern blotting, northern blotting, western blotting and eastern blotting technique. Then we'll discuss the ABC transporters and related disorders, for example, Tangier's disease, Dubin-Johnson syndrome, Rotor syndrome. It is related with the mutation in the protein which codes for the ABC transporters. Then ABG analysis, specifically we will focus on the high anion gap metabolic acidosis, the causes of high anion metabolic acidosis, the mud piles is a mnemonic. Then various glucose transporters, specifically GLUT2 and GLUT4 is important. Also GLUT1 is important. GLUT1, GLUT2 and GLUT4. These are the important transporters, glucose transporters, types of facilitated diffusion. Then we will focus on the glycogen storage disorder, lysosomal storage disorder, mucopolysaccharidosis, that is Hurler, Hunter, Sanfilippo, Marchio, Morotilami, Sly disease. We'll discuss on the lipoproteins and related disorders, that is Fredrickson classification of hyperlipoproteinemia. We will discuss. Then DNA repair mechanism, this can be asked in the match the pair type of question, or there is question on the hereditary non-polyposis colon cancer or the xeroderma pigmentosum. Then what do you mean by SDA and the respiratory quotient, tumor markers for the diagnosis of various cancers, and the various inhibitors, antibiotics that are used in the treatment of various diseases, and they inhibit the translation process, protein biosynthesis. So we'll discuss the mechanism of tetracycline, doxycycline. This is overlapping topic with the pharmacology. So these are the important topics, the high alert area, the top priority area from the biochemistry. We'll discuss these topics with the help of this workbook session. This is the workbook session. See, first is the Vacutainers. This is the trending topic, very very important and frequently asked in any entrance examination, Vacutainers and their use. See, the order of draw is important. So order of draw, for the order of draw, remember this mnemonic, that is bunny rabbit. See, bunny rabbit get pregnant food. Bunny rabbit get pregnant food. This is mnemonic for order of draw. Means when we collect the blood sample, this order should be there. This means जो सैंपल हम कलेक्ट करते हैं उसको एक स्पेसिफिक सीक्वेंस में वैक्यूटेनर ट्यूब में डालना पड़ता है. फर्स्ट इज द ब्लड कल्चर बॉटल. सबसे पहले आता है ब्लड कल्चर बॉटल. सो रिमेंबर दिस न्यूमोनिक, ब्लड कल्चर बॉटल सबसे फर्स्ट. द फर्स्ट वन इज द in the blood culture bottle. Then is the blue tube, that is citrate tube. Blue is the citrate tube. Then it is red or the golden yellow or the yellow tube. This is alternative to red or yellow. This is alternatively used. This is generally this is with the clot activator is there. There is clot activator gel in the yellow or golden yellow tube. Then green is heparinized tube, which is used for ABG analysis. This purple, P for purple. So it is purple tube. It is EDTA tube. It is used for the CBC analysis, also glycated hemoglobin estimation. And this is fluoride, F for fluoride tube. It is gray color top, gray top tube, fluoride tube, which is having the sodium fluoride and potassium oxalate in the 1:3 ratio. So fluoride ion inhibit the enzyme enolase. Now see this blue citrate tube. It is for the coagulation analysis. It is for the coagulation study. The citrate tube. Then plain bulb and the yellow. This is alternatively Miss red, and this is plain bulb. It is used for, it is without any additive, and generally this yellow or golden top tube, this is with the clot activator gel. This is used for the LFT, liver function test, KFT, kidney function test, electrolytes estimation, these tubes, these Vacutainers are generally used. Generally plain tube is Miss red top tube is widely used. And alternatively the yellow or the golden top tube is used. Alternatively, this is for the serum biochemistry. This is for the serum biochemistry analysis, biochemical analysis of various parameter. This red or the yellow top tube, it is used. Then green, it is heparinized tube or heparinized syringe. It is used for ABG analysis, arterial blood gas analysis. Also this tube can be used for the immediate biochemistry parameters. For example, electrolyte estimation, this tube also can be used. Immediate whole blood is used in the arterial blood gas analysis, and this is heparinized tube. This is purple color tube. It is EDTA tube. It is mainly for the CBC analysis, complete blood count. Also it is used for HbA1c estimation. Remember HbA1c, it tells you about the average blood glucose level for past 8 to 12 weeks. For past 8 to 12 weeks, this is HbA1c importance. It is the preferred test for HbA1c estimation is ion exchange chromatography. It is ion exchange chromatography which is used for the HbA1c estimation, and for the collection of sample we use the purple cap tube or EDTA tube. EDTA tube, it is used for the CBC HbA1c estimation. Then this is fluoride, F for fluoride. This is fluoride tube. It is a gray cap tube. It is having the sodium fluoride and potassium oxalate in the ratio of 1:3. It is in the ratio of 1:3. This fluoride ion inhibit the enzyme enolase of glycolysis by non-competitive irreversible inhibition and maintain the glucose level in the collected sample. It maintain the glucose level in the collected sample if there is time lag between the collection and the processing. In that situation, this fluoride bulb, it is very important. Fluoride ion inhibit the enzyme enolase, maintain the glucose glucose level in the collected sample give you the true glucose value, So remember this, first is the blood culture bottle followed by the blue citrate tube, then red or yellow tube, it is alternatively used tubes, red or yellow, then green tube, heparin tube for the ABG analysis, purple tube, EDTA tube for the CBC and HbA1c estimation, fluoride tube, gray cap tube for the glucose estimation, sodium fluoride, potassium oxalate in the 1:3 ratio. Fluoride ion inhibit the enzyme enolase by non-competitive irreversible inhibition. Remember that for HbA1c estimation, we use the purple color tube or the EDTA tube. HbA1c tells you about the average blood glucose level for preceding 8 to 12 weeks. It is non-enzymatic attachment of glucose to N-terminal valine of the beta globin chain. Past 8 to 12 weeks. This is important. So this is all of important points related with the Vacutainers which are used in the biochemistry, clinical biochemistry for the collection of the blood sample. Now the second important topic, amino acids and their derivatives. This is important and trending topic nowadays. So the products given by the different amino acid. Now see, phenylalanine and tyrosine, they are considered together because phenylalanine, by the phenylalanine hydroxylase, it is converted into tyrosine. So phenylalanine is converted into tyrosine. This phenylalanine is converted into tyrosine, and this tyrosine will give you different products that includes the dopamine, norepinephrine, epinephrine in the catecholamine synthesis pathway. It will give you dopamine, norepinephrine, epinephrine. Then in the thyroid gland, it will give you T3 and T4 thyroid hormone. In skin, hair and eyes, it will give you melanin. So dopamine, norepinephrine, epinephrine, T3, T4, melanin. And along with this, this is both glucogenic and ketogenic amino acid. All three amino acid, phenylalanine, tyrosine, tryptophan, aromatic amino acids will give you both glucose and fat. Okay. So remember, both glucose and fat, both glucogenic and ketogenic amino acid, it includes phenylalanine, tyrosine, tryptophan and isoleucine. So see, these are the products given by the tyrosine: dopamine, norepinephrine, epinephrine, T3, T4 in the thyroid gland, and melanin in skin, hair and eyes. Tryptophan, another aromatic amino acid, will give you NAD, NADP, serotonin, melatonin, and it is excreted in urine as hydroxyindole acetic acid. Hydroxyindole acetic acid, it is a marker, it is a tumor marker in the carcinoid syndrome, urgent affinoma carcinoid syndrome, HIAA, increased amount of HIAA in the urine. Hydroxyindole acetic acid, it is a tumor marker for the carcinoid syndrome. So these are the products. Remember, melatonin is given by the tryptophan, melanin is given by the tyrosine. Cysteine will give you the taurine, pyruvate, glutathione, sulfide and the coenzyme A. So cysteine will give you coenzyme A, taurine, pyruvate, glutathione, then sulfide. These are the products given by the cysteine. Another important amino acid is glycine. Glycine is another important amino acid. Now see, this is the glycine. This will give you heme. Glycine. Glycine plus succinyl coenzyme A is the first step in the heme synthesis. Glycine will give you heme. Then it will give you creatine. Creatine phosphate, creatinine. Then it is a component of glutathione. 30% glycine is there in the collagen structure. The collagen is composed of near about glycine XY. So 30% is glycine in the collagen structure. It is the smallest amino acid and it can easily accommodate in the turn of the alpha helix. So it is collagen, 30% glycine molecule. Then C4, C5 and N7 of the purine ring. It is contributed by the glycine. Glycine combined with the benzoyl coenzyme A, it forms the hippuric acid. Hippuric acid excretion test, it is used for the testing the detoxification function of the liver. Test for, remember the HD, hippuric acid excretion test, it is a test for detoxification function of the liver. Remember this, detoxification function of the liver. And one more MCQ related with the glycine, sodium benzoate. It is given benzoate, it is given in the treatment of hyperammonemia, increase NH3 level. Sodium benzoate is given, and this sodium benzoate, it is converted into benzoyl coenzyme A. It is converted into benzoyl coenzyme A. This benzoyl coenzyme A combines with the glycine and remove one molecule of ammonia in the form of glycine. By combining with the benzoyl coenzyme A, it is excreted in the urine as hippuric acid. So this is removal of one molecule of ammonia in the hyperammonemia when the sodium benzoate is given as a drug. When we give the phenylbutyrate as a drug, phenylbutyrate is converted into phenyl acetate, and phenyl acetate combines with the glutamine and removes two ammonia molecule. Remember this mechanism. This is also a pharmacology question, also in the treatment of hyperammonemia. So it is sodium benzoate will remove one molecule of ammonia, and sodium the phenylbutyrate, it is converted into phenyl acetate and it removes two molecules of ammonia when it is given in the treatment of hyperammonemia. कौन सा बोला मैंने? See, sodium, not sodium, it is phenylbutyrate. Phenylbutyrate it is given. Phenylbutyrate in our body, it is converted into phenyl acetate. And this phenyl acetate combines with the glutamine. And it forms phenyl acetylglutamine. And it is excreted in the urine. So two molecules of ammonia, it is removed by this glutamine in the form of glutamine. It is removed, it is combined with the phenyl acetate. This is a conjugation reaction where phenyl acetate combines with the glutamine is the conjugating agent, and it is converted into phenyl acetylglutamine and it is excreted in the urine. So glutamine, in the form of glutamine, two molecules of ammonia, they are removed. This is given in the treatment of increase ammonia level. So these are the products of glycine: heme, creatine phosphate, creatinine, glutathione, collagen, C4, C5, enzyme of the purine ring, hippuric acid. These are the products given by the glycine. One more important thing, the easy thing to remember, that is the mat will fly. Remember, these are the essential amino acid. Mat will fly. There are 10 essential amino acid. Of this 10, 2 amino acids, they are semi-essential. They are known as semi-essential. Essential amino acid means they are not produced in our body. There is need to be supplied, they need to be supplied in the diet. They are known as essential amino acid. There are 10 essential amino acid. What is catch here in this mnemonic? There is no tyrosine, because phenylalanine will give you tyrosine. So there is no tyrosine, and pyruvate will give you alanine. There is no alanine. So remember, no tyrosine is there. No tyrosine and no alanine is there in the mat will fly. No tyrosine, no alanine is there in the essential amino acid. So it is methionine. It is arginine, which is semi-essential. Then it is tryptophan, it is threonine, it is valine, isoleucine, leucine, phenylalanine, histidine. Again, histidine is the semi-essential amino acid, and the lysine. Count 10. So this is first, second, third, fourth, 5, 6, 7, 8, 9, 10. These are the 10 essential amino acid. 2 semi-essential, that includes arginine and histidine. These are the semi-essential amino acid. So remember this amino acid classification, the essential and non-essential amino acid. The second important thing is the glucogenic, ketogenic, and both glucogenic and ketogenic amino acid. In that, remember this ketogenic amino acid, that is ketogenic amino acid, it is leucine, which is more important, means exclusively ketogenic amino acid, followed by the lysine. Lysine. This type of question can be there in the match the pair type of question. मैच द पेयर, इस एक लाइन में उनकी कैरेक्टरिस्टिक दी रहेंगी और दूसरे लाइन में उनके नाम दिए रहेंगे. सो कीटोजेनिक अमाइनो एसिड ल्यूसिन एंड लाइसिन, बोथ ग्लूकोजेनिक एंड कीटोजेनिक अमाइनो एसिड, इट इंक्लूड्स एरोमेटिक, तीनों एरोमेटिक अमाइनो एसिड्स, दैट इज phenylalanine, tyrosine, tryptophan and isoleucine. These four amino acids are both glucogenic and ketogenic in nature. Ketogenic amino acid, leucine, lysine. Rest of the amino acids, they are glucogenic in nature. Then the polar and non-polar. Remember the non-polar amino acid by their classification. non-polar amino acid, not soluble in water, non-polar hydrophobic amino acid. It includes aromatic, all three aromatics, that is aromatic amino acid, phenylalanine, tyrosine, tryptophan. These are the aromatic amino acid. Aromatic amino acid. Second one is the branch chain amino acid, valine, isoleucine, leucine. Valine, isoleucine, leucine, that is branched amino acid. Branched amino acid. Then simple amino acid, alanine. Alanine is the simple amino acid which is hydrophobic. Then sulfur containing amino acid, methionine, that is sulfur containing amino acid, methionine. And the proline, amino acid proline. These are the non-polar amino acid. Rest of the amino acid, they are polar in nature. So remember the non-polar amino acid by their classification: aromatic amino acid, branch chain amino acid, simple amino acid, alanine. The glycine is polar. Methionine is sulfur containing amino acid, is non-polar. Proline is non-polar amino acid. So these are the non-polar amino acid. The question can be there in the form of match the pair type of question. Match the pair type of question. So this is very, very important. Now coming to the vitamins and their related disorders. Vitamins with their related disorder. Just wait. Hi everyone. Just wait. Normal values. Okay, just wait. See, vitamins, their RDA, their sources, and their biochemical functions and deficiency manifestations, they are important. Okay. Now, RDA. The RDA, these are particularly important in some vitamins. For example, vitamin A, D, E, K, then vitamin B9 and the that is B12. Then it is important in case of the vitamin C, and it is important in case of the minerals also. RDA, recommended daily allowance. Okay, we'll discuss the RDA. First, we'll solve this match the pair. See, we'll go in reverse direction. Scurvy, it is the that is perifollicular hemorrhage, gum bleeding, the bleeding in the joints, the petechial hemorrhage, ecchymosis, scorbutic rosary. The beaded appearance of chest is there in the scorbutic rosary. So it is because of the defective collagen synthesis, because of the defect in hydroxylation process, hydroxylation of proline and the lysine, defect in the prolyl hydroxylase and lysyl hydroxylase. Scurvy, it is due to the vitamin C deficiency. Scurvy, it is due to vitamin C deficiency. It is, so vitamin C deficiency causes scurvy. Vitamin C deficiency causes scurvy. Okay, rickets, it is in the children. The spongy bones, when the neonate is there, the wide open fontanelle, then frontal bossing is there. When he starts crawling, the widening of the wrist occur. When he starts that is walking, in that condition the bowing of the legs occurs. So then Harrison sulcus, rachitic rosary, craniotabes in the newborn, craniotabes, that is ping pong appearance of the ping pong like skull is there, that is known as craniotabes. These are the manifestations of the rickets. So rickets is due to the vitamin D deficiency. So this is rickets. देन बेरी का लिटरल मीनिंग होता है वीकनेस, बेरी, ड्राई बेरी, वेट बेरी, इन्फेंटाइल बेरी, एंड वर्निकेस कोर्साकॉफ सिंड्रोम. इट इज ड्यू टू विटामिन B1 deficiency, that is thiamine deficiency. This is thiamine deficiency causes bery, and also it causes Wernicke's Korsakoff syndrome in chronic malnutrition cases and in chronic alcoholic. And in cases of the malnutrition, there is Wernicke's Korsakoff syndrome. Thiamine status of the body, it is checked by the RBC transcriptolase activity. Remember RBC transcriptolase activity to check the thiamine status of the body. Niacin and thiamine, these are frequently asked question in the entrance examination. Niacin deficiency causes classical 3Ds, diarrhea, dementia, dermatitis, that is known as pellagra. Niacin deficiency causes pellagra. that is classical 3Ds: diarrhea, dementia, and dermatitis. Here the dermatitis, it is Castle's necklace dermatitis and glove and stalking appearance of hand and feet. It is sun exposed part of the body which is affected in the niacin deficiency. Pellagra, classical 3Ds. Pantothenic acid, vitamin B5, pantothenic acid, vitamin B5 deficiency causes burning feet syndrome. Burning feet syndrome, there is burning, there is sense of hotness, numbness, feeling of hotness and numbness and paresthesia in the feet, that is known as burning feet syndrome. So pantothenic acid deficiency causes burning feet syndrome. Pyridoxine deficiency, pyridoxine, vitamin B6 pyridoxine, the RDA is 2 milligram. And pyridoxine, the important coenzyme form is pyridoxal phosphate, which is required for the decarboxylation reaction. Remember, it is required for the decarboxylation reaction and synthesis of neurotransmitter synthesis. Pyridoxine is required. Apart from this, pyridoxine, it is important cofactor or coenzyme for the ALA synthase, which is first step in the heme synthesis. So pyridoxine deficiency causes anemia and neurological manifestation. So it causes, pyridoxine deficiency causes anemia and neurological manifestation. Anemia and neurological manifestation is there in the pyridoxine deficiency. Now folic acid deficiency and the B12 deficiency both causes megaloblastic anemia, because B12 deficiency causes folate deficiency, that is known as functional folate trap. So in both the deficiency, folate deficiency and B12 deficiency, megaloblastic anemia is there. Megaloblastic anemia with increased excretion of Figlu in the urine, it is a classical feature of the folate deficiency. See, megaloblastic anemia with increased excretion of the Figlu in the urine, it is a feature of this folate deficiency. So this is megaloblastic anemia, it is mainly because of the folate deficiency. And the cobalamin, that is B12 deficiency, it causes megaloblastic anemia, and it also causes the defect in myelin synthesis, defect in myelin sheath, that causes the subacute combined degeneration of the spinal cord. And there is increased methylmalonic acid excretion in the urine. Now coming to the RDA and particular sources. See, vitamin A. So just quick revise this RDA. This is according to the guideline given by the ICMR and MOHFW in their updated summary in December 2024. According to the RDA given by the ICMR, MOHFW, it is given by the NIN, National Institute of Nutrition. The vitamin A, RDA for the vitamin A, it is men, women, pregnancy, lactation. It is 1000 microgram in men. It is 840 microgram in female. In pregnancy, it is 900 microgram. In lactation, it is 950 microgram. Vitamin A requirement, RDA of vitamin A. It is there in the fish oils. It is there in the cod liver oil, halibut liver oil. And it is there in the beta carotene form. It is there in the green leafy vegetable and orange color fruits. Mainly it is there in the carrots, papaya, mango. Vitamin A is there. Vitamin D, the RDA of vitamin D, it is for all ages, it is 600 international unit. It is 600 international unit per day. Below the age of 1 year, it is 400 international unit. Vitamin E requirement, it is 7.5 to 10 milligram per day. And vitamin K, it is 55 microgram. It is 55 microgram vitamin K, RDA of vitamin K. Yes, it is necessary to remember the RDA specifically in case of vitamin A, vitamin D, then vitamin B12 and the folic acid. Okay. Then remember, so B1 that is thiamine, B2 that is riboflavin, B3 that is niacin, B5 that is pantothenic acid, B6 pyridoxine, B7 biotin is there, B9 folic acid, B9 is folic acid, and B12 it is cobalamin. These are the B complex vitamin, and vitamin C is there. Okay, we'll discuss the important features also related with this enzyme. Vitamin B1, this is thiamine. and the coenzyme form of the vitamin B1 is thymine pyrophosphate. Coenzyme form is vitamin B1 is thymine pyrophosphate. Remember, thymine status of the body, it is checked by RBC transcriptolase activity. Vitamin B1 requirement is roughly, it is 1 to 2. It is B1, it is 1 to 2 milligram per day. It is 1 to 2 milligram per day. Then B2, it is riboflavin. It is riboflavin. The requirement, this is FMN, flavin mononucleotide, and FAD, flavin adenine dinucleotide. These are the coenzyme form. The requirement is 2 to 3 milligram per day. 2 to 3 milligram per day. RDA, it is per day also. It is mainly in the per day. Recommended daily allowance. Okay. B3, it is niacin. The coenzyme form of the B3 is NADP. NADP is there. NADP, niacin. So niacin requirement is 10 to 20 milligram per day. 10 to 20 milligram per day. B5, this is pantothenic acid. B5, this is pantothenic acid. The coenzyme form is coenzyme A. Also there it is there in the acyl carrier protein. Coenzyme A, acyl carrier protein, coenzyme A means pantothenic acid is there. The requirement is, remember, pantothenic acid 5, it is 5 milligram is the requirement. 5 milligram is requirement. B6, it is pyridoxine. Pyridoxine, the coenzyme form is pyridoxal phosphate. Pyridoxal phosphate, important vitamin for the transamination reaction, also important for the decarboxylation and synthesis of neurotransmitter. Also it is required for the first step of heme synthesis, ALA synthase reaction. Pyridoxal phosphate requirement is 2 milligram. Requirement is 2 milligram. Biotin, it is there in the enzyme that is known as biocytin or carboxyl biotin enzyme complex. It is biocytin. The requirement is 25 to 30 microgram. 25 to 30 microgram per day. Folic acid, it is men, women, pregnancy and lactation. The requirement, it is in the microgram. Folic acid requirement in men is 300 microgram, women it is 220 microgram, pregnancy it is 570. This is important. This is 570 microgram, and lactation it is 330 microgram. Remember, folic acid is supplemented during the ANC period. The deficiency of folic acid causes the neural tube defect, that is spina bifida and anencephaly. Vitamin B12 requirement, it is again men, women, pregnancy, lactation. Men it is 2.2 microgram, women it is 2.2 microgram, pregnancy it is 2.4 microgram, and lactation it is 3.2 microgram. So this is B12 requirement. Vitamin C requirement, it is in the case of men it is 80 milligram in case of the men. In case of the woman it is 65 milligram. In case of the pregnancy it is 80 milligram, and in case of the lactation it is 115 milligram per day. This is RDA. Remember the RDA. This is very, very important, specifically in case of the vitamin A. Remember the RDA in case of the vitamin A. This is very, very important. Vitamin A is there in the fish oils and the orange color, that is carrots, papaya, mango, it is there. Vitamin D, it is in the cholesterol rich food. On sun exposure there is conversion occur. Vitamin E, it is there in the vegetable oils. Vitamin K, it is there in the vegetables, and it is from the intestinal microflora. Vitamin K2 is there. Vitamin B1, it is present in outer alluron layer of the whole grains. From B2 to B7, the sources are meat, milk, egg, fish, green leafy vegetables, cereal, and pulses from B2 to B7. B9, folic acid is there in the green leafy vegetable. B12, it is there in the food of animal origin. And vitamin C, it is there in the Indian gooseberry, amla, amla and green leafy vegetable, and citrus fruits, orange, lemon, vitamin C is there. Orange, lemon, so vitamin C is there. Vitamin A deficiency causes the vision problem. अभी deficiencies discuss करते हैं एक chart में. See, vitamin A deficiency, the form which is important in the vision के लिए important है vitamin A, that is 11 cis retinal. This form is important in the vision. Vitamin A is stored in the ito cells of the liver, that is known as hepatic stellate cell, as retinal ester या retinal palmitate. It is stored as retinal ester. Retinal ester means retinal palmitate या retinal ester, retinal palmitate in ito cells of the liver. Ito cells of the liver, also known as hepatic stellate cell. Hepatic stellate cell. Stellate cells. Remember this point. Then vitamin A deficiency. Deficiency of vitamin A. Vitamin A deficiency causes vision impairment. It causes vision impairment. That includes vision impairment. That includes the night blindness. That includes That includes Bitot spot, conjunctival xerosis, Bitot spot, X1A, X1B. X2 is there, corneal involvement is there. That is corneal xerosis. X3A, X3B, that is the corneal ulcer, less than 1/3 of the cornea, more than 1/3 of the cornea, that is known as the involvement of the cornea, that is included in the X3. That is WHO grading of vision impairment in the vitamin A deficiency. Night blindness is the earliest manifestation. Night blindness, that is increase in the dark adaptation time, night blindness. Then Bitot spot and the conjunctival xerosis is there. Conjunctival xerosis का मतलब होता है dryness. Conjunctival xerosis and the Bitot spot, it is triangular. So this is eye, this is cornea. There is triangular white opaque spot opaque spot on the conjunctiva. This is known as Bitot spot. Then X2, it is corneal xerosis and X3, it is corneal ulceration. Ulcer less than 1/3, more than 1/3 of the cornea, AB. And then the scarring is there, corneal scarring is there, and xerophthalmic fundus is there. This is WHO grading of vision impairment in the vitamin A deficiency. Apart from the vision impairment, vitamin A deficiency also causes phrinoderma. This is multi-nutrient deficient condition, mainly in the patient with malnutrition or patient on parenteral nutrition suffered with the phrinoderma, that is known as toad-like skin. It is there in the essential fatty acid deficiency, also in the vitamin A deficiency. The hyperkeratinization of the skin and the toad-like appearance of the skin is there. Acanthosis and hyperkeratinization of the skin, increased skin thickness is there in the phrinoderma. Toad-like skin is there. So this is vision impairment in the vitamin A deficiency. Vitamin A toxicity of vitamin A, acute toxicity of vitamin A causes the increased intracranial tension, that is known as pseudotumor cerebri. So this is raised ICT. Vitamin A damages the lysosomes. It is hepatotoxic, damages the liver, hepatotoxic. It causes hyperlipidemia, increases the lipid level, hyperlipidemia. It is teratogenic vitamin. It causes the frequent fractures in the bone. Bony exostosis is there. Pseudotumor cerebri, lysosomal damage, hepatotoxic vitamin, hyperlipidemia, and it causes the bone fractures. So these are the toxic manifestation of vitamin A. So this is important information related with the vitamin A. Now in short, we'll discuss the other vitamins. See, vitamin D deficiency. Deficiency of vitamin D causes the rickets in the child. You should able to differentiate between the rickets and the other types of rickets also. So there are various types of rickets: nutritional ricket, vitamin D dependent ricket type 1, type 2, then X-linked hypophosphatemic ricket, that is and the autosomal dominant hypophosphatemic ricket is there, and also there is renal ricket. These are the different types of ricket. You should able to diagnose these different types of rickets. Remember the nutritional ricket. Mainly in the nutritional ricket there is calcium level low or normal. Remember phosphorus levels are low. The 25 hydroxy cholecalciferol cholecalciferol levels decreases, calciferol level decreases. Then there is hyperparathyroidism, PTH, because of the low calcium level, PTH level increases, and which try to maintain the serum calcium level. That's why you may get the serum calcium level normal. So normal or low calcium level, phosphorus levels are low, 25 hydroxy cholecalciferol level decreases, PTH levels are high, alkaline phosphatase levels are high. This is nutritional ricket. Remember, this is nutritional ricket. Vitamin D deficiency causes the rickets in the children and osteomalacia in the adults. So A, D. Vitamin E deficiency, vitamin E deficiency causes decrease in the vitamin E. Vitamin E, it is antioxidant vitamin. Decrease in the vitamin E damages the RBC membrane. So it damages the RBC membrane, also damages the neuronal membrane. RBC and neuronal membrane damage is there if there is loss in the antioxidant property of vitamin E, that is alpha tocopherol. They damages the membrane because of the antioxidant property decreases, and damage to the membrane occur. RBC hemolysis is there, and the neuronal membrane is damaged, that causes damage to the neuronal membrane, that causes the neuropathy. There is areflexia, neuropathy. This is because of axonal degeneration of large myelinated neurons. So vitamin E deficiency causes axonal degeneration of large myelinated neuron. Also it causes the hemolysis of the RBC. Vitamin K deficiency causes the bleeding. Vitamin K, deficiency causes the bleeding tendencies. It causes bleeding in the newborns, specifically newborns. They are prone for the bleeding tendencies because of the immature liver and the immature intestinal system. Vitamin K deficiency causes bleeding in the newborn. There is increased prothrombin time, bleeding time increases in vitamin K deficiency. Vitamin K, it is required for post translational gamma carboxylation of clotting factor. Post translational gamma carboxylation of clotting factor, vitamin K is required. So remember, vitamin A, D, E, K, vision impairment and phrinoderma in vitamin A deficiency. Vitamin A excess causes raised intracranial tension, that is known as pseudotumor cerebri. Vitamin D deficiency causes rickets in the children, osteomalacia in the adult. Then vitamin E deficiency causes axonal degeneration of large myelinated neurons. Neurological symptoms are there, and hemolysis is there because of loss of antioxidant function, which is there in the alpha tocopherol, which is because of the 6-hydroxychromin ring in the alpha tocopherol structure. Vitamin K, K1, K2 and K3, three forms are there. Vitamin K is required for the post-translational gamma carboxylation of the clotting factor. If vitamin K deficiency is there, clotting factors, they are affected, and there is bleeding tendency in the newborn. Particularly in the newborn, because of the sterile intestine and immature hepatic system and poor placental transfer of vitamin K. Then the water soluble vitamins, it includes vitamin B1. Vitamin B1 deficiency, the thiamine deficiency causes beriberi, that is dry beriberi, wet beriberi and infantile beriberi. These are the three types of beriberi. Also the vitamin B1 deficiency causes Wernicke-Korsakoff syndrome. This is frequently asked question, Wernicke-Korsakoff syndrome. It is there in the malnutrition, chronic malnutrition, also there in the chronic alcoholic, because there is decreased activity of thiamine pyrophosphate. So Wernicke-Korsakoff syndrome, it is characterized by the symptoms, that is global confusion, ophthalmoplegia and ataxia, and memory loss and the psychosis. There is anterograde amnesia, also the retrograde amnesia is there, and confabulation is there. The patient feels the gap in the memory, the fabricated memory is there, that is known as confabulation. Confabulation. This is a feature of the Korsakoff psychosis, This is a chronic condition, Korsakoff psychosis. So thiamine is given before the glucose in the Wernicke-Korsakoff syndrome. Remember, global confusion, ophthalmology, ataxia, memory loss, psychosis. Confabulation is the characteristic of Wernicke-Korsakoff syndrome. It is there in the chronic alcoholic, also in the malnutrition. Chronic alcoholic also there in the malnutrition cases. Malnutrition cases it is seen. Chronic malnutrition cases, the thiamine deficiency. Vitamin B1 deficiency causes the Wernicke-Korsakoff syndrome. Thiamine deficiency causes beriberi, dry beriberi, that is neurological manifestation. Wet beriberi, the heart involvement is there. High output cardiac failure. Remember this word, high output cardiac failure is there. Cardiac failure, high output cardiac failure, and accumulation of fluid in the spaces, pericardial space, pleural space, there is accumulation of fluid occurs. So there is edema, there is high output cardiac failure, there is neuropathy in dry beriberi. Infantile beriberi, when the involvement is less than 1 year, there is CVS involvement, that is known as beriberi. So that is vitamin B1 deficiency. Vitamin B1 status of the body, it is checked by RBC transketolase activity. So it is status of the body, it is checked by RBC transketolase activity. Then B2 deficiency causes ariboflavinosis, that is chillosis, glossitis, angular stomatitis, seborrheic dermatitis, conjunctivitis, that is pink eye, circumoral and circumcorneal manifestations are there in the B2 deficiency. Vitamin B3 deficiency, niacin deficiency causes pellagra. B3 deficiency causes pellagra. Classical 3Ds, diarrhea, dementia, and dermatitis. This dermatitis, it is typically sun exposed part of the body. Sun exposed part of the body. Sun exposed part of the body that give glow and stalking appearance of hand and feet. Also there is Castle's necklace dermatitis, that is known as Castle's necklace shaped dermatitis. This is niacin, it is related with, it is 60 milligram of tryptophan will give you 1 milligram of niacin, 1 milligram of niacin. So this is very, very important. The disorder, for example, heart nerves disease or the B6 deficiency, the disorder which affect the tryptophan to NAD conversion also causes the these symptoms, the pellagra like symptoms. So B3 deficiency causes the pellagra. Vitamin B5 deficiency causes the burning fit syndrome. Vitamin B5 deficiency causes burning fit syndrome. Vitamin B6 deficiency, pyridoxal phosphate, it causes anemia and neurological manifestation because of the affected neurotransmitter. Neuropathy, neurological symptoms, mainly neuropathy, because it is required for the transamination reaction. It is required for the decarboxylation and synthesis of neurotransmitter. Vitamin B6 is required. So deficiency causes anemia and neurological manifestation. The vitamin B7, pyridoxal phosphate B6 deficiency is also common in the INH therapy. When isoniazid it is given in the treatment, it causes the vitamin B6 deficiency. Biotin deficiency is there in the when there is consumption of excessive amount of raw egg. Avidin is there in the raw egg. So avidin combined with the biotin and makes the biotin unavailable for the absorption. So biotin deficiency causes the rash, anemia, hallucination, depression like symptoms, but it is very rare because it is widely present in the foodstuff. Biotin B7 deficiency. B7 biotin. Vitamin B12 and folic acid. Remember these two, vitamin B12 and folic acid. See, vitamin B12, cobalamin, and the folic acid is there. Folic acid deficiency causes megaloblastic anemia because it is required for the DNA, nucleotide synthesis, DNA and RNA synthesis. Folic acid is required. So folic acid deficiency causes megaloblastic anemia. Megaloblastic anemia is there in the deficiency of B12 also, megaloblastic anemia, because these are connected with one reaction. I will discuss that reaction. See, this is homocysteine. This homocysteine, it is converted into methionine. Homocysteine is converted into methionine. This is with the help of vitamin B12 dependent reaction. The name of enzyme is methionine synthase. If there is deficiency of vitamin B12, this is B12 dependent reaction, methionine synthase, B12 dependent enzyme. And this catalyzes, in this reaction, there is conversion of methyl tetrahydrofolate tetrahydrofolate is converted into tetrahydrofolate. So this is only use of this methyl tetrahydrofolate. It is required for this methionine synthase reaction. This is B12 dependent reaction. This is only use of this reaction, methyl tetrahydrofolate. There is no other use of this methyl tetrahydrofolate. If there is block or if there is deficiency of B12, if there is deficiency of B12, this reaction get blocked, and there is accumulated methyl tetrahydrofolate level increases. Methyl tetrahydrofolate level increases, and there is no other use of this methyl tetrahydrofolate. Though the tetrahydrofolate is present in the methyl form, but it is unavailable for the other reaction, क्योंकि इसका दूसरा कुछ काम नहीं है. So this reaction is known as folate trap. This is known as folate trap. So in B12 deficiency, folate deficiency is also there. In the B12 deficiency, folate deficiency is also there. As the folic acid, it is required for the C2 and C8 of the purine synthesis, purine nucleotide synthesis. Also it is required for the deoxy TMP synthesis. Two important nucleotides, means purine nucleotides and the pyrimidine nucleotide synthesis. This is required folic acid. So it affects the DNA synthesis. So there is megaloblastic anemia. So DNA synthesis is affected DNA synthesis, and it results in the increased cytoplasm, means cell grows without a cell division. There is increase in the cytoplasm occurs and decreased size of nucleus occurs. That is known as megaloblastic anemia in the folate deficiency. As B12 deficiency also causes folate deficiency, in B12 deficiency megaloblastic anemia is also there. But in B12 deficiency, remember one important feature in the B12 deficiency, along with the megaloblastic anemia, there is increased level of methylmalonic acid, methylmalonate or methylmalonic acid. It levels increased in the blood and urine. Methylmalonic acid level increase in the urine, and there is neurological symptoms in this disorder. Neurological symptoms, that is in the form of subacute combined degeneration of spinal cord. Subacute degeneration of spinal cord. This is mainly because of the affected level of the myelin, degeneration of spinal cord. So this may present as the positive Romberg sign. Positive means loss of vibration position sense is there. So this may be present as the positive Romberg sign in the vitamin B12 deficiency. So megaloblastic anemia, increased methylmalonic acid level, and neurological manifestation, that is subacute combined degeneration of spinal cord, is there in the B12 deficiency. Folate deficiency, there is megaloblastic anemia, and on histidine load test there is excretion of farm-aminoglutamic acid in the urine in the folic acid deficiency. In the folic acid deficiency, there is excretion of on histidine load test there is excretion of FIGLU in the urine. Remember, folic acid, there is excretion of FIGLU in the urine. In the B12, there is methylmalonic acid excretion in the urine. So this is in short discussion of the vitamins and related deficiency. Now minerals. So there are two categories of the mineral: major elements. When the requirement is more than 100 milligram per day, these minerals are known as the major elements. So there are two categories in the minerals. One is major elements, second is the minor elements. So major elements. When the requirement is, when the requirement is more than 100 milligram per day, it is known as major elements. When the requirement is less than 100 milligram per day, it is known as trace element. या तो minor element. Trace elements या तो minor elements बोलते हैं, minor elements. So major elements includes calcium, phosphorus, sulfur, sodium, potassium, chloride. क्या बचा? Calcium, phosphorus, sulfur, magnesium, sodium, potassium, chloride. These are the major elements. Requirement is more than 100 milligram per day. Trace element, it includes iron, selenium, zinc, copper, molybdenum, chromium, then cobalt. Like these are the iodine, fluoride. These are known as the trace elements. These are known as trace elements. Okay, so we'll discuss the deficiency manifestation. Calcium deficiency, when it is below 7 milligram per deciliter, it causes hypocalcemia. The features of hypocalcemia, that is convulsion, arrhythmia, tetany, spasms, stridor, tremors. These are the features of hypocalcemia. So calcium deficiency causes carpopedal spasm, that is known as tetany. Carpopedal spasm, that is known as tetany. Calcium deficiency causes carpopedal spasm when the level goes below 6 or below 7 milligram per deciliter. It causes the tetany, that is known as carpopedal spasm. The requirement of calcium is 1000 milligram per day for men, women and the pregnancy. 1000 milligram per day. Iron, it is important trace element. Iron deficiency causes microcytic hypochromic anemia. Iron deficiency causes microcytic hypochromic anemia. Then zinc deficiency. Zinc is responsible for number of number of functions in our body. That is, zinc is important for the more than 300 enzymes. For example, superoxide dismutase, carbonic anhydrase, RNA polymerase, then various dehydrogenase, then ALA dehydratase. Zinc is required. So zinc deficiency causes lot of manifestation. For example, मैं बता दूं, just wait. So zinc deficiency causes acrodermatitis enteropathica. Copper deficiency causes the Menkes disease, and excess causes Wilson's disease. Selenium deficiency causes Cation disease, that is cardiomyopathy, Cation disease. Iodine deficiency causes goiter. And the fluoride deficiency causes dental caries. So dental caries is there in the fluoride deficiency. Excess causes dental and skeletal fluorosis. Now remember these three. Just wait. See, the niacin deficiency. Niacin is the vitamin B3. Niacin deficiency causes diarrhea, dementia, dermatitis. The zinc deficiency causes diarrhea, alopecia, dermatitis, delayed wound healing, and decreased immunity. Also decreases the vitamin A level in the serum. Also causes loss of taste sensation. Also responsible for the sterility. Zinc deficiency. Then the biotin deficiency is also there. Biotin deficiency causes the mild hemolysis. Is there. Hemolysis. There is dermatitis, that is rash. Dermatitis is there. Hallucination, depression is there. Hallucination, depression is there. Also there is alopecia. See, dermatitis is there, alopecia is there, but it is typically common in the person consuming, the bodybuilder. जो bodybuilder है, जो रॉ एक कंज्यूम करते हैं जिसमें एविडिन रहता है, वो कंबाइन होता है बायोटिन के साथ. इट मेक्स द बायोटिन अनअवेलेबल. सो बायोटिन डिफिशियंसी कॉजेस ऑल्सो डर्मेटाइटिस, एलोपेशिया, बट इट इज माइल्ड लेवल बायोटिन डिफिशियंसी. जिंक डिफिशियंसी, it is diarrhea, alopecia. This is alopecia. This is dermatitis. So this dermatitis in the niacin deficiency, it is niacin deficiency. This dermatitis is photosensitive dermatitis. That is on the sun exposed part of the body. Remember this, sun exposed part of the body, that is known as Castle's necklace, glove and stocking appearance of hand and feet. While in the dermatitis, it is there, dermatitis in the zinc deficiency, it is periorificial. Remember this word, periorificial, around the opening. Periorificial dermatitis, around the opening. Anal area, the dermatitis, the anal area, perianal area, it is involved. The area around the mouth, toes, finger, nose, these are involved. Acral part of the body, it is particularly involved. That's why it is known as acro matlab acral part, distal part of the body. Acrodermatitis enteropathica, because of the decreased absorption of zinc from the intestine. Enteropathica, acrodermatitis enteropathica, because of the zinc deficiency. Remember the zinc deficiency manifestation: diarrhea, alopecia, dermatitis, that is periorificial dermatitis, delayed wound healing, loss of taste sensation. There is decreased immunity in the zinc deficiency, decreased vitamin A level. vitamin A level in serum. Decrease vitamin A level in the serum also can present as night blindness, because decrease, it is required for circulating level of maintaining the circulating level of the vitamin A. Zinc is required. So zinc deficiency causes loss of immunity. There is diarrhea, there is alopecia, there is dermatitis, that is periorifacial dermatitis. Remember, three Ds: diarrhea, dementia, dermatitis, that is photosensitive dermatitis in niacin deficiency. Remember, diarrhea, alopecia, delayed wound healing, and dermatitis, that is periorifacial dermatitis in the zinc deficiency. And in the biotin deficiency, it is rare. It causes mild hemolysis, it causes the rash, it causes hallucination, depression, it causes the alopecia also. This is when there is history of raw egg consumption history is there. The avidin which is present in the raw egg, it combines with the biotin and it makes the biotin unavailable for the absorption. Biotin is very, very important in the carboxylation reaction, biotin dependent carboxylation reaction. Okay, so it is pyruvate carboxylase, then propionyl coenzyme carboxylase, acetyl coenzyme carboxylase reaction, biotin is required. The carboxyl, biotin dependent carboxylation reaction, biotin is required. Okay, so see, calcium deficiency causes the tetany, that is carpopedal spasm. This is the typical position of hand in the carpopedal spasm. Iron deficiency causes microcytic hypochromic anemia. Zinc deficiency causes acrodermatitis enteropathica. Copper deficiency causes Menkes disease. Excess causes Wilson's disease. आगे हम इसको डिस्कस करने वाले हैं. Selenium deficiency causes the Cation disease, that is cardiomyopathy. When there is severe deficiency of selenium in the soil that affect the population, that causes the cardiomyopathy. Myopathy is there in the Cation disease. Cardiac involvement, cardiomyopathy is there in the Cation disease. The in search of the iodine, thyroid gland enlarges, that present as goiter in the iodine deficiency. Fluoride deficiency causes dental caries, while fluoride excess causes that is mottling of the enamel, the staining of the teeth, that is known as the dental fluorosis. When the level increases for prolonged duration of time, more than 4 milligram per liter, it causes the skeletal fluorosis, and more than 10, it causes the crippling disease. It causes the crippling disease. See, so fluoride when it is less than 0.5 milligram per liter, it causes dental caries. When the level is more than 1.5, it causes GIT disturbances. When it is more than 2, it causes dental fluorosis. That is mottling of the enamel, the staining of the teeth, the patches on the teeth, the dental fluorosis. When it is more than 4, actually it is 3 to 6 mentioned, but it is when it is more than 4, it causes skeletal fluorosis. And when the level is more than 10, more than 10 ppm or more than 10 milligram per liter, it causes crippling. Severe skeletal damage, crippling disease. It causes the crippling disease. This is fluorosis. It is fluoride. It is present in the drinking water. Then selenium, the important things related with the selenium. Selenium is there in the 3 important enzymes. First one is the glutathione peroxidase. Selenium is there, peroxidase. Then deiodinase and thioredoxin reductase. These are the 3 enzymes which require selenium as a cofactor. So this is antioxidant mineral. Antioxidant mineral includes it includes zinc, copper, selenium and the manganese. This zinc and copper, it is related with cytosolic superoxide dismutase. This is related with the mitochondrial superoxide dismutase, and this is related with the glutathione peroxidase. peroxidase, glutathione peroxidase, selenium. So these are the antioxidant minerals, okay. Antioxidant vitamin कौन से? Vitamin A, that is beta carotene form, then alpha tocopherol, and vitamin C, that is ascorbic acid, antioxidant vitamin. So see, in short revision, so iron deficiency causes microcytic hypochromic anemia. Iron deficiency, iron is one way element, it is absorbed through the intestine via the divalent metal ion transporter, and it is exported out of the cell via the ferroportin. Hepcidin regulate the iron level. Zinc is important for the immunity, zinc is important for the taste sensation, zinc is important for the many enzymes. For example, metalloproteinase, the carbonic anhydrase, then superoxide dismutase, RNA polymerase, so it is required for the protein synthesis, RNA polymerase, then the various dehydrogenase, zinc is required. Copper is required for the various enzyme, for example, the various cytochromes, ALA synthase, ceruloplasmin, the lysyl oxidase, copper is required. Selenium is required for the glutathione peroxidase, then thyroidoxin reductase and deiodinase. Iodine is important for the synthesis of T3 and T4. So it is important for the metabolism, mainly to increase the glucose level, to utilize the lipid. For the T3 T4, it increases the basal metabolic rate. It is important for the mental development. Iodine deficiency in the pregnancy for the chronic duration of time causes cretinism in the child, and fluoride deficiency causes dental caries, and the excess causes the fluorosis, that is dental and skeletal fluorosis. So these are these are the important topics or important points related with the minerals. Okay. RDA बचा है, RDA बता दूं क्या? Just wait, RDA रिवाइज करते हैं. RDA, see, RDA in case of the mineral, calcium RDA, it is 1000 milligram for men, women and pregnancy, and 1200 it is there in the lactation. Men, women and pregnancy, it is 1000 milligram per day. This is in the milligram calcium. Phosphorus, it is 600 milligram per day. Phosphorus 600 milligram per day. Then sodium, potassium, chloride. Sodium requirement is 2 gram. Potassium requirement is 3.5 gram. It is there in the banana and the tender coconut. Chloride requirement, it is 2 gram. Along with the sodium, it is 2 gram. Sodium requirement, chloride requirement, it is 2 gram. Sodium requirement 2 gram, chloride requirement 2 gram. Phosphorus 600 gram. Then magnesium requirement, it is magnesium requirement, it is near about 370 in case of the women, and 430 in case of the men. This is milligram, magnesium requirement in the milligram. This is for the major elements. When the RDA is more than 1000 milligram per day, they are known as the major elements. Now minor elements, it includes minor elements, iron, mainly iron. It is men, women, pregnancy and lactation. It is 19 milligram in men. It is 29 milligram in the menstruating woman. Pregnancy, it is 27 milligram, and lactation, it is 23 milligram per day. 23 milligram per day. Zinc, it is 10 to 20 milligram. Actually 10 to 12 milligram per day. Copper, it is 1.7 milligram per day. Then the selenium, molybdenum, then chromium, and iodine. These are the elements. These are known as the ultra trace element, also known as ultra trace element. The selenium requirement is 40 microgram. It is 45 microgram. This is chromium, it is 50 microgram. Iodine, it is 140 microgram. In pregnancy, it is 220 microgram. Iodine requirement is 220 microgram in the pregnancy. So this is requirement. This is requirement of the major elements and the minor elements. So remember, calcium deficiency causes the tetany. Then the iron deficiency causes microcytic hypochromic anemia. Zinc deficiency causes diarrhea, alopecia, dermatitis, delayed wound healing. Copper deficiency causes Menkes disease, also causes the anemia. Selenium deficiency causes cardiomyopathy, that is Cation disease. Molybdenum is related with the xanthine oxidase enzyme. Chromium, it is known as glucose tolerance factor. It potentiates the action of insulin. Chromium. Iodine, it is required for the synthesis of T3 and T4. Iodine is required for the synthesis of T3 and T4. So this is in short discussion about the vitamins and minerals. Now coming to the ABC transporter proteins. ABC transporter proteins, these are the ABC transporter. These are the types of the primary active transport. Primary active transport, ABC transporter. ABC transporter. Now see ABCA1. ABCA1, it is required for transport of cholesterol. It is required for transport of cholesterol from peripheral tissues to the HDL core. Peripheral tissues to the HDL core. It is important. This is peripheral tissue where cholesterol is there. With the help of various transporter, that is ABCA1, ABCG1 and SRB1, scavenger receptor B1, cholesterol is transported out of cell and it moves to the HDL, discoidal HDL. It moves to the discoidal HDL, and with the help of lecithin cholesterol acyl transferase, the esterification of cholesterol occurs. So this is ABCA1. It is important for transport of cholesterol from tissue to the HDL. The defect in this ABCA1 protein, the mutation causes the Tangiers disease. Remember, mutation causes the Tangiers disease. So it is important. Alpha lipoprotein deficiency, where HDL is 0 to low. There is mutation in ABCA1 protein, and there is the yellow orange color tonsil is there in the Tangiers disease. There is hepatosplenomegaly, neuropathy and yellow orange tonsil in the Tangiers disease. Transport of cholesterol from tissue, peripheral tissues to the HDL makes the HDL spherical. ABCC2 means ATP binding cassette transporter C2, or multidrug resistant like protein 2 or multispecific organic anion transporter. This ABCC2, MRP2 or MOAT, it is required for the active secretion of bilirubin into bile. Active secretion of bilirubin. It is required for active secretion of bilirubin into bile canaliculi. Mutation in this ABCC2 or MRP2 causes Dubin-Johnson syndrome. Dubin-Johnson syndrome. Mutation in ABCC2 or MRP2. Then ATP7A. Remember, Menkes, M comes first and the W comes second. So A and B mutation is there. So see, this is Menkes disease. ATP7A mutation there is there. ATP7B mutation is there in the Wilson's disease. So this is required for absorption of copper. From the intestine. Defect causes Menkes disease. This is neurodegenerative disorder characterized by steel or wiry hair because of the affected lysyl oxidase activity. ATP7B mutation, it is there in the Wilson's disease. This is also known as Wilson's disease, hepatolenticular degeneration. The ATP7B, it is required for incorporation of copper into a ceruloplasmin. Also, it is required for excretion of copper from the intestine into the bile. So, if deficiency of ATP7B mutation is there, the copper accumulates and it causes various symptoms. We'll discuss the Menkes and Wilson's disease later on also. CFTR, cystic fibrosis transmembrane regulator gene. The chloride transporter, it is a chloride transporter. The deficiency or the mutation causes the cystic fibrosis. रिसेंटली एक साउथ इंडियन मूवी आया इस पे द हाई पापा, उसको प्रोनाउंसिएशन नहीं आता है सिस्टिक फाइब्रोसिस का, तो वो बच्ची बोलती है सिस्टिक फाइब्रोसिस, उस पे वो मूवी है. सो शी गेट फ्रीक्वेंट इन्फेक्शन बिकॉज ऑफ द प्लगिंग ऑफ द वेरियस copious secretion, the mucus becomes thick. That's why the obstructive lung disease is there. This is known as cystic fibrosis. The recurrent infection is there, and sweat chloride level, it is increase in this cystic fibrosis. Chloride transporter is affected. एक Hollywood movie भी है इस पे, that is 5 feet apart. Then MDR, multi drug resistant like protein 1. This is required to pump the chemotherapeutic agent which is given in the cancer therapy to pump out this agent out of the cell. So it is responsible for the resistance of certain cancer drugs. You have to increase the dose of that particular drug. So it is MDR, multi-drug resistant protein 1. Okay, so ABCA1 mutation causes Tranger's disease, ABCC2 or MRP2 mutation Dubin-Johnson syndrome, ATP7A mutation Menkes disease, it is for the copper, ATP7B mutation causes the Wilson's disease, CFTR mutation causes the cystic fibrosis. So these are the different ABC transporter proteins and the related disorder and their functions. Then membrane markers. So markers, enzymatic marker for various subcellular organelles. This is required for the confirmation when we do the subcellular fractionation. We use the density gradient. Generally, sucrose density gradient is used for the fractionation, subcellular fractionation. And once they are fractionated, it is confirmed by measuring the enzyme levels and in that particular fraction. For the plasma, it is 5' nucleotidase, adenylyl cyclase, and sodium potassium ATPase. Endoplasmic reticulum, glucose 6-phosphatase is the marker. Inner mitochondrial membrane, ATP synthase is the marker. Golgi apparatus, galactosyl transferase. Cytoplasm, lactate dehydrogenase. Lysosome, cathepsin and acid phosphatase. Peroxisome, catalase is the marker. See, plasma membrane. It is plasma, not plasma, it is plasma membrane. Plasma membrane marker is 5' nucleotidase, adenylyl cyclase and sodium potassium ATPase. Then endoplasmic reticulum, glucose 6-phosphatase, inner mitochondrial membrane, ATP synthase, Golgi apparatus, galactosyl transferase, cytoplasm, lactate dehydrogenase, lysosome, it is cathepsin, also the acid phosphatase, and peroxisome, catalase is the marker. Marker enzyme for subcellular organelles. Now the metabolic pathway, the important metabolic pathway, their rate limiting enzyme and how they are regulated in our body. So important points, we'll discuss the important point. Fatty acid synthesis, important enzyme is acetyl coenzyme A carboxylase. It is regulated by CID. Remember, it is regulated by CID, citrate, insulin and the dephosphorylated state of the enzyme. Citrate, insulin and dephosphorylated state of the enzyme increases the activity of acetyl coenzyme A carboxylase. This is multifunctional enzyme, multi-enzyme complex. It is composed of E1 that is biotin carboxylase and E2 that is carboxyl transferase. Biotin is required for acetyl coenzyme A carboxylase activity and it is regulated by citrate. It is activated by citrate. Insulin favors the fatty acid synthesis, insulin and the dephosphorylated state of the insulin. Citrate, insulin and the dephosphorylated state of the enzyme. This acetyl coenzyme carboxylase is the active, it promotes the fatty acid synthesis. So fatty acid synthesis, acetyl coenzyme carboxylase is the rate limiting enzyme. Glycolysis, rate limiting enzyme is phosphofructokinase. This phosphofructokinase, it is activated by AMP, that is adenosine monophosphate, and fructose 2,6-bisphosphate. These are the activators of glycolysis. And citrate is a inhibitor here. Citrate and the ATP. These are the inhibitors. So it is inhibited by the citrate and ATP. Phosphofructokinase. This is a bottleneck in the glycolysis. These are activator. ये एक्टिवेटर्स है, रेड में नहीं तो इनिबिटर समझोगे, ठीक है. देन बीटा ऑक्सीडेशन ऑफ फैटी एसिड, द CAT1 कार्निटिन असाइल ट्रांसफरेज 1 इज द रेट लिमिटिंग एंजाइम. कीटोन बॉडी सिंथेसिस HMG कोएंजाइम ए सिंथेज. कोलेस्ट्रॉल सिंथेसिस HMG कोएंजाइम ए रिडक्टेज. ग्लाइकोजन सिंथेसिस ग्लाइकोजन सिंथेज. ग्लाइकोजन डिग्रेडेशन ग्लाइकोजन फॉस्फोराइलेज. रिमेंबर टू allosteric activators of this glycogen phosphorylase. One is direct activator, another one is the indirect activator. Direct activator is AMP in the muscle, low levels of AMP in the muscle. AMP in the muscle is the direct activator of glycogen phosphorylase, and indirect activator is calcium. Remember this is very important MCQ. Indirect activator is calcium via the various dependent calmodulin dependent kinases. This glycogen phosphorylase get activated. So direct activator is AMP, indirect activator is calcium, glycogen phosphorylase. TAG degradation in adipose tissue, hormone sensitive lipase is the important enzyme. Hormone sensitive lipase, it is stimulated by glucagon and epinephrine. glucagon, epinephrine in the fasting condition. In the fasting condition, this is stimulated, while insulin inhibit this. Insulin inhibit this hormone sensitive lipase. So in the well-fed state, this is in the inactive mode, while in the fasting state, under the presence of glucagon and epinephrine, this is activated. So TG lipolysis is there in the fasting condition. Heme synthesis, rate limiting enzyme is ALA synthase, which is pyridoxal phosphate dependent. PLP dependent, PLP is the coenzyme. Urea cycle, the rate limiting enzyme is carbamyl phosphate synthetase 1. The N-acetyl glutamate act as a activator, allosteric activator of CPS1. The purine nucleotide synthesis main enzyme is PRPP glutamyl amidotransferase. So PRPP glutamyl amidotransferase is the rate limiting enzyme of purine nucleotide synthesis. So these are the rate limiting enzyme. The important one is the acetyl coenzyme carboxylase, phosphofructokinase, then glycogen degradation, that is the glycogen phosphorylase is important. Glycogen phosphorylase is important. Hormone sensitive lipase TG degradation in adipose tissue is important. So these are the important enzymes, rate limiting enzymes for this important pathways. Now energetics, remember two pathways जिसमें zero ATP production होता है. One is Rappaport lubering cycle जिसमें 2,3 bisphosphoglycerate generate होता है. 2,3 bisphosphoglycerate generate होता है. और दूसरा HMP shunt, hexose monophosphate shunt, HMP shunt and the Rappaport lubering cycle. HMP shunt pathway, hexose monophosphate shunt and RL cycle. The ATP synthesis is zero ATP production. ये दोनों पाथवे का क्या सिग्निफिकेंस है? HMP shunt is related with production of NADPH and ribose. It is important for the production of NADPH and ribose. NADPH and ribose synthesis, HMP shunt is important, and RL cycle is important for the production of 2,3 bisphosphoglycerate. The ATP synthesis is zero in these two pathway, HMP shunt and the Rappaport lubering cycle. Anaerobic glycolysis, ATP production 2, aerobic glycolysis, ATP production 7. Complete oxidation of glucose, it is 32 ATPs they are produced. Oxidation of palmitic acid 106 ATP, oxidation of stearic acid, that is 18 carbon, 120 ATPs are there. Glycolysis in the cancer cell, that is anaerobic glycolysis, 2 ATPs are produced. So this is energetics of this important pathway. Remember energetics, RL cycle, HMP shunt, 0 ATP production. Now inborn errors, we'll discuss these inborn errors. आगे भी हम discuss करेंगे one by one. So this is the enzyme deficiency in this inborn error. You can get match the pair of type of question. Match the pair type of question on this inborn errors of metabolism and the enzyme defect. See the phenylketonuria. It is due to phenylalanine hydroxylase defect. Alkaptonuria, black urine on standing, and on the latter ages, means after the 30 year of the life, the tendency to develop arthritis because of deposition of alkaptone pigment. This is homogenticide oxidase defect, alkaptonuria. Albinism, tyrosinase is defective. The copper dependent enzyme tyrosinase is defective in the albinism. Homocystinuria, related with the methionine cysteine metabolism. Cystathionine beta synthase defect, pyridoxal phosphate dependent enzyme, cystathionine beta synthase. There is subluxation of lens, that is inward and towards the medial side. In Marfan syndrome, the subluxation is up and outward. In the homocystinuria, it is inward and towards the medial side. Downward and inward subluxation of lens occur in the homocystinuria. Maple syrup urine disease, it is branchane alpha ketoacid dehydrogenase defect. Primary hyperoxaluria, it is a protein targeting defect of alanine glyoxylate amino transferase. There is tendency of oxalate stone in primary hyperoxaluria. It is related with the glycine metabolism. Defect in protein targeting of alanine glyoxylate amino transferase. Galactosemia, there is hypoglycemia, there is congenital cataract, there is excretion of galactose in urine which can give the Benedict test positive. Blood sugar level, blood glucose levels are low. It is galactosemia. Galactose 1-phosphate uridyl transferase defect. Hereditary fructose intolerance typically manifest in the weaning period. Weaning period, when the adult food is given to the child, the food given mainly the fructose rich food, sucrose rich diet, fructose rich diet, when it is given, because of aldolase B defect, autosomal recessive disorder, if there is deficiency of aldolase B, there is hereditary fructose intolerance. Then essential pentosuria, it is xylitol dehydrogenase defect, mainly precisely it is xylulose reductase defect. There is excretion of pentose, xylulose excretion in the urine. Then drug induced hemolytic anemia, it is G6PD deficiency. Primaquine therapy or sulfonamide or dapsone therapy. This is a X-linked disorder, typically most commonly affect the males. When primaquine or the antibiotic therapy is given, because of the low activity of G6PD, glucose 6 phosphate dehydrogenase enzyme, the NADPH production is decreases, and when the oxidant drugs are given, it may manifest as drug induced hemolytic anemia, that is G6PD deficiency. Lactose intolerance because of the congenital lactase deficiency. Leishman syndrome, there is self-mutilating activity, biting of the finger nails, the lip biting is there, head banging is there, chorioathetosis is there, the abnormal movements, jerky movements are there in the Leishman syndrome. HGPR is hypoxanthine guanine phosphoribosyl transferase defect. And the orotic aciduria, there is orotate acid, orotate crystals in the urine. Also the megaloblastic anemia is there. There is decreased pyrimidine nucleotide synthesis in the orotic aciduria. It is because of the UMP synthase defect. This is the UMP, uridine monophosphate synthase defect. This is bifunctional enzyme composed of two enzymes, that is OPRtase, OMP decarboxylase, and OPRtase and OMP decarboxylase. There is excretion of orotate in the urine. The enzyme defect is UMP synthase. तो जितने भी एंजाइम डिफेक्ट्स है और इनबॉर्न एरर्स है, जैसे कि ग्लाइकोजन स्टोरेज डिसऑर्डर, लाइसोसोमल स्टोरेज डिसऑर्डर, म्यूकोपॉलीसैकेराइडोसिस, हाइपरलाइपोप्रोटीनेमिया, इनबॉर्न एरर्स ऑफ प्रोटीन मेटाबॉलिज्म, इनबॉर्न एरर्स ऑफ कार्बोहाइड्रेट, प्रोटीन, लिपिड, न्यूक्लियोटाइड मेटाबॉलिज्म, जितने भी डिसऑर्डर्स है एटलीस्ट उनके एंजाइम डेफिशिएंसी करो. मैच द पेयर टाइप या मल्टीपल करेक्ट ऑप्शन में आपको ये आ सकते हैं. सो जितने भी डिसऑर्डर्स है, जितने भी आपको दिखते हैं, जितने भी कॉमनली पूछे जाते हैं, वो सारे डिसऑर्डर में एंजाइम डेफिशिएंसी, एटलीस्ट एंजाइम डेफिशिएंसी सारे करके रखो. सो दीज आर द सम इंपॉर्टेंट डिसऑर्डर्स एंड दीज आर द एंजाइम डेफिशिएंसीज. Now see, this graph can be a IBQ type question. See, here it is solute concentration. This is maximum rate, maximum rate of transport, maximum rate of the transport. Two lines are there. One is green line, one is the red line. There can be a question on interpretation of red line or interpretation of the green line. So kinetics of carrier mediated diffusion with passive diffusion. In passive diffusion, there is no transporter required, no carrier protein is needed. So in this is directly proportional. So this is directly proportional, directly related. So that's why there is straight line in the passive diffusion, while in the carrier mediated transport, that is facilitated diffusion and the active transport, ये दोनों जो मैकेनिज्म है, ये दोनों एंजाइम सैचुरेशन जैसा काइनेटिक दिखाते हैं. दैट इज कैरियर मेडेड बिकॉज देर इज कैपेसिटी ऑफ दिस प्रोटीन टू ट्रांसपोर्ट particular amount of solute. That's why it shows the saturation kinetic. Saturation kinetic, it is shown by the carrier mediated diffusion, mainly facilitated diffusion, or the active transport, whether it is primary active or secondary active transport. While in the passive diffusion, it is directly, there is no saturation, though there is no protein, carrier protein involved in the transport. This is a give the interpretation of green line, give the interpretation of red line. This type of question, IBQ type question, can be there in the examination. So these are well known graphs. All of you know the X shape, V shape and the parallel line. X shape, V shape, parallel line. Remember, when it is X shape graph, it is competitive inhibition. When it is X shape graph, it is competitive inhibition. In the competitive inhibition, this is reversible type of inhibition. In competitive inhibition, Km, remember what is Km? Km is the substrate concentration to produce half of the maximum velocity. To produce half of the maximum velocity, half of the Vmax, to produce half of the Vmax. Km means. So this type of inhibition, this is a reversible inhibition. This type of inhibition can be overcome by increasing the substrate concentration. So in this type of inhibition, in the competitive inhibition, you will get X-shaped graph. In this, in the competitive inhibition, Km value increases, Km increases, and Vmax remains same. Vmax remains same. Km increases, Vmax remain same. Competitive inhibition. In the non-competitive inhibition, this is irreversible type of inhibition. Increasing the substrate concentration cannot overcome this type of inhibition. So this does not affect the enzyme substrate binding. This type of inhibition, it shows the V-shaped graph. This is known as non-competitive inhibition. For example, fluoride ion inhibit the enolase activity by the non-competitive irreversible inhibition. In this type of inhibition, Km remains same. Km remains same. See the Km value. Km remains same. This is the Km value. This is -1 by Km. Km remains same. And Vmax, remember maximum velocity, either it remains same or it get lowered. There is nothing like increase in the Vmax. So Vmax get lowered. Vmax get lowered in the non-competitive inhibition. Then third type is the uncompetitive inhibition. In the uncompetitive inhibition, you will get parallel line. Uncompetitive. In the uncompetitive inhibition, the example is phenylalanine, high level of phenylalanine. Phenylalanine inhibit the placental alkaline phosphatase. Placental alkaline phosphatase. This is the example of uncompetitive inhibition. The inhibitor binds to enzyme substrate complex, and it decreases both. Decrease in the Km value and decrease in the Vmax is there. Vmax is there. So there is parallel lines in the uncompetitive inhibition. So competitive X-shaped graph, non-competitive V-shaped graph, and the uncompetitive, it is parallel lines. Uncompetitive, it is parallel line. Identify the drug Z given in the image. Identify the drug Z which inhibit the vitamin K reductase, that is vitamin K epoxide reductase. Vitamin K epoxide reductase, it is inhibited by oral anticoagulant warfarin and the dicumarol. It is warfarin and dicumarol. These are oral anticoagulant drug. Oral anticoagulant drug. This is overlapping topic. Coagulant drug. Oral anticoagulant drug. It inhibits the vitamin K epoxide reductase. Now see vitamin K activity. Vitamin K is required for, this is vitamin K activity. Reduced form of the vitamin K. It is required for vitamin K. It is required for carboxylation. It is required for the post-translational gamma carboxylation of clotting factor 2, 7, 9 and 10. Clotting factor 2, 7, 9 and 10 activation vitamin K is required. Also activation of osteocalcin, then protein C and protein S. This is required. The vitamin K is required. So this reduced vitamin K is converted into oxidized vitamin K. Oxidized vitamin K is again converted into reduced vitamin K with the help of vitamin K epoxide reductase enzyme. This is inhibited by the warfarin and dicumarol. These are the competitive inhibitors of this vitamin K epoxide reductase. Vitamin K epoxide reductase, warfarin or dicumarol. Warfarin or dicumarol. Now see which drug is used in the treatment of gout as a drug of choice. Gout. The first metatarsophalangeal joint is commonly involved in the gout. The treatment of choice is allopurinol. Allopurinol is a drug which acts by two mechanisms. One is competitive inhibition. And second one is the suicide inhibition, that is also known as mechanism based inactivation. Competitive inhibition and the suicide inhibition. This is uric acid. Because of the uric acid, this is overproduced. So this is by the reaction, see nucleotide degradation. So adenosine monophosphate, inosine monophosphate and guanosine monophosphates, they are degraded into hypoxanthine, and this hypoxanthine is converted into xanthine, and xanthine is converted into uric acid. This is how uric acid is synthesized by the enzyme xanthine oxidase. Xanthine oxidase is required here. Xanthine oxidase is the enzyme required here, also required here. Okay, so this is a allopurinol. It is structural similarity with hypoxanthine. It is a competitive. It is it is a competitive inhibitor of xanthine oxidase, first mechanism. Second, this xanthine oxidase converts this allopurinol into alloxanthine, convert it into alloxanthine, and this alloxanthine is the suicide inhibitor. It is a more potent inhibitor. It is a more potent inhibitor of xanthine oxidase. This is conversion is done by enzyme itself. Enzyme खुद इसको convert करता है and convert this drug into more potent form which inhibit the irreversibly inhibit the this xanthine oxidase enzyme. That's why it is known as suicide inhibitor. So the drug which is used in the gout, it is the allopurinol. Now remember, first metatarsophalangeal joint is involved, and the diagnostic test, the gold standard test, the diagnostic test is microscopy. Aspiration of the monosodium urate crystal, and microscopy, that is polarized microscopy. You will see the needle shaped crystal, negatively birefringent needle shaped crystals of urate is seen in the under the microscope. So this is aspiration of the synovial fluid, and microscopy is a gold standard test for the diagnosis of the gout. Aspiration of synovial fluid and microscopy, negatively birefringent urate crystals are seen in the microscope in the gout, in the synovial fluid microscopy. Identify the enzyme X targeted by allopurinol in the picture given below. Here enzyme is xanthine oxidase. Enzyme is xanthine oxidase. Competitive inhibition as well as suicide inhibition. Match the pair. The competitive inhibitors are mentioned here, and these are the enzymes. Xanthine oxidase, it is inhibited by allopurinol. Then dihydrofolate reductase, it is inhibited by anti-cancer agent, that is methotrexate. It is inhibited by methotrexate. Vitamin K epoxide reductase, it is inhibited by dicumarol and warfarin. HMG coenzyme reductase, it is inhibited by the statin group of drug. Lovastatin, simvastatin, atorvastatin, rosuvastatin. These are the statins which inhibit the HMG coenzyme reductase activity. Hydroxymethylglutaryl coenzyme reductase activity. So these are the competitive inhibitors, and these are the enzymes. Competitive inhibitors with their enzymes. Identify the Vacutainers and write its use. ये हमने just discuss किया पहले ही slide में. This is a plain tube, red tube. It is a plain tube, plain Vacutainer. This is a plain Vacutainer. It is used in the biochemistry. This is a plain Vacutainer, plain tube Vacutainer. It is in biochemistry, serum parameter, serum biochemistry, LFT, liver function test, kidney function test, that is urea creatinine, electrolyte estimation. This tube, red tube, or alternatively yellow cap tube or golden cap tube can be used. This is EDTA tube, purple tube. EDTA tube, mainly it is used for the CBC analysis. Also it is used for HbA1c estimation, HbA1c glycated hemoglobin estimation. This is a gray cap tube. It is having the fluoride, that is, it is known as fluoride bulb. It is for the glucose estimation. Fluoride ion inhibit the enzyme enolase of glycolysis and maintain the glucose level in the collected sample. So these are the Vacutainers, commonly used Vacutainers. Now just wait 5 minutes. 5 minutes नहीं 2 minutes, 2 minutes wait करो. Welcome to a FMG Marathon series.
Just wait. Hi, Micro World. Hi, everyone. See, these are the glucose transporters. First 5 याद रखो, पहले 5 याद रखो. GLUT1, GLUT2, GLUT3, GLUT4 and GLUT5. ये 5 याद रखो. Also GLUT7. ओके, ये इंपॉर्टेंट है. बाकी इतने इंपॉर्टेंट नहीं है जितने की ये पहले 4-5 है. GLUT1, it is widely distributed. It is there in the there is mnemonic Kohli plays for RCB. Now see, kidney, placenta, RBCs, colon, brain, that is blood brain barrier. Remember, it is blood brain barrier. So this is most widely distributed transporter. GLUT1, it is most widely distributed transporter. GLUT1. GLUT2 is there on the other side, basolateral surface of the intestine, basolateral surface of the proximal convoluted tubular cell, also in the sinusoidal surface of the liver, and it is there in the beta cells of the isolate of Langerhans of the pancreas. GLUT2 is there. It is important in the regulation of blood glucose level. GLUT2. GLUT3 is there mainly in the neurons. Remember, GLUT1 is there in the blood brain barrier. GLUT3 is there in the neurons. GLUT4, the important one, the insulin sensitive glucose transporter. GLUT4, it is there in the skeletal muscle, heart and adipose tissue. Skeletal muscle, heart and adipose tissue. GLUT4 is there. Also GLUT8 and 12, these are insulin sensitive glucose transporter. So insulin sensitive or insulin dependent glucose transporter, this is very, very important. ये लास्ट INICT में भी क्वेश्चन आके गया था. द ग्लूकोज ट्रांसपोर्टर इन द मसल, that is mainly the skeletal muscle, heart and adipose tissue. Glucose transporter in the muscle which is insulin dependent, that is GLUT4. GLUT5, it is for the transport of fructose, it is there in the small intestine. GLUT7, it is there in the endoplasmic reticulum for the transport of the glucose in the endoplasmic reticulum. So these are the main glucose transporter. Remember, GLUT4, 8 and 12, these are insulin dependent glucose transporter. GLUT4 is distributed in skeletal muscle, heart and adipose tissue. GLUT2 is there on the other side. GLUT2 is there on the other side of the intestinal cell and proximal convoluted tubular cell. It is there in the sinusoidal surface of the liver, and it is there in the beta cells of the pancreas. GLUT1 is there in the kidney, placenta, RBC, colon and the brain. Glucose transporters, very, very important. Then see, these are the glycosaminoglycans. We'll discuss the glycosaminoglycans and the disorders related with the glycosaminoglycan. These disorders are known as mucopolysaccharidosis. They are known as mucopolysaccharidosis. In short, we'll tell you about the functions of the glycosaminoglycans. See, hyaluronic acid, it is there in the synovial fluid. And vitreous humor of the eye. Synovial fluid and vitreous humor of the eye. This act as lubricant, shock absorbent. It is important in cell migration and wound repair. Lubricant, shock absorbent, hyaluronic acid. Lubricant, shock absorbent, cell migration and wound repair. These are the polyanions. These are negatively charged because of the sulfate group, because of the mainly sulfate group, carboxyl group, sulfate group. Their negative repulsion is there. They are mucus in nature. They are resilient in nature. They are viscous. They absorb. They are like sponge. They are viscous. They are mucus in nature because negative repulsion is there. So hyaluronic acid, it is important in the shock absorbent, lubricant, cell migration, wound repair. Along with the chondroitin sulfate, it is important in the compressibility of the joint, in the weight bearing joint, compressibility of cartilage in the weight bearing joint. Along with the chondroitin sulfate, this hyaluronic acid is important. It is important for shape, structure and compressibility of cartilage and weight bearing. Along with the hyaluronic acid, it is there in the cartilage, bone and tendon. Mainly it is there in the cartilage, bone and tendon, chondroitin sulfate. Dermatan sulfate, it is there in the skin, heart walls and blood vessel. It is there in the skin, heart walls and blood vessel. Dermatan sulfate, it is N-acetyl galactosamine plus L-iduronic acid is there. This is epimer of glucuronic acid. L-iduronic acid is there. Dermatan sulfate. It is there in the skin, heart walls and blood vessel. It is there in the sclera. It is important for shape and structure of these tissues. Shape and structure of these tissues. Then the heparin, it is there in the skin, it is there in the lung, it is there in the mast cells. So lung, mast cell, blood and skin, heparin is there. Heparin, it is anticoagulant, it is anticoagulant, and heparin, it causes release of lipoprotein lipase from the capillary endothelium. Release of lipoprotein lipase from the capillary endothelium. This is heparin. This is heparin. Then heparan sulfate, it is there in the glomerular basement membrane. It is there in the glomerular basement membrane. It is there in the capillary endothelium. It is there in the synaptic vesicles. It is there on the cell surface. It is there on the cell surface, act as a receptor on the cell surface. It is there on the glomerular basement membrane, heparan sulfate. It is responsible for charge selectiveness of glomerular basement membrane. It gives negative charge to the glomerular basement membrane. That's why albumin doesn't appear in the urine. Albumin doesn't appear in the glomerular filtrate because negative repulsion is there. Despite of the low molecular weight of the albumin does not appear in the glomerular filtrate because of the negatively charged glomerular basement membrane. So it imparts negative charge to the glomerular basement membrane. It is having the anchoring role to the lipoprotein lipase to the capillary endothelium. Attachment of lipoprotein lipase to the capillary endothelium. It acts as a receptor and participate in cell adhesion and cell-cell interaction. It is there on the surface of the cell, act as a receptor and important in the cell-cell interaction, cell adhesion and cell-cell interaction. Heparan sulfate. Keratan sulfate is having N-acetyl glucosamine plus galactose is there. Remember, in keratan sulfate there is no uronic acid. Glycosaminoglycans, they are composed of repeating disaccharide unit. It is amino sugar plus uronic acid. But in the keratan sulfate structure, there is no uronic acid. In place of the uronic acid, there is galactose. It is there in the cornea. It is there in the cartilage. It is responsible for the transparency of the cornea. Okay. Now, when there is a defect in the degradation of this mucopolysaccharides, when there is defect in the degradation of lysosomal, defect in the enzyme, defect in the lysosomal hydrolases, when there is defect in the lysosomal hydrolases, it affect the metabolism of hydrolases, it affect the metabolism of glycosaminoglycan, and glycosaminoglycans accumulates in the various tissues. It is known as mucopolysaccharidosis. MPS. It is known as MPS. There are many types of the mucopolysaccharidosis. See, the type 1 is there, that is known as Hurler syndrome. Type 2 is there, that is known as type 1S is there. Type 1S, that is known as Hurler-Schei syndrome. Then type 2 is there, that is Hunter syndrome. Type 3, it is Sanfilippo ABCD. A, B, C and D. Then type 4 is the Marquio A and B. Type 5 Marquio A and B. Then type 6 is there. Type 6 is there. Type 6 is there. That is Marotilami. Type 6. Then type 7 is there. Sly disease. Sly disease. And type 9 is there. Type 9 is there. That is known as Natovic syndrome. Natovic syndrome. Type 9 is there. That is known as Natovic syndrome. Okay. So these are the mucopolysaccharidosis. At least try to remember the enzyme defect. Not all, but important one. See, the hurler, it is due to the defect in iduronidase. Iduronidase defect. This is due to the partial deficiency of iduronidase. Partial deficiency of this iduronidase. Iduronidase. This is iduronate sulfatase defect. Iduronate sulfatase defect. This is ABCD. This is generally related with the degradation of heparan sulfate. So there is very severe mental retardation when there is accumulation of heparan sulfate. Mainly it is sulfatase. Mainly it is sulfatase defect and the transferase. Sulfatase and transferase defect is there in the Sanfilippo syndrome. Marquio A and B. This is N-acetyl galactosamine. N-acetyl galactosamine sulfatase defect. Sulfatase defect. This is beta galactosidase. Beta galactosidase defect. Beta galactosidase defect. Marquio A, Marquio B. Remember, in Marquio syndrome there is accumulated substance, that is keratin sulfate and chondroitin sulfate, and or keratin and chondroitin sulfate. There is no accumulation of dermatan sulfate and the heparan sulfate as there in Hurler and the Hunter syndrome. Here accumulation of heparan sulfate and dermatan sulfate occurs. So there is mental retardation in this Hurler, Hunter, and in Sanfilippo heparan sulfate is there. There is mental retardation. There is there is no mental retardation in Marquio syndrome. There is accumulated compound is keratin sulfate, chondroitin sulfate. Then the Marotilami, it is due to the aryl sulfatase B defect. Aryl sulfatase B defect. Sly disease, it is beta glucuronidase defect. Glucuronidase defect. There is accumulation of dermatan sulfate and the heparan sulfate in the Sly disease. And the Natovic syndrome, it is hyaluronic acid. Hyaluronic acid accumulates. It is hyaluronidase. Hyaluronidase defect. There is joint problem. There is joint problem in this syndrome. Joint problem. This was asked. Natovic syndrome was asked in one of the paper, the PYQ. This is related with the PYQ. Natovic syndrome, type 9 mucopolysaccharidosis. Hyaluronic acid level increases. Hyaluronidase defect. It is joint problem. There is joint problem. So these are the mucopolysaccharidosis due to defect in the lysosomal hydrolase. There is accumulation of the glycosaminoglycan, mainly heparan sulfate and dermatan sulfate in the Hurler syndrome. Then again heparan sulfate and dermatan sulfate in the Hunter syndrome. Heparan sulfate in the Sanfilippo, ABCD. Marquio syndrome, there is keratin sulfate and chondroitin sulfate accumulation. Then Marotilami, it is the dermatan sulfate accumulation. Sly disease, there is accumulation of dermatan and heparan sulfate, and the Natovic syndrome, hyaluronic acid accumulates. Now see the mucopolysaccharidosis. Hurler, Hunter. The Hurler is the Hurler, feminine naam hai Hurler. The she is always first, so Hurler is the first, Hunter is the second. Remember, Hunter required vision for hunting, and he requires X for killing. So it is X-linked. Remember, this is X-linked disorder. Hunter is X-linked, and there is no corneal clouding in the Hunter syndrome. So Hurler syndrome, the defect is iduronidase. It is iduronidase defect. And Hunter syndrome, it is iduronate sulfatase. It is iduronate sulfatase defect. Iduronate sulfatase defect. See, Dermatan sulfate and heparan sulfate accumulates in Hurler and Hunter syndrome. Shy disease, there is accumulation of dermatan sulfate. There is partial deficiency of iduronidase is there. So these are characterized by skeletal deformity, mental retardation, coarse faces, hepatosplenomegaly, skin lesions are there. In this, multi-system involvement is there. Remember, there is no corneal clouding. There is no corneal clouding in the Hunter syndrome. Remember, there is no corneal clouding in the Hunter syndrome. So this is difference between Hurler and Hunter, but main feature is there is corneal clouding in the Hurler syndrome. There is no corneal clouding in the Hunter syndrome. It is X-linked. It is X-linked disorder. The Hunter syndrome is X-linked disorder. Now see, this is Sanfilippo ABCD. It is related with the heparan sulfate accumulation, and there is mental retardation, severe mental retardation because of the accumulation of mental retardation because accumulation of heparan sulfate. Markio AB, it is galactosamine sulfatase and beta galactosidase. There is accumulation of keratin sulfate and the keratin sulfate, and in the Morquio A there is chondroitin sulfate accumulation. There is no mental retardation, no hepatosplenomegaly in the Morquio A and B. Morotilami aryl sulfatase B defect, dermatan sulfate accumulates. There is no mental retardation. Remember, जिसका नाम M से चालू होता है उसमें mental retardation नहीं है, उसमें mental retardation नहीं है क्योंकि उसमें heparan sulfate accumulate नहीं होता है. Heparan sulfate जहाँ पे accumulate होता है वहाँ पे mental retardation is there. Sly disease type 7 is the Sly disease. Sly disease, it is beta glucuronidase defect, dermatan sulfate and heparan sulfate accumulates in the Sly disease. So these are the mucopolysaccharidosis. Type 9 is the Natovic syndrome. Joint problem is there because of accumulation of hyaluronidase. Now the glycogen storage disorder. Remember this mnemonic for the glycogen storage disorder. See, this is mnemonic, that is versatile player, कोरी एंडरसन न्यूजीलैंड का प्लेयर है. लास्ट टाइम जो इसके पहले की 2020 हुई थी यूएसए के तरफ से खेला था. कोरी एंडरसन, इस बार था या नहीं पता नहीं, मुझे भी याद नहीं. कोरी एंडरसन, वर्सेटाइल प्लेयर कोरी एंडरसन मेड हिस्ट्री या मेड हिस्ट्री करो या मेड हिज ग्लाइकोजन करो. ग्लाइकोजन स्टोरेज डिसऑर्डर याद रहने के लिए मेड हिज ग्लाइकोजन या मेड हिस्ट्री. Versatile player Corey Anderson made history. So this is von Gerg disease. This is von Gerg disease. Von Gerg disease. This is Pompey's disease. Remember, pump failure is there. मतलब heart failure. Pompey's disease. This is Corey disease. This is Corey's disease. This is Anderson disease. This is McArdle disease. This is Hirsch disease. The 7 is there. That is seventh is there. That is Taroi's disease. Is also there. Taroi's disease. Okay. Seventh. This is 6th. This is 5th. Okay. This is 1st. This is 2nd. Pompey's disease. This is 3rd, Corey's disease, or also known as limited dextrinosis, or the Forbes disease, and Anderson disease, also known as amylopectinosis. So first von Gerg's, Pompey's, then Corey's, then Anderson, then McArdle, Hirsch, and the Taroi's disease. Now the enzyme defect. See the enzyme defect. At least remember, try to remember the enzyme defect. Versatile player, von Gerg's disease. It is von Gerg's disease. Glucose 6 phosphatase defect. This enzyme is actually absent in the muscle, so there is no involvement of muscle in the von Gerg disease. Remember, there is no involvement of muscle in the von Gerg disease. Also spleen is not involved here. Here is hepatorenomegaly. Remember, हम हमेशा hepatosplenomegaly बोलते हैं, यहाँ पे hepatoreno. Liver enlargement is there, kidney enlargement is there in the von Gerg disease. Glucose 6 phosphatase defect. There is increased lipid levels. There is increased lactic acid level. Because of lactic acidosis, there is increased uric acid level. There is increased lipid, increased lactic acid. There is uric acid level because lactic acid competes with the uric acid for the excretion. This is known as von Gerg disease. Type 1 glycogen storage disorder. Type 0 is also there, that is glycogen synthase defect. Pompey's disease, there is pump failure. This is the lysosomal acid maltase disease. Lysosomal acid maltase, that is alpha glucosidase, alpha 1,4 glucosidase, alpha 1,6 glucosidase defect is there. There is involvement of the heart and heart failure. Death occur due to heart failure. This is mainly a muscle glycogen storage disorder. Muscle glycogen storage disorder. There is floppy infant and death at early age, around 2 years, below the 2 years of the age, 18 months to 2 years, because of the heart failure. Death occur because of the cardiac enlargement. There is cardiac enlargement, there is tongue enlargement. Pump failure, Pompey's disease, heart failure, lysosomal acid maltase defect. Now here is the ABCD, Anderson disease, branching enzyme defect. AB, Anderson disease, branching enzyme defect. Branching enzyme is defective. The life expectancy is below 5 years. There is amylopectin accumulates. The branching enzyme नहीं होने के वजह से the glycogen with few branching points accumulates. So Anderson disease, branching enzyme defect. Cory's disease, this is debranching enzyme defect. Debranching enzyme defect. Debranching enzyme defect. Small amount of glycogen, it is removed by the glycogen phosphorylase. इवन मतलब ब्रांचिंग वाले पॉइंट पे भी ग्लाइकोजन फॉस्फोराइलेज रिमूव करता है, लेकिन जैसे ही ब्रांच पॉइंट के पास में आता है, फोर ग्लूकोज रेसिड्यू नियर द ब्रांच पॉइंट, द ग्लाइकोजन फॉस्फोराइलेज एक्टिविटी stops, then you need the debranching enzyme. If there is debranching enzyme defective, the branched glycogen accumulates, but it is with the short branch glycogen which is accumulated, that is known as limit dextrin accumulation. So limited dextrinosis or forced disease, also known as Cory's disease. ये दोनों में, Cory disease, Anderson disease में liver cirrhosis is there, progressive liver cirrhosis is there. Anderson में life expectancy is very less. McArdle disease, it is muscle glycogen phosphorylase defect. Muscle glycogen phosphorylase defect. There is exercise intolerance, second wind phenomenon, and if exercise continues, there is excretion of myoglobin in the urine, that is myoglobin urea is there. Exercise intolerance, myoglobin urea on prolonged exercise. There is second wind phenomenon. If you pause for some time, if you take rest for some time, you can resume your activity in the McArdle disease. Her's disease, it is liver glycogen phosphorylase defect. Liver glycogen phosphorylase defect. So Her's disease, hepatomegaly is there. Thyroid disease, it is muscle and RBCs involved. Muscle and RBCs phosphofructokinase defect. There is mild hemolysis and exercise intolerance in the thyroid disease. Mild hemolysis and exercise intolerance. So this is type 1 Goenger's disease, type 2 Pompey's disease, type 3 Cory's disease, then Anderson disease, McArdle disease, Her's disease and thyroid disease. McArdle, Her's and thyroid disease. Remember, the Pompey's disease, mainly the muscle disorder, the McArdle disease, muscle glycogen storage disorder, and thyroid disease, muscle glycogen storage disorder. While the Goenger's, Cory's, Anderson and Her's disease, these are the liver glycogen storage disorder. Now see, type 0, it is because of glycogen synthase is defective, life expectancy is very less. There is no hepatomegaly in the type 0 glycogen storage disorder. There is hypoglycemia between the meal and early death occur. Glycogen synthase defect, type 0, glycogen storage disorder, type 0. Glycogen storage disorder type 1, it is Goenger's disease. It is due to the defect in the enzyme glucose 6-phosphatase. There is fasting hypoglycemia, hyperlipidemia, hyperuricemia, lactic acidosis and hepatomegaly is there. Lactic acid increases, that causes the retention of uric acid. It competes with the uric acid for the excretion. So that causes the hyperuricemia in the Goenger's disease. Then type 2 is the Pompey's disease, lysosomal acid maltase, also known as alpha 1,4 glucosidase या alpha 1,6 glucosidase defect is there. Small amount of glycogen, it is degraded in the lysosomes. If it is defective, it causes floppy infant. It causes glycogen accumulation and in liver, heart and muscles are mainly involved. It causes floppy infant and it causes cardiomegaly. Heart failure is there, tongue enlargement is there, heart and tongue enlargement is there in the Pompe's disease. The life expectancy is below the 2 years. Cory's disease, also known as limited dextrinosis or Forbes disease, there is debranching enzyme defect. Remember, this is CD. Cory's disease, debranching enzyme defect. Anderson disease, branching enzyme defect. Branching enzyme defect. There is progressive liver cirrhosis in the Cory's and Anderson disease. McArdle disease, it is muscle glycogen phosphorylase defect. Muscle glycogen phosphorylase defect. Phosphorylase defect. There is exercise intolerance, second wind phenomenon, and excretion of myoglobin in urine in the McArdle disease. Type 6 is the HERS disease. There is liver glycogen phosphorylase defect, hepatomegaly, and fasting hypoglycemia. These are the features. So fasting hypoglycemia is the important feature in the von Gerg's disease. von Gerg's disease. Okay. So these are the glycogen storage disorder. Liver के 4 है और मसल के 3 है. लिवर के 4 कौन से है? von Gerg's disease, Cory's disease, Anderson disease and HERS disease. मसल के 3 कौन से है? Pompe's disease, McArdle disease and the Taro's disease. Pompe's, McArdle and the Taro's disease. Coming to the link reaction PDH complex E1, E2, E3. It is a multi-enzyme complex. इसके 2 भाई और है. पायरुवेट डिहाइड्रोजनेस कॉम्प्लेक्स के 2 भाई और है. एक अल्फा कीटो ग्लूटारेट डिहाइड्रोजनेस और दूसरा ब्रांचेन अल्फा कीटो एसिड डिहाइड्रोजनेस कॉम्प्लेक्स. They are composed of 3 enzymes E1, E2 and E3. E1 is pyruvate dehydrogenase itself. E2 is dihydrolipoyl transacetylase and E3 is dihydrolipoyl dehydrogenase. So this is E1, that is PDH complex. E2 is dihydrolipoyl transacetylase and E3 is dihydrolipoyl dehydrogenase. There are 5 coenzymes required. कौन से 5 coenzyme लगते हैं? B1, B2, B3, B5 and lipoic acid. Now B1 का coenzyme form कौन सा है? Thymine pyrophosphate. Then B2 FAD is required. B3, that is niacin, that is NAD, it is required. The B5 coenzyme A is required, pantothenic acid का coenzyme A, and the lipoic acid. These are the coenzyme. 5 coenzymes requires for the pyruvate dehydrogenase complex. 3 enzyme, 5 coenzymes required for the pyruvate dehydrogenase complex. Now see, remember the thymine status of the body, it is checked by RBC transketolase activity. Thymine status of the body. Okay. Now coming to the uncouplers and the inhibitors of electron transport chain and the oxidative phosphorylation. There are 4 complexes in the electron transport chain: complex 1, complex 2, complex 3 and complex 4. When the electron it is transferred from the NADH, it is transferred through a complex 1, 2, 3, 4. When it is from the succinate dehydrogenase, it is via the complex 2, it is via the coenzyme Q, it is to the complex 3, cytochrome C, complex 4, and it is accepted by the oxygen molecule and it is converted into water molecule. Okay. Now see here, there are 2 mobile component. One is named the mobile electron carriers in the electron transport chain. This is the first, that is coenzyme Q. Coenzyme Q is first, that is known as ubiquinone. This is lipid soluble. And second one is the cytochrome C. These are the 2 mobile component of the electron transport chain. जब इलेक्ट्रॉन मूव होता है, ट्रांसफर होता है, इट इज फ्रॉम द कॉम्प्लेक्स 1 टू कोएंजाइम Q टू कॉम्प्लेक्स 3 टू साइटोक्रोम C एंड टू कॉम्प्लेक्स 4 एंड फाइनली ऑक्सीजन एक्सेप्ट करके वाटर मॉलिक्यूल बनता है. ओके, फाइनली एक्सेप्ट करके वाटर मॉलिक्यूल बनता है. जब एक सक्सिनेट से आता है, फ्रॉम सक्सिनेट इट इज कॉम्प्लेक्स 2 टू कॉम्प्लेक्स कोएंजाइम Q, देन कॉम्प्लेक्स 3, देन cytochrome C, then complex 4. During the transfer of electron, simultaneous pumping of the proton occurs. This is known as chemiosmotic hypothesis, which is responsible for generation of the electromotive force between the electromotive force are generated across the membrane, the positive outside and negative inside, because of ये जो complexes है इनके दो काम है, एक the transfer of electron पहला काम, the second important role is to act as a pump, proton pump, and pumping out of the protons from the matrix to the intermembrane space. Intermembrane space में proton pump out करता है, intermembrane space में proton pump out करता है. When the protons are pumped, when electron it is transfer, when electron transfer from NADH, 10 protons are pumped out. 10 protons are pumped out. When electron transfer from succinate dehydrogenase complex, 6 protons are pumped out. 6 protons are pumped out because first complex is bypass here. इसी वजह से इसमें से 4 और इसमें से 2 प्रोटॉन्स पंप्ड आउट होते हैं. फॉर सिंथेसिस ऑफ 1 ATP 4 प्रोटॉन्स आर नीडेड. एक्चुअली 3 लगते हैं और एक मूवमेंट के लिए लगता है, तो 4 प्रोटॉन लगते हैं एक ATP के प्रोडक्शन के लिए. सो the NADH will give you, this 10 protons will give you 2.5 ATP. It will give you 2.5 ATP, and 6 protons from the FADH2 via succinate dehydrogenase, it will give you 1.5 ATP. This is because of the chemiosmotic hypothesis. This transfer of electron through the various complexes of electron transport chain, it is coupled with pumping of proton from the matrix side to the intermembrane space. And these protons, when this membrane is impermeable to these protons, and only entry point, इसको वापस सिर्फ एक ही entry point है, through the FO unit of the ATP synthase. ATP synthase is composed of FO unit and F1. When proton moves through the FO unit of this ATP synthase, it causes changes in the gamma handle of the F1 unit, that causes the conformational change in the beta subunit, of ATP complex, which is responsible for the conformational change, that is known as binding change mechanism. The conformational change in the beta subunit is responsible for the ATP synthesis. It is responsible for the ATP synthesis, so ATP synthesis occurs. So electron transport, it is coupled with the oxidative phosphorylation. So these are the two important mobile electron carrier. Coenzyme Q, this is lipid soluble, lipid in nature. This is protein and this is water soluble. Remember, this is water soluble, this is protein in nature, and this is water soluble mobile component of electron transport chain. The complex 1, 2, 3 and 4, there are inhibitors of this complex 1, 2, 3, 4. Complex 1 inhibitor includes rotenone. This is an insecticide and fish poison. Rotenone inhibit the complex 1 of electron transport chain. The most important and frequently asked MCQ, rotenone. Then pericidin, gonithidine, and amobarbitol, barbital and secobarbital. These are the inhibitors of complex 1 of electron transport chain. Complex 2, it is inhibited by malonate, which is a malonate inhibits succinate dehydrogenase by competitive inhibition. Then phenyl trifluoroacetone and carboxyl. Inhibit the complex 2 of electron transport chain. Complex 3, it is inhibited by British anti-levisite, antimycin and the fenformin. These are the inhibitors of complex 3 of electron transport chain. And complex 4, the most important, the cyanide, carbon monoxide, azide and hydrogen sulfide. These gases, all gases, inhibit the complex 4 of electron transport chain. Specifically, the cyanide and carbon monoxide inhibit the complex 4 of electron transport chain. Here, remember the rotenone, remember the malonate, remember the cyanide and carbon monoxide inhibit the complex 4 of electron transport chain. Now the inhibitors of oxidative phosphorylation, that is the FO unit, FOO for oligomycin, FO, its inhibition by oligomycin, and F1, 1 represent the first factor that was isolated from the mitochondria. So FO unit, it is inhibited by the oligomycin. It is inhibited by oligomycin. Oligomycin and venturicidin. F1, it is inhibited by the orovatin. ATP, ADP transporter, it is inhibited by atractyloside. The chemical uncouplers, the delinking of the electron transport chain from oxidative phosphorylation means only heat is produced and ATP synthesis decreases. ATP synthesis decreases, O2 consumption increases, and the heat production increases. Heat production increases, ATP synthesis decreases, O2 consumption increases. This is by the chemical uncoupler or physiological uncoupler. This causes the delinking, means delinks इलेक्ट्रॉन ट्रांसपोर्ट चेन फ्रॉम ऑक्सीडेटिव फॉस्फोराइलेशन. तो एटीपी सिंथेसिस नहीं होता है क्योंकि द प्रोटॉन ग्रेडियंट जो डेवलप हो रहा था वो नहीं होता है. सो इट डीलिंग्स इलेक्ट्रॉन ट्रांसपोर्ट चेन फ्रॉम ऑक्सीडेटिव फॉस्फोराइलेशन. दिस अनकपलर्स इंक्रीजेस परमेबिलिटी ऑफ द इनर माइटोकॉन्ड्रियल मेम्ब्रेन. परमेबिलिटी, ये दोनों भी, ये भी और ये भी, मतलब permeability, increases permeability of inner mitochondrial membrane. So they act as an uncoupler. So chemical uncouplers are there: 2,4-dinitrophenol, dinitro-cresol, fluorochlorocarbonyl phenylhydrazine, and the aspirin in high doses, also calcium in high doses. 2,4-dinitrophenol, dinitro-cresol, FCCP, fluorochlorocarbonyl phenylhydrazine, aspirin in high doses, calcium in high doses. Physiological uncouplers, the important one includes the thermogenin. Thermogenin, it is there in the mitochondria. Thermogenin, it is there in the mitochondria of brown adipose tissue. Thermogenin, also known as uncoupler protein 1. Uncoupler protein 1, it is there in the newborn. It protects the newborn from hypothermia. It is there in the hibernating animal. So thermogenin, then long chain free fatty acid, then thyroxine, high level of thyroxine, and unconjugated bilirubin. These are the physiological uncouplers: thermogenin, long chain free fatty acid, thyroxine, and unconjugated bilirubin. 2,4-dinitrophenol, dinitro-cresol, fluorochlorocarbonyl phenylhydrazine, aspirin, and calcium. These are the chemical uncouplers. They decreases ATP production, increases O2 consumption, decreases ATP production, increases heat production. This was MCQ in the recent INICT examination. The effect of uncoupler: it decreases the ATP synthesis, increases O2 consumption, and increases the heat production. The ionophores increases the movement of other ions across the inner mitochondrial membrane. Mainly potassium ionophores are there: valinomycin, gramicidin, and nigricin. So these are the inhibitors and uncouplers of the electron transport chain and oxidative phosphorylation. Now the porphyria. See, porphyria, what is important to remember in the porphyria? Remember three important porphyria. Remember the three important porphyria. See, remember this U1, U3 and UD. U1, U3 and UD. U1 means uroporphyrinogen 1 synthase. U3 means uroporphyrinogen 3 co-synthase. This is uroporphyrinogen decarboxylase. These are the three important enzymes in the conversion of in the heme synthesis. From succinyl coenzyme A and glycine. It starts with succinyl coenzyme A and the glycine. U1, U3, UD. Uroporphyrinogen 1 synthase, uroporphyrinogen 3 co-synthase, uroporphyrinogen decarboxylase. If there is defect in the uroporphyrinogen 1 synthase, it causes acute intermittent porphyria. If there is defect in the UPG3 co-synthase, it causes congenital erythropoietic porphyria. and if there is defect in uroporphyrinogen decarboxylase, it causes porphyria cutanea tarda. It causes porphyria cutanea tarda. Now in acute intermittent porphyria, there is increased ALA, aminoleucinic acid, and parphobilinogen. There is increased ALA and PBG. There is decreased heme synthesis. There is decreased heme synthesis in decreased heme in the cells and body fluid. There is decreased heme in the cell and the body fluid, and there is increase this neurotoxin. There is increased neurotoxin. So it present as neuropsychiatric manifestations. It present as neuropsychiatric symptoms, psychiatric manifestation, neuropsychiatric symptoms, abdominal pain and neuropsychiatric symptoms. It present as abdominal pain and neuropsychiatric symptoms. Up till this step, there is no synthesis of porphyrinogen occurs. Because of that, there is no photosensitivity. There is no photosensitivity in acute intermittent porphyria. But here, the only manifestation in congenital erythropoietic porphyria and porphyria cutanea tarda, there is production of porphyrinogens on exposure to UV light. These porphyrinogens are converted into porphyrins. So there is increased level of porphyrinogens. These porphyrinogens, they are converted into the porphyrins by on exposure to sunlight. It is converted into porphyrins by the UV light. By the UV light on sun exposure, this porphyrins causes the lysosomal damage. This causes lysosomal damage, and this lysosomal damage causes the release of enzymes that causes the skin manifestation, that causes skin lesions, that causes photosensitivity is there. Sensitivity is there in the congenital erythropoietic porphyria and porphyria cutanea tarda. However, in the hereditary coproporphyria and variegate porphyria, there is all three symptoms: abdominal pain, psychiatric manifestation, psychiatric symptom. Also the photosensitivity is there. Photosensitivity. All porphyrias, they are autosomal dominant, except this congenital erythropoietic porphyria, it is autosomal recessive, and erythropoietic protoporphyria, which is autosomal recessive. Rest of the porphyrias, these are autosomal dominant. So these are the disorders related with the heme synthesis pathway. The acute intermittent porphyria, it is mainly because of uroporphyrinogen 1 synthase defect. Another name for this enzyme is hydroxymethylbilin synthase, also known as the parphobilinogen deaminase, because deamination is there. Parphobilinogen deaminase, तीनों एक ही एंजाइम के नाम है. यूरोपारफाइरिनोजन 1 सिंथेस, हाइड्रोक्सीमिथिलबिलिन सिंथेस, या तो पार्फोबिलिनोजन deaminase. Acute intermittent porphyria. No porphyrinogen synthesis occur till this step. Because of that, there is no photosensitivity in this porphyria. There is accumulation of ALA and PBG, which causes the neurological manifestation, and also because of the decreased heme synthesis in cells and the body tissues. Porphyria cutanea tarda is the most common. Defective enzyme is uroporphyrinogen decarboxylase. Photosensitivity is there because of the lysosomal release, because of the porphyrins. Hereditary coproporphyria and variegate porphyria, all three symptoms are there. It is because of the coproporphyrinogen oxidase defect. Variegate porphyria, it is due to the defect in the protoporphyrinogen oxidase. Congenital erythropoietic porphyria, it is autosomal recessive. It is because of uroporphyrinogen 3 co-synthase defect. There is main manifestation, it is photosensitivity. On exposure to the sunlight, there is photosensitivity. There is red color teeth, there is red urine, passage of red color urine in the porphyrias. Protoporphyria, this is erythropoietic protoporphyria, autosomal recessive. Because of the ferrochelatase defect, there is photosensitivity. So these are the porphyrias. Remember U1, U3, UD, acute intermittent porphyria, congenital erythropoietic porphyria, and the porphyria cutanea tarda. All are autosomal dominant except congenital erythropoietic porphyria and erythropoietic protoporphyria. Most of the porphyria, these are known as hepatic porphyria. For example, acute intermittent porphyria, porphyria cutanea tarda, hereditary coproporphyria, and variegate porphyria. These are known as hepatic porphyria, while these two are known as the Erythropoietic porphyria. Erythropoietic porphyria. The jaundice, how to differentiate between the three jaundice, the prehepatic, hepatic and the posthepatic jaundice. Remember, all enzyme levels are normal in the hemolytic jaundice. All enzymes levels are normal in the hemolytic jaundice. There is increase in the indirect bilirubin. There is increase in the indirect bilirubin in the hemolytic jaundice or prehepatic jaundice, and there is increased urinary urobilinogen, Ehrlich aldehyde test. It is detected by Ehrlich aldehyde test. Urinary urobilinogen, it is present in the hemolytic, that is prehepatic jaundice. Now, hepatic jaundice, SGOT, SGPT levels are marked raised in the hepatocellular enzymes, and slightly raised activity of ALP, GGT and the nucleotides. Slightly raised. There is increase in the both type of bilirubin. Both type of bilirubin increases. Vandenberg reaction is biphasic in the hepatic jaundice. Obstructive jaundice, there is slightly raised activity of SGOT, SGPT, but there is marked increase in the alkaline phosphatase, GGT and the 5' nucleotides. This is 5' nucleotides activity. 5' nucleotides. This is 5' nucleotides activity. There is marked increase in the obstructive jaundice. In obstructive jaundice, bile pigment and bile salt appears in the urine. So urinary bilirubin means Fauchet test and the H sulfur test is positive. Also, it may be positive in the hepatic jaundice. There is pale colored urine in the obstructive jaundice. And bilirubin which increases mainly is the direct bilirubin. So this is how to differentiate between the prehepatic, hepatic and the obstructive or posthepatic jaundice. Obstructive jaundice or the posthepatic jaundice. This is congenital hyperbilirubinemia, increase in the bilirubin level. There are two types of bilirubin. Indirect bilirubin, that is also known as unconjugated bilirubin, and the direct bilirubin which is known as conjugated bilirubin. Indirect bilirubin and the direct bilirubin. Indirect bilirubin increases in the Crigler-Najjar type 1, type 2 and the Gilbert syndrome. This is Crigler-Najjar type 1, this is type 2. The Gilbert syndrome, there is increase in the indirect bilirubin occur. So in this disorder, indirect bilirubin increases, while in the direct bilirubin increases in the Dubin-Johnson, DR, Dubin-Johnson and Rotor syndrome, DR, direct bilirubin increases in Dubin-Johnson and the Rotor syndrome. Okay, Crigler-Najjar syndrome, it is due to the deficiency of UDP glucuronil transferase enzyme. This is due to the UDP glucuronil transferase complete deficiency, complete block in the UDP glucuronil transferase enzyme. It causes Crigler-Najjar syndrome, and this is very severe where the bilirubin unconjugated bilirubin go beyond 20. It can be 25 to 45 milligram per deciliter. There is Kernick terrace. It is very fatal and it crosses the blood brain barrier, and it causes Kernick terrace. Type 1, that is Crigler-Najjar type 1 syndrome. Type 2, it is a milder form. 10% activity is retained. There is partial deficiency of UDP glucuronil transferase activity. Bilirubin can go up to 20. Bilirubin can go up to 20. Indirect bilirubin increases. Gilbert disease due to defective uptake of bilirubin by the hepatocytes. Also the 33% activity of UDP glucuronil transferase is there. So this is mild. The bilirubin can go up to 4 to 5 milligram per deciliter bilirubin. Indirect bilirubin can go up to 4 milligram per deciliter. So these are the causes of indirect increase in the bilirubin level, increase in the indirect bilirubin level. Crigler-Najjar type 1, type 2 and the Gilbert syndrome. And the conjugated hyperbilirubinemia, increase in the direct bilirubin occurs in the Dubin-Johnson and Rotor syndrome. In the Dubin-Johnson syndrome, this is MRP2 mutation, multi-drug resistant like protein 2, or also known as ABCC2, also known as MOAT, multispecific organic anion transporter defect. Because of MRP2 mutation, there is decrease. This is active secretion. This is involved in the active secretion of bilirubin into bile canaliculi. This is affected, and there is black liver, black discoloration of liver occurs in the Dubin-Johnson syndrome. Bilirubin, direct bilirubin can go up to 4 milligram per deciliter, 4 to 5. Matlab it is 2 to 5 or 2 to 4 milligram per deciliter bilirubin, that is direct bilirubin. So there is also mild hyperbilirubinemia in the Rotor syndrome. Here it is due to the mutation in organic anion transporter 1B1 and 1B3, I think 1B1 and 1B3. Organic anion transporter 1b1 and 1b3. This is required for reuptake of conjugated bilirubin by the hepatocyte. It is required for reuptake of conjugated bilirubin by the hepatocytes. The mutation causes the Rotor syndrome. There is no black staining of the liver occur. Bilirubin can go up to 2 to 4 milligram per deciliter. That is direct bilirubin. So this is congenital hyperbilirubinemia. Crigler-Najjar type 1, Crigler-Najjar type 2, Gilbert syndrome, Dubin-Johnson syndrome, Rotor syndrome. Now lipoproteins. Focus on the functions of lipoprotein and their major apoproteins. Apoprotein means the, just wait. See, focus on the lipoprotein functions and their मेजर अपोप्रोटीन. अपोप्रोटीन मतलब प्रोटीन पार्ट ऑफ लाइपोप्रोटीन जो रहता है उसको बोलते हैं अपोप्रोटीन, प्रोटीन पार्ट ऑफ लाइपोप्रोटीन. काइलोमाइक्रोन मेजर अपोप्रोटीन इज B48. इट इज फॉर द ट्रांसपोर्ट ऑफ डाइटरी ट्राइसाइल ग्लिसरॉल जो हम डाइट में लेते हैं. ट्रांसपोर्ट ऑफ एक्सोजिनस मतलब डाइट में जो टीजी हम खाते हैं दैट इज कैरिड विद द हेल्प ऑफ काइलोमाइक्रोन. इनका मेन फंक्शन यही है, ट्रांसपोर्ट ऑफ लिपिड. VLDL इट इज फॉर ट्रांसपोर्ट ऑफ द एंडोजिनस ट्राइसाइल ग्लिसरॉल जो लीवर में बनता है. सो ट्रांसपोर्ट ऑफ एंडोजिनस ट्राइसाइल ग्लिसरॉल फ्रॉम लीवर टू द पेरिफेरल टिश्यू. दिस इज द फंक्शन ऑफ VLDL. मेजर अपोप्रोटीन इज B100. Major is B100. Here it is ApoB48. ApoB48 and ApoB100, these are the examples of RNA editing. These are example of RNA editing. Ideal is the intermediate between VLDL and LDL. LDL is for the cholesterol. It is for the cholesterol, transport of cholesterol from liver to the peripheral tissue. It is known as bad cholesterol. When it is in the excess amount, there is formation of oxidized LDL, and this oxidized LDL is responsible for formation of foam cell, plaque, and that can cause myocardial infarction or stroke. So that's why it is known as bad cholesterol, transport of cholesterol from liver to the peripheral tissue. And HDL, it is reverse transport of cholesterol from peripheral tissue to the liver. Reverse transport of cholesterol, this is known as good cholesterol. Major is the ApoA1. ApoA1 is the major apoprotein in the HDL. LDL major apoprotein is the B100. Major apoprotein is the B100. These are the lipoproteins. Now see, this B48 is there in the chylomicron, B100 is there in the VLDL, IDL and LDL, because IDL and LDL they are produced from the VLDL. So VLDL, IDL, LDL is having the B100. Apo C1, C2, C3, Apo A1, A2 and Apo E. The functions are important. Remember these functions like this. See, Apo A1 activates Apo A1 is there in the HDL. It activates lecithin cholesterol acyl transferase. Apo A1 activates lecithin cholesterol. Apo A1 activate. This is Apo A1. Apo A1 activates lecithin cholesterol acyl transferase. Activates LCAT, lecithin cholesterol acyl transferase. Apo A1. Then remember Apo C2. This is Apo C2. Apo C2 activates lipoprotein lipase. It activates lipoprotein lipase. These are the two important MCQ. Very important MCQ. Apo A1 activates LCAT. Apo C2 activates the lipoprotein lipase. Now AC23. Remember AC23 matlab A2, Apo A2 and C3. Apo A2 and C3, they inhibit the lipoprotein lipase. Apo A2, remember see, Apo A2 inhibit the lipoprotein lipase and Apo C3 inhibit the lipoprotein lipase. Remember these important things. Apo E it is for the uptake. It is required for the uptake. Apo E, it is required for the uptake. Okay, so these are the important apoproteins, the protein part of the lipoprotein. अभी आते हैं फ्रेडरिक्सन क्लासिफिकेशन ऑफ हाइपरलाइपोप्रोटीनेमिया. फ्रेडरिक्सन क्लासिफिकेशन ऑफ हाइपरलाइपोप्रोटीनेमिया. दिस इज very important. So see, ये जो पहली ट्यूब दिखाई है, यहाँ पे जो ट्यूब है, दिस इज नोन एज लाइपेमिक प्लाज्मा, मिल्की टर्बिड ड्यू टू काइलोमाइक्रॉन. दिस इज टर्बिड प्लाज्मा. दिस इज ड्यू टू इंक्रीज काइलोमाइक्रॉन लेवल. दिस इज जनरली सीन इन टाइप 1 hyperchylomicronemia. Type 1 hyperchylomicronemia. So see, the milky plasma, chylomicron level increase, milky plasma is there in the type 1 disorder, type 1 hyperchylomicronemia. Apart from this, there is eruptive xanthomas all over body because of the TG deposition. There is eruptive xanthoma, and because of increased TG level, there is risk of pancreatitis in the type 1 hyperchylomicronemia. Type 1 or type 2, these are two very, very important. Now see, these are the manifestation in type 2A. Type 2A, see the type 2A, there is tendon xanthoma. The tendon xanthoma, the lesion, the nodular lesion because of accumulation of cholesterol on the tendon. So this is known as tendon xanthoma. The Achilles tendon is more commonly involved, Achilles tendon. And there is xanthelasma, the lesion, yellowish lesion on the eyelid, that is known as xanthelasma. It is seen in type 2A. This is seen in type 2A. This is seen in type 2A. This is seen in type 1. This is type 1. This is seen in type 1. This is type 2A, familial hypercholesterolemia. There is increased tendency of atherosclerosis, increased risk of atherosclerosis. There is tendon xanthoma. There is increased LDL cholesterol. There is increased cholesterol. In the type 1, there is TG level increases. In the type 2A, there is cholesterol level increases. So this is Fredrickson classification of hyperlipidemia. Type 1 is familial chylomicronemia. It is lipoprotein lipase defect. Lipoprotein lipase defect or ApoC2 defect. There is increased level of chylomicron and VLDL. TG level is more than 1000 milligram per deciliter. There is eruptive xanthoma and there is risk of pancreatitis in the type 1. There is milky plasma in the type 1. Type 2A, it is known as familial hypercholesterolemia. There is LDL receptor defect, also ApoB100 defect, LDL receptor or ApoB100 defect. There is increased level of LDL and cholesterol. There is tendon xanthoma, atherosclerosis, and there is risk of coronary artery diseases. There is arcus senilis. There is xanthelasma. There is risk of coronary artery diseases in the familial hypercholesterolemia. Type 2B, it is familial combined dyslipidemia. The feature of increased TG level and increased cholesterol level is seen in familial combined dyslipidemia. This is a common condition, familial combined dyslipidemia. Familial dysbeta lipoproteinemia, it is ideal defect. It is mainly the remnant chylomicron, remnant VLDL, that is known as ideal. It is ApoE defect, familial dysbeta lipoproteinemia. Familial triglyceridemia type 4, type 5, there is increased production of VLDL, and decreased clearance of chylomicron. It is there in the type 5. Type 4 is associated with insulin resistance, hyperinsulinemia and the insulin resistance. Type 4, it is related with alcoholism, obesity and diabetes mellitus. Type 4, overproduction of VLDL is there, familial hypertriglyceridemia. Remember type 1 and type 2. Type 1 is lipoprotein lipase defect or ApoC2 defect. Type 2 is LDL receptor defect or ApoB100 defect. There is tendon xanthoma, there is eruptive xanthoma in type 1, there is tendon xanthoma in the type 2. There is increased risk of pancreatitis because of increased TG level. There is increased risk of coronary artery diseases, atherosclerosis because of increased LDL level in the type 2A. So these are known as familial hyperlipidemia. Now hypolipidemia, beta lipoproteinemia, there were question in the last I think INICT examination. The beta lipoproteinemia, there is decreased beta lipoprotein, means decreased production of B48, B100. So there is no chylomicron, means there is this beta absent. Beta means absent. There is absent activity of this beta apoprotein. So there is no chylomicron, there is no VLDL, there is no IDL, and there is no LDL. Only HDL levels remain normal. And there is acanthocytes. Due to mutation in the gene encoding microsomal triglyceride transfer protein, chylomicron, VLDL and LDL, they are not produced. Beta apoprotein वाले कोई भी नहीं बनेंगे. This is known as A-beta lipoproteinemia. There is acanthocytosis in the A-beta lipoproteinemia. Tangiers disease, this is mutation in ABCA1 transporter, which is required for transport of cholesterol from peripheral tissue to the HDL core. It makes the HDL spherical. It is important in the transport, reverse transport of cholesterol. If there is Tangiers disease, if there is ABC mutation, it affects the HDL level. Low levels of HDL there, enlarged yellow-orange tonsil, hepatosplenomegaly, and neuropathy. These are the features of this Tangiers disease. See, this is yellow-orange tonsil, the hepatosplenomegaly, and the neuropathy is there in the Tangiers disease. Yellow-orange tonsil. This is pathognomic of the Tangiers disease. ABCA1 mutation is there. And there is decrease, means there is low or absent level of HDL. Which is important. HDL synthesis is requires ABCA1. The cholesterol is required. The HDL is responsible for the transport of the cholesterol. कौन से 3 feature बताए मैंने? Yellow orange tonsil, hepatosplenomegaly, and neuropathy is there, and the low levels of HDL is there in the Tangiers disease. So this is classical image-based question of the Tangiers disease. Now coming to the important discussion, that is the lysosomal storage disorder. Each and every point related with the lysosomal storage disorder, it is important. See, a patient presented with refractory anemia. A histological picture is shown with cells in the bone marrow. Which of the following enzyme is deficient? So this is wrinkled paper macrophages. This is known as Gaucher cell. The crumpled tissue paper or tissue paper macrophages is there. This is intracytoplasmic inclusion. The stacked appearance of the lipid is arranged, that is glucocerebroside. It is accumulates. Glucocerebroside accumulates. This is known as Gaucher's disease. In the Gaucher's disease, there is affected bone marrow. So that's why there is RBC, WBC and platelet count decreases. There is bleeding tendency. There is avascular necrosis of the bone. There is involvement of liver and spleen. It is involved. So there is hepatosplenomegaly. Bone marrow is involved. The cell count goes down. There is Gaucher cell, that is intracytoplasmic inclusion. Inclusion is seen. The glucocerebroside accumulates and it is responsible for the most of the symptoms. See, this is again crumpled tissue paper macrophages is there. Following is the bone marrow biopsy picture from a child with hepatosplenomegaly and pancytopenia. The characteristic cell seen in this biopsy is a diagnostic finding in which of the following disease? Answer is Gaucher's disease. This is a Gaucher's disease. This is known as Gaucher's cell. Gaucher's disease. Pancytopenia is there. Bone marrow, liver and spleen, it is involved. There is the lower end of the femur, the long bone appears like conical flask, that is known as Erlenmeyer flask. So this is known as Erlenmeyer flask deformity. There is pancytopenia, decrease RBC, WBC and platelet count. Because of the thrombocytopenia, because of the decreased platelet count, there is bleeding tendency. There is lower end of the femur, there is X-ray finding, it is known as Erlenmeyer flask deformity in the Gaucher's disease, and there is no cherry red spot on the macula in the Gaucher's disease. No cherry red spot on the macula. Now see, these are the features of lysosomal storage disorder. Cherry red macula without hepatosplenomegaly, without organ involvement. It is seen in Tay-Sachs disease. That is hexosaminidase A defect, hexosaminidase A deficiency, GM2 gangliosidosis. In Sandow disease, it is the cardiomegaly is there, hepatosplenomegaly is there, and cherry red macula is also there in the Sandow disease. Same feature, cherry red macula with hepatosplenomegaly, it is seen in the Niemann-Pick disease, that is sphingomyelinase defect, Niemann-Pick disease. This is seen in the Niemann-Pick disease. Cherry red macula with hepatosplenomegaly. The sphingomyelin accumulates. Sphingomyelinase defects, Niemann-Pick disease. Without hepatosplenomegaly, it is Tay-Sachs disease, that is GM1 gangliosidosis, that is Tay-Sachs disease. The bone crisis, the Erlenmeyer flask deformity in the lower end of the long bone. It is like a conical flask on the X-ray finding. Crumpled tissue paper macrophages, that is known as Gaucher's cell, and the pancytopenia. This is a feature of Gaucher's disease. There is no cherry red. Sorry, there is no cherry red spot on the macula in the Gaucher's disease. Beta glucocerebrosidase deficiency. Then ABC, angiokeratomas, the burning sensation in hand and feet. ABC, angiokeratomas, burning sensation in hand and feet, and the corneal opacity, the vessel involvement, renal failure, X-linked inheritance is there. That is known as Fabry's disease. That is known as Fabry's disease. Alpha galactosidase defect. Alpha galactosidase disease, Fabry's disease. Remember, vessel involvement is there. Young age involvement is there. The vessel involvement causes the renal stenosis. Renal vessels are involved. The X-linked inheritance, and ABC, angiokeratomas, means the telangiectatic lesions on the bathing trunk area below the umbilicus above the knee joint. Then this is known as angiokeratomas. Then the burning sensation in hand and feet, that is known as acroparesthesia, and the corneal opacities. These are the finding in the Fabry's disease. Then the Hurler syndrome, that is corneal clouding, coarse facial feature, developmental delay, hepatosplenomegaly, and the skeletal deformity is there in the Hurler syndrome. Hunter syndrome, there is no corneal clouding, iduronate sulfatase defect. There is no cherry red spot on the macula in the Krabbe's, Gaucher, and the Fabry's disease. Remember KGF as the mnemonic. Krabbe's, Gaucher, and Fabry's disease. There is no cherry red spot on the macula. No cherry red spot on the macula. Cherry red spot is seen in Tay-Sachs disease, Sandorf disease, Niemann-Pick disease. Tay-Sachs, Sandorf, Niemann-Pick disease. There is cherry red spot on the macula. There is no cherry red spot on the Krabbe's disease, Gaucher's disease, and the Fabry's disease. So these are the important points related with the lysosomal storage disorder. Lysosomal storage disorder. See, this is Erlenmeyer flask deformity. The Erlenmeyer flask deformity, the conical flask appearance of this, lower end of the femur, it is known as X-ray appearance. It is the avascular necrosis of long bone is there in the Gaucher's disease. So this is Gaucher's disease. Gaucher's disease, the defective enzyme is glucocerebrosidase. There is accumulation of glucocerebroside. Occurs. This is cherry red spot on the macula. The following fundoscopy depict a characteristic finding. This finding is present in all of the following except कौन से इसमें नहीं दिख रहा है. Cherry red macula कब दिखता है? When lipid accumulates and surrounding retina appears pale and fovea is spared because there is no layer of retinal ganglion cell in the fovea. So it is spared. So that's why it appears bright on the fundoscopic examination. So cherry red spot, it is not seen in KGF, Krabbe's, Gaucher, and Fabry's disease. So here answer is Gaucher's disease. There is no cherry red spot. It is seen in Niemann-Pick, which is with the hepatosplenomegaly. Tay-Sachs, there is no organomegaly, only cherry red spot is there. Sandorf disease, it is cherry red spot, organomegaly, hepatosplenomegaly is there, and cardiomegaly is also there. Is also there. These are the GM2 gangliosidosis, Tay-Sachs disease, and the Sandorf disease. Niemann-Pick disease, it is because of the sphingomyelin accumulation, sphingomyelinase defect, Niemann-Pick disease. See, these are the enzyme defect. Gaucher's disease, beta glucocerebrosidase defect. Niemann-Pick disease, sphingomyelinase defect. Krabbe's disease, beta galactosidase defect. Fabry's disease, alpha galactosidase defect. Tay-Sachs disease, hexosaminidase A defect. Sandorf, hexosaminidase A and B. Metachromatic leukodystrophy, aryl sulfatase A defect. And Farber's disease, it is ceramidase defect. Now from the nutrition, the MCQ from the nutrition, that is SDA, matlab specific dynamic action. The some amount of energy it is utilized for the utilizing the foodstuff for digestion, absorption, transport, utilization, and metabolism of that particular foodstuff. For example, carbohydrate. In case of the carbohydrate, the SDA is 5 to 10%. In case of the lipid, it is 0 to 5%. and in case of the protein it is near about 30%. This is for the deamination. Some amount of energy is lost as the urea. This is for the protein synthesis. The protein is with the highest SDA. Some amount of energy it is required over and above the calorific requirement, over and above the BMR, over and above the BMR. Some amount of energy it is required for utilization of the foodstuff. That is known as SDA of the food, or the calorigenic action of the food. This is for the storage of the carbohydrate as glycogen. This is required for the utilization of the lipid. This is required for the trans-deamination of the protein. This is required for the protein synthesis. This is required for the metabolism of the protein. This is mainly required for the utilization of foodstuff, that is digestion, absorption, transport, and the metabolism of the foodstuff. So for the mixed diet it is 10%. Caloric value, the carbohydrate will give you 4 calorie, the lipid will give you 9 calorie, the protein will give you 4 calorie per gram. RQ value matlab respiratory quotient, it is CO2 produced, it is a ratio of CO2 produced and oxygen utilized, oxygen consumed and CO2 produced when food is metabolized. When food is metabolized, this ratio is known as the respiratory quotient. In case of carbohydrate it is 1, in case of the protein it is 0.8, and in case of the lipid it is 0.7. In case of the mixed diet it is 0.85. that is known as respiratory quotient. It denotes the type of food utilized for the energy purpose. Carbohydrate 1, lipid 0.7 and protein 0.8, and for the mixed diet it is 0.85. SDA means it is for the digestion, absorption, transport, storage, and the utilization and metabolism of the foodstuff. Over and above the BMR, some amount of energy it is needed. 10% should be considered when calculating the calorie requirement of an individual. It is the BMR, the SDA of the food, and the physical activity which is taken into account when the calorie requirement of individual is calculated. कौन से 3 पैरामीटर कंसिडर करने चाहिए? BMR, basal metabolic rate, SDA of the food, and third one is the physical activity. These 3 factors should be taken into consideration when we calculate the energy requirement of an individual. This is oxygen dissociation curve, O2 dissociation curve. It is S-shape, it is sigmoidal in shape, it is S-shape or sigmoidal in shape. This is because of cooperativity. This is because of the cooperativity. This is also shown by the allosteric activators. This is because of the cooperativity. Cooperativity means each subsequent molecule binds with more affinity than the previous one. जैसे ऑक्सीजन और हीमोग्लोबिन का बाइंडिंग है, it shows the O2 dissociation curve sigmoidal. It is because of the cooperativity. The shift of oxygen dissociation curve to the right shift occur in presence of, right shift occur when there is increase in the H ion concentration, means decrease in the pH, increase in the PCO2, increase in the 2,3 bisphosphoglycerate level, which causes the release of oxygen to the tissue, increase in the chloride ion, and increase in the temperature. These are the factors. This is important MCQ. Cooperativity and right shift of oxygen dissociation curve. When there is increase in the H ion concentration, means decrease in the pH, increase in the partial pressure of CO2, increase in the 2,3 bisphosphoglycerate. This molecule occupies the central cavity of deoxyhemoglobin molecule, stabilizes the tense state of the hemoglobin, and causes release of O2 to the tissue. Chloride ion and temperature. This causes the right shift of oxygen dissociation curve. These are the urine, the order of the urine, the classical order of the urine. Remember it for the that is phenylketonuria. Remember it for the the burnt sugar smell. It is in the MSUD. Remember it is for the tyrosinemia. Okay, so tomcat urine order is there in the multiple carboxylase deficiency. Hawkins urea, there is swimming pool odor of the urine. Rotten fish odor, it is in the trimethyl amino urea, trimethyl amino urea. Boiled cabbage like odor because of succinyl acetone excretion in the urine in tyrosinemia type 1. This is in the tyrosinemia type 1. Remember this, tyrosinemia type 1. Burnt sugar smell, or the smell like burnt sugar, also known as क्या बोलते हैं उसको, burnt sugar smell. It is there in the maple syrup smell, or the burnt sugar smell, it is there in the maple syrup urine disease. Sweaty feet odor, it is leucine metabolism disorder, that is isovaleric acidemia. The sweaty feet odor is there, and the mousy odor or musty odor, it is there in the phenylketonuria. Musty odor or mousy odor is there in the phenylketonuria. So these are the typical odor of the urine in the various disorder. Okay. So this is very, very important. The top rated table from the Harper's Illustrated Biochemistry. Mainly remember the disorders related with the repair mechanism. So see, the nucleotide excision repair defect, it is because of the nucleotide excision repair defect. It repairs the thymine dimer. It is because of the UV light induced. Remember, UV light causes the thymine dimer formation. There is formation of covalent crosslinks between the two adjacent thymine residue. There is cyclobutane ring between two adjacent thymine residue. So this type of damage, it is induced by the UV light. This damage is repaired by the nucleotide excision repair. The bulky lesion, it is repaired by the nucleotide excision repair. There are steps: recognition, removal of the segment, then synthesis, and the synthesis of the DNA and the DNA ligase. So recognition, removal, synthesis of DNA, and the DNA ligase role is there in the repair, nucleotide excision repair. If there is fault in the nucleotide excision repair, it causes the xeroderma pigmentosum. Zero matlab dryness, derma matlab skin. Xeroderma pigmentosum. There is pigmented skin lesion. Hyperpigmented skin lesion, that is known as multiple freckles on sun exposed part of the body. Even on small sun exposure, even on small or single time sun exposure can cause the lesion. This lesion is 1000 times carcinogenic. There is 1000 times risk of getting cancer, that is squamous cell carcinoma, basal cell carcinoma, and melanoma in the xeroderma pigmentosum. There is thymine dimer formation. It is repaired by the nucleotide excision repair with the help of XC-nuclease enzyme, UVR XC-nuclease enzyme. If there is defect in the nucleotide excision repair, it causes xeroderma pigmentosum. Also the Coca-NA syndrome is there. Then second important is, if there is replication error and if there is mismatch, this type of mismatch, it is repaired by the, if incorrect base is added, जैसे कि साइटोसिन के अगेंस्ट में हमेशा गोनिन रहता है लेकिन थाइमिन ऐड हो गया, so this type of incorrect base, it is repaired by the methyl directed mismatch repair. If methyl directed mismatch repair is defective, that is because of the mutation in MSH and MLH, gene, MSH, MLH and PMS gene mutation. If there is this gene mutation, it causes the microsatellite instability and it causes the syndrome that is known as HNPCC, that is hereditary non-polyposis colon cancer, hereditary non-polyposis colon cancer, HNPCC. Autosomal dominant condition, familial condition, dominant familial condition. There is multiple cancer, multiple organs they are involved, mainly the colorectum, colon and rectum is involved, followed by the endometrium, ovaries they are involved. The relatives they are involved, the two successive generations they are involved. The relatives they are involved. 3-to-1 criteria is, it is used for the diagnosis. At least 3 family member, 2 generation, and 1 should be below the age of 50 years. This is the Amsterdam criteria for the diagnosis of HNPCC, hereditary non-polyposis colon cancer. It is due to the fault in the mismatch repair. Other disorders are defect in the non-homologous end joining, defect. Non-homologous end joining defect causes the SCID. There is T cell and B cell defect too. B and T cell, both the cells are defective, and there is repeated infection. There is repeated infection because of decreased immunity. Because of decreased immunity, it is decreases in severe combined immunodeficiency. Combined immunodeficiency. This was a disorder, severe combined immunodeficiency. Severe combined immunodeficiency. This was a disorder on which the gene therapy was tried first time. First time gene therapy was tried on SCID, severe combined immunodeficiency. B cell and T cell both are defective. It is because of defect in non-homologous end joining, also because of defect in adenosine deaminase, also because of decrease or defect in adenosine deaminase activity. Adenosine deaminase, purine nucleotide degradation enzyme, adenosine deaminase, and there is accumulated deoxyadenosine accumulates that causes the symptoms. So non-homologous end joining results in the SCID. These are the mechanism for the double strand break repair. Double strand break repair because of the ionizing radiation or the reactive oxygen species. Double strand break is there. If it is not repaired by the non-homologous end joining, it leads to the severe combined immunodeficiency. Non-homologous end joining leads to the severe combined immunodeficiency. If there is homologous recombination, if defect in the homologous recombination, this causes the ataxia telangiectasia like disorder, Bloom syndrome, Fanconi anemia, or breast cancer susceptibility. So remember the diseases, and this is defective repair mechanism. Diseases and defective repair mechanism. This is very, very important table from the Harper's Illustrated Biochemistry. See, Menkes disease and Wilson disease. See, ATP7A, A पहले आता है, M पहले आता है. Menkes disease, ATP7A mutation. Wilson disease, ATP7B mutation. Wilson's disease. This is Wilson's disease. Wilson's disease. Hepatolenticular degeneration भी बोलते हैं इसको. Hepatolenticular degeneration is there. There is involvement of liver. There is involvement of lenticular nucleus of the brain. As brain is involved, there is neurological symptoms, seizures, tremors, ataxia like symptoms are there, and also the lens is involved. The decimate membrane of the cornea is involved. There is ring that is known as KF ring. Golden brown, see brownish or greenish pigmentation in the decimate membrane of the cornea, that is known as Kaiser-Fleischer ring, because of copper accumulation in the decimate membrane of the cornea. And anterior surface of the lens, the copper accumulates, that gives the sunflower cataract in the Wilson's disease. Wilson's में copper excess है, Menkes में copper deficiency है. ATP7A, it is required for absorption of the copper, so copper deficiency is there. So copper deficiency is there. Here copper excess is there because of problem in the excretion of copper in the bile and incorporation into the ceruloplasmin. Ceruloplasmin level decreases in both Menkes and Wilson. दोनों में ceruloplasmin decrease होता है, but Menkes में copper levels are low, Wilson's में copper levels are high, and it causes the hepatolenticular degeneration. So neurological manifestation, KF ring, sunflower cataract, these are the features of the Wilson's disease because of ATP7B mutation. 7B का role क्या है? 7B is required for excretion of the copper, and it is required for incorporation of copper into ceruloplasmin. 7A is required for the absorption of copper. Deficiency causes Menkes disease. There is decreased copper, so decreased copper level in the Menkes disease. So there is decreased activity of enzyme lysyl oxidase. This is required for collagen cross-linking. So in Menkes disease, there is mental retardation, neurodegenerative disorder, X-linked disorder, mental retardation is there. There is steel or wiry hair, easily pluckable, brittle hair, wiry hair, wiry hairs, kinky hair, that is known as kinky hair. Easily pluckable hairs, brittle hairs are there. Also there is hypopigmentation. Also there are hypopigmentation because of affected tyrosine is pigmented patches, hypopigmented patches all over the body. So this is Menkes disease, copper deficiency. Wilson disease, copper excess. Diagnostic test for the Wilson disease is hepatic biopsy, copper biopsy, and the quantification of copper per dry weight of the liver. So the definitive gold standard test is the liver biopsy. liver biopsy and quantification of copper in dry weight of the liver, it is more than 250 microgram of the copper per 100 gram of the liver tissue, per 100 gram of the liver tissue. It is there in the Wilson's disease, hepatolenticular degeneration. Urinary copper more than 100 microgram per day. Microgram है कि milligram भूल गया मैं. Microgram per day. This is used for the screening purpose, and this is diagnostic purpose. Gold standard liver biopsy. So Menkes disease is important, and the Wilson's disease, it is important. Okay. Now see, these are the important points related with the telomere, which is it is there at the end of the DNA. There is 6 nucleotide repeat at the end of the DNA, that is known as telomere sequence. So this is, see, this is chromosome. So this is the end of the DNA. तो ये जो end वाला part रहता है, this end वाला part, this is having the telomere. This is having the telomere activity. 6 nucleotide repeat, TTAGGG. TTAGGG repeat is there. There is near about 15,000 bases, the junk region of DNA, which do not code for any protein, maintained by the telomerase, that is known as telomere terminal transferase. Telomerase, it is maintained by the telomerase. This is telomere terminal transferase, which is having the, which is active because of the RNA part, and it is having the reverse transcriptase activity. Telomerase is having the reverse transcriptase activity. The telomerase activity, it is increases in the cancer. And it decreases with the aging. Telomerase activity is there in the germ cell and the stem cell. It is there in the germ cell and stem cell, and it is absent in the somatic cell. So it is to protect the end of the DNA. After removal of the RNA primer. So it is maintained by the telomerase activity in the germ cell and the stem cell. This activity is absent in the somatic cell. This is about the telomere and the telomerase. Now coming to the ABG analysis, arterial blood gas analysis. ABG analysis, just wait. Just wait for 2 minutes. ABG analysis is important. All of you know the ROMs, all of you know about the causes of high anion gap metabolic acidosis. We will discuss that. Just wait. अभी थोड़ा सा फास्ट जाएंगे. सी, arterial blood gas analysis, look for the bicarbonate and PCO2 and look for the pH. Arterial blood gas analysis. If pH is less than 7.35, it is acidosis. If it is more than 7.45, it is alkalosis. So 7.35 के नीचे acidosis, 7.45 के ऊपर alkalosis. Look for the bicarbonate level 22 to 28 millimole per liter. If bicarbonate, it is the alkali reserve. If alkali decreases, it is acidosis. If alkali decreases, it is acidosis. If alkali increases, it is alkalosis. PCO2, it is carbonic acid. If carbonic acid increases, it is respiratory acidosis. If it is increases, it is acidosis. If it is decreases, it is alkalosis. ठीक है. If it is decreases, it is alkalosis. See 7.35 to 7.45. Then HCO3 22 to 28 millimole per liter, and PCO2 35 to 45 mmHg, 35 to 45 mmHg. ठीक है. See for the primary defect. Primary defect मतलब क्या रहेगा? जो पीएच के साथ जाएगा वो प्राइमरी डिफेक्ट. रिमेंबर दिस क्राइटेरिया रोम्स. Respiratory opposite metabolic same. Respiratory opposite metabolic same. So if pH decreases मतलब acidosis and the bicarbonate decreases means metabolic same direction में जा रहा है. Metabolic same direction में जा रहा है. If pH decreases and the bicarbonate level decreases, it is known as metabolic acidosis. This is known as metabolic acidosis. Acidosis. Now see, pH increases. If pH increases and the bicarbonate level increases, this is known as metabolic alkalosis. This is known as metabolic alkalosis. Metabolic alkalosis. ठीक है. Now the respiratory goes in opposite direction. If PCO2 increases, if PCO2 increases and pH decreases, this is known as respiratory acidosis. Respiratory acidosis. And if PCO2 decreases and pH increases, this is known as respiratory alkalosis. Respiratory alkalosis. Now always remember the parameter who goes with the pH. जैसे कि यहाँ पे pH डिक्रीज हो रहा है तो यहाँ पे मतलब यहाँ पे एसिडोसिस दिख रहा है तो यहाँ पे भी एसिडोसिस अगर दिख रहा है तो ये प्राइमरी डिफेक्ट. द पैरामीटर हु गोज विद द पीएच इज द प्राइमरी डिफेक्ट एंड सेकंड पैरामीटर इज द कॉम्पेंसेशन. Second parameter is the compensation. So these are the causes of metabolic acidosis and alkalosis. These are the main matlab this is the primary. These are the blood buffers. These are the blood buffers which is composed of bicarbonate, phosphate and the protein buffer. Bicarbonate buffer is important because of the quantity, because of the alkali reserve. Phosphate buffer is major intracellular buffer. This bicarbonate buffer is major in the extracellular fluid, and the mainly histidine is active because of imidazole group of the histidine. It is the most effective buffer in the plasma because of the histidine. Histidine is important. Imidazole group of histidine is important in the protein buffer. So remember, bicarbonate buffer is the major buffer in the extracellular fluid. Phosphate buffer is the major buffer in the intracellular fluid, and the albumin or hemoglobin act as a buffer mainly because of imidazole group of the histidine. These are the causes of metabolic acidosis, alkalosis, respiratory acidosis, respiratory alkalosis. Now remember these causes. See, the metabolic acidosis is divided into two main categories: high anion gap metabolic acidosis and normal anion gap metabolic acidosis. Metabolic alkalosis, when there is upper GI tract obstruction and vomiting, there is metabolic alkalosis. When there is retention of CO2 occurs, as in obstructive airway disorder, this is COPD, pneumonia, emphysema, paralysis of respiratory muscles, narcotics or sedatives. In this condition, the retention of CO2 occurs, that causes respiratory acidosis. When there is hyperventilation, either at high altitude or hyperventilation is there, hysteria is there, whether because of the fever, septicemia, meningitis. If there is hyperventilation, it causes blowout of the CO2 and it decreases the partial pressure of CO2, that causes the respiratory alkalosis. Now coming to the metabolic acidosis causes: high anion gap metabolic acidosis and the normal anion gap metabolic acidosis. This is important. So metabolic acidosis, see, in the metabolic acidosis, the pH means bicarbonate level decreases. That's why pH decreases. This is metabolic acidosis. There are two types, that is high anion gap metabolic acidosis. The causes includes mud piles. These are the causes of high anion gap metabolic acidosis. Methanol poisoning, uremia, that is renal failure, means renal failure. This is uremia, means renal failure. Diabetic ketoacidosis, propylene glycol poisoning. Then INH overdose, या तो iron overload. Lactic acidosis, ethylene glycol poisoning, ethylene glycol poisoning, and the salicylate poisoning. So these are the causes of high anion gap metabolic acidosis. So diabetic ketoacidosis, renal failure, organic acidurias, lactic acidosis, these are the causes of high anion gap metabolic acidosis. And normal anion gap metabolic acidosis is there. Anion gap, it is sodium minus bicarbonate plus chloride. Sodium minus bicarbonate plus chloride. Normal level is 8 to 12 millimole per liter. So it is normal anion gap metabolic acidosis. It is mainly seen in diarrhea. It is seen in renal tubular acidosis 1, 2 ka 4. 1, 2 and 4. It is seen in the gastrointestinal fistula. It is seen in sigmoidostomy, and it is there in acetazolamide therapy. So these are the causes of normal anion gap metabolic acidosis. So remember these causes: metabolic acidosis, high anion gap metabolic acidosis, and the normal anion gap metabolic acidosis. Causes of high anion gap metabolic acidosis and normal anion gap metabolic acidosis. Now this can be there, the blotting technique can be there in the match the pair type of question. Southern blotting is important for the DNA, identification of DNA. Northern blotting is there for the RNA identification, and the western blotting, it is confirmatory test used in the HIV. It is for the identification of protein. Also the eastern blotting is there, which detect the post translational modification in the protein. So southern blotting DNA, northern blotting RNA, and the western blotting is for the protein identification. It is for the protein identification. The branch chain alpha keto acid dehydrogenase complex, it is defective in the maple syrup urine disease. Smell of the burnt sugar. Intellectual disability is there. This is a disorder of branch chain amino acid metabolism, valine, isoleucine, and leucine. There are three important part of this, E1, E2, and E3, and it requires thymine pyrophosphate as the coenzyme. Also requires the other coenzymes are also required. 5 coenzymes required. Main is the thymine pyrophosphate. So this maple syrup urine disease, smell of burnt sugar, intellectual disability, hypotonia, boxing, bicycling like attitude is misbehavior is there. There is because of the branch chain alpha keto acid dehydrogenase defect. It is composed of three enzymes. E1, it is branch chain alpha keto acid decarboxylase. Branch chain alpha keto acid decarboxylase is the E1. E2 is dihydrolipoyl transacetylase, and E3 is the dihydrolipoyl dehydrogenase. So this is main classical MSUD. It is because of the branch chain alpha keto acid decarboxylase defect. Branch chain alpha keto acid decarboxylase defect. Then tumor markers, these are useful for the identification of various tumors. For example, alpha fetoprotein, it is identification for hepatocellular carcinoma and the germ cell tumor. That is the carcinoembryonic antigen CEA, it is for the CBL diagnosis. Colon, breast, lung, and pancreatic cancer. Colon, breast, lung, and the pancreatic cancer, it is important CEA. CA15-3, CA549, CA2729, estrogen receptor, progesterone receptor, and human epidermal growth factor 2 receptor 2 new. It is obtained from the rat neuroblastoma cell. That's why new. Human epidermal growth factor 2. Human epidermal growth factor receptor 2. So there is overexpression or amplification of HER2 new in the breast cancer. So it is in the breast cancer. CA15-3, CA549, CA2729, estrogen receptor, progesterone receptor, HER2 new. It is HER2 new. It is overexpressed or amplified in the breast carcinoma. CA19-9 for the pancreatic tumor, CA125 for the ovarian carcinoma. ACTH for the ectopic production of ACTH in small cell lung carcinoma. Calcitonin, it is most important. It is for the medullary carcinoma of thyroid gland. Medullary carcinoma of thyroid gland. Medullary carcinoma of thyroid gland. Calcitonin. Gastrin for gastrinoma, glucagon for glucagonoma, HCG for the placental tumor, also choriocarcinoma. Insulin insulin for the insulinoma, detection of insulinoma. This is the tumor marker. Then prostate specific antigen and prostatic acid phosphatase. It is for the prostate carcinoma. It is for the prostate cancer dono bhi. Alkaline phosphatase for the bony metastasis, neuron specific enolase for the neuroblastoma and also the small cell lung carcinoma, and LDH, lactate dehydrogenase, it is for the germ cell tumor and the lymphoma identification. So these are the tumor markers. Main is calcitonin, CEA is the colon, breast, lung and the pancreatic cancer, the alpha fetoprotein for the hepatocellular carcinoma and the germ cell tumor. Then CA125, CA199, CA125 for the ovarian tumor, CA199 for the pancreatic carcinoma. Then the breast cancer marker, that is HER2 new overexpress or amplification. It is seen in the breast cancer. These are the inhibitors of protein synthesis: prokaryotic inhibitor, eukaryotic inhibitor and inhibitor of the both. It includes puromycin. Puromycin is structurally similar to that of the tyrosine tRNA. Tyrosine tRNA, it is structurally resembles the tyrosine tRNA, incorporates into a chain, incorporates into a peptide, and causes the premature truncation of peptide, premature termination of protein synthesis, It is a inhibitor in both prokaryotic and eukaryotic inhibitor, puromycin. These are the prokaryotic inhibitor, tetracycline and doxycycline, block the attachment of amino acyl tRNA to the A site. Chloramphenicol binds to the 50S unit and blocks the peptidyl transferase activity. Erythromycin binds to the 50S unit and blocks the translocation of the ribosome. Aminoglycoside causes the misreading of the mRNA. It causes misreading of the mRNA. Blocks the initiation. Diphtheria toxin causes the ADP ribosylation of eukaryotic elongation factor 2. Ricin removes adenine nucleotide from 28S ribosomal RNA. Cycloheximide binds to the 60S ribosomal unit and blocks the elongation process. See, tetracycline binds to the 30S unit, prevent the attachment of new incoming amino acyl tRNA to the A site. Chloramphenicol binds to the 50S unit, blocks the peptidyl transferase activity. Erythromycin binds to the 50S unit, blocks the translocation of ribosome. Aminoglycoside causes the misreading of the mRNA and inhibit the translocation. It mainly blocks the initiation process. Aminoglycoside, streptomycin, kanamycin, neomycin, these are the drugs. Diphtheria toxin, this is very, very important, causes ADP ribosylation of eukaryotic elongation factor 2, blocks the translocation. Ricin binds with the 60S unit. It removes one adenine nucleotide from 28S ribosomal RNA. Adenine nucleotide, it is removed by the ricin. Cycloheximide binds to the 60S unit, inhibit the peptidyl transferase activity. Puromycin inhibit both prokaryotic and eukaryotic translation. It resembles the tyrosinyl tRNA and causes the premature termination of the protein synthesis. It resembles the tyrosinyl tRNA. So these are the inhibitors of the protein translation. These are the inhibitors of the translation process, protein biosynthesis. So diphtheria toxin is important, ricin is important, the tetracycline, doxycycline, chloramphenicol, erythromycin and aminoglycoside, it is important. Puromycin is also important. See, black urine on standing and black pigment deposit, it is seen in the alkaptone urea. This is the deposition of the alkaptone in the intervertebral disc. The converting the urine into the black urine and the staining of the cartilage is there. This is there. The enzyme defect is homogentisate. The enzyme defect is known as homogentisate oxidase. This is enzyme defect. The disorder is alkaptone urea. And this pigment, alkaptone urea, this pigment, name of the pigment is known as alkaptone, that causes uchronosis. Alkaptone, because of diversion of homogentisate by the polyphenol oxidase, it is converted into benzoquinone acetate, and benzoquinone acetate is converted into alkaptone. So this is a typical IBQ. The Castle's necklace dermatitis, it is seen in niacin deficiency. Pellagra, diarrhea, dementia, dermatitis is there. So it is seen in niacin deficiency. Zinc deficiency, the perianal rash is there. Periorifacial rash is there. Around the mouth, around the anal region is there. Thiamine deficiency causes the beriberi, dry beriberi, wet beriberi, infantile beriberi, Wernicke-Korsakoff syndrome. Iron deficiency causes microcytic hypochromic anemia. So this is Castle's necklace dermatitis in the niacin deficiency, that is known as pellagra. That is known as pellagra. So these are the important topics for the FMGE examination. Just revise this topic. Go for the common questions. Go for the frequently asked topics. Read the PYQs and the PYTs. Focus on the PYQs and PYTs. कुछ बाउंसर आएंगे, उनको स्किप करके ही हमको आगे जाना है. जो लेकिन कॉमन क्वेश्चन है, जो रिपीटेडली आता है और जो कॉमन एरिया से पूछा गया है, वो हमारा छूटना नहीं चाहिए. सो दिस इज ऑल अबाउट द important topics related with the FMGE examination. Just wait. Hi Dr. Khan. Hi Preeti. Hello everyone. Doll like faces all. So thank you very much all of you. Keep watching, keep learning, and best of luck for your examination. Thank you very much. Keep watching.
Hello students, good afternoon. Welcome to class. I hope I'm audible and visible. शुरू करें क्या? शुरू करें? Good afternoon. Are we good to go? चलो. So we are like a week away from the exam. बिल्कुल exam सिर पे है. तो हम क्या करें? So are we good to go? अरे राजेश sir, it's perfectly fine. We are very good and we'll finish on time. There'll not be a problem. Okay, so देखो, we are less than a week away from the exam and आज ना हम सिर्फ जो सबसे इम्पोर्टेंट चीज़ें हैं वो रिवाइज करेंगे. आई वॉन्ट यू ऑल टू गो टू द एग्ज़ाम वेरी वेरी कॉन्फिडेंटली. तो आज जो सबसे ज़्यादा इम्पॉर्टेंट चीज़ें हैं जो फिंगर टिप्स पे होना चाहिए उसको रिवाइज करेंगे. वी विल कीप द सेशन शॉर्ट बिकॉज यू हैव टू रिवाइज, यू हैव अ लॉट ऑफ थिंग्स टू रिवाइज ऑल्सो. जो भी थोड़े से आड़े टेढ़े वाले क्वेश्चंस थे वो ऑलरेडी जो FMG प्रेडिक्टर सीरीज था उसमें आई हैव ऑलरेडी डिस्कस्ड. जो हमारा TND था उसमें भी मैंने डिस्कस किया है. So all those things which are like how to differentiate between similar images, how to answer those kind of questions, वो सारी चीज़ें FMG predictor series में हम कर चुके हैं. तो I am not repeating the same thing. Today what we'll do is we will discuss those topics जिसका जो theory हमें बिल्कुल at the top of the mind होना चाहिए. Okay, चलो, let us start. So see, I'll start with the first topic, vernal keratoconjunctivitis, a topic that is asked almost हर एग्जाम में पूछते हैं. तो वर्नल केरेटोकंजंक्टिवाइटिस क्या है? इट इज द टाइप ऑफ रेकरेंट एलर्जिक कंजंक्टिवाइटिस. इट्स अ टाइप ऑफ रेकरेंट एलर्जिक कंजंक्टिवाइटिस. इसका दूसरा नाम क्या है? द अदर नेम इज स्प्रिंग कटार. इट इज स्प्रिंग कटार. It is seen in boys between 5 to 15 years of age. This is very important because ये question में हमेशा mentioned होता है. In India, it is seen during the summer months. In India, it is seen during the summer months and it presents with what the complaint is itching, watering, redness of the eyes. Itching, watering and redness of the eyes, this is the complaint. And let us look at what are the signs. So look at this picture. ये कौन सा picture है? These two are two important images here. So look at this. These flat topped elevations that are there. These flat topped elevations, they are called as the papillae. And this appearance, what is this called? This is called as your cobblestone appearance. This is called as the cobblestone appearance. And where is this seen? This is seen on the upper tarsal conjunctiva. So flat topped elevations on the upper tarsal conjunctiva, and this is called as the cobblestone appearance. Similarly, look at this. This is seen where? This is seen on the upper limbus. ये last time का भी question है on what do we see here? We see these whitish elevations and they are called as the HT spots or the Horner-Trantas spots. The HT spots or the Horner-Trantas spots. Okay, so these are the two important points here. Cobblestone appearance and Horner-Trantas spots. Now let's come to the treatment part. Treatment में there are two aspects. The treatment of the acute episode. The treatment of the acute episode means that the child has been brought to us with complaint of redness, watering, itching, etc. So for this, what are the classes of drugs which are used? Number one is lubricants. But lubricants जो है, they are only meant for symptomatic relief. Lubricants are meant only for symptomatic relief. So what are the different classes of drugs which are meant for definitive management? It starts with topical antihistaminics. Please remember, ये जो सारे drugs हैं, they are topical, they are not oral. We start with topical antihistaminics. इसके बाद, if the child does not improve, we step it up to topical steroids. And if still the child does not improve, then you step it up to topical immunosuppressants. So these are the classes of drugs. So topical antihistaminics, topical steroids, and topical immunomodulators. These are the drugs that are used in the treatment of the acute episode. Right? लेकिन अगर हमसे पूछा जाता है that which is the class of drugs which is used for the prevention of recurrence, which class of drugs is used for the prevention of recurrence? So prevention of recurrence के लिए which class of drugs are we using? We are using the mast cell stabilizers. We are using the mast cell stabilizers. And this is the treatment of VKC, vernal keratoconjunctivitis or spring catarrh. What kind of conjunctivitis is it? It is a recurrent and it is allergic. It's a type of allergic conjunctivitis. It's a type of recurrent allergic conjunctivitis. Okay, so this is about the VKC, vernal keratoconjunctivitis. I will just go through all the important topics quickly so that जो तुमको भूल गया है, it will just come back to you. Next important topic that we have is xerophthalmia. Xerophthalmia क्या है? Xerophthalmia, this is caused by deficiency of vitamin A. It is caused by deficiency of vitamin A, and this deficiency, this is usually seen in malnourished children. ये usually होता है in malnourished children. Now, how does deficiency of vitamin A affect the eye? The deficiency of vitamin A, it affects the eye in two ways. The deficiency of vitamin A, it affects the eye in two ways. Quickly yaad karo, what were the two ways? The first was it affects the rod cells of the retina. It affects the rod cells of the retina, wherein there is a pigment which is called as rhodopsin. And if this is not properly synthesized, then the patient will present to us with night blindness, that is nyctalopia. Night blindness या फिर nyctalopia. But deficiency of vitamin A, it also affects the ocular surface. How does it affect the ocular surface? In the ocular surface, the normal epithelium is stratified, squamous, non-keratinized epithelium. Stratified, squamous, non-keratinized epithelium. But in the absence or deficiency of vitamin A, this undergoes metaplasia. This undergoes metaplasia and it changes to stratified, squamous, keratinized epithelium. ये PYQ है. What is the change? The change of epithelium is from stratified, squamous, non-keratinized to stratified, squamous, keratinized. And this keratinized epithelium leads to xerosis, that is dryness, and ulceration, which is called as keratomalacia. Ulceration or keratomalacia. Xerosis, that is dryness, and keratomalacia, which is ulceration. So this is how the deficiency of vitamin A, it affects the eyes. Okay, अब आते हैं what is the WHO classification. WHO classification क्या है? This is the WHO classification. It begins with XN, that is night blindness. तो यहाँ से question आता है what is the earliest symptom of xerophthalmia? The earliest symptom of xerophthalmia, the earliest symptom is of xerophthalmia is night blindness. That is XN. Then comes stage X1. X1 comes to 1A and 1B. 1A जो है, it is conjunctival xerosis. And conjunctival xerosis, this is the earliest sign. ये दोनों ही PYQ है. And commonly ये गलत होता है. So याद रखो, if they ask what is the earliest symptom, the answer is night blindness. But if they ask what is the earliest sign, then the answer is conjunctival xerosis. लेकिन any conjunctival xerosis is actually not vitamin A deficiency. So what is the most specific sign? The most specific sign is stage X1B, that is Bitot spot. So the most specific sign is Bitot spot, and Bitot spot is what you see here in this image. तो ये जो इमेज है ये भी एग्जाम का ही इमेज है. दिस इज द bite out spot. So we look at this whitish lesion here. This is the bite out spot, stage X1b, which is the most specific sign. Then comes the stage X2. X2, this is the stage of corneal xerosis. और यहाँ से याद रखना है corneal xerosis. It is xerophthalmia is reversible up to this stage. It is reversible up to this stage. Then comes stage 3A and 3B. Stage 3A means corneal ulcer, which involves less than 1/3 of the cornea, that is 3A. And 3B is corneal ulcer involving more than 1/3 of the cornea. Then comes stage XS. Then comes the stage XS, that is xerophthalmia scarring, and end stage is xerophthalmia fundus. So यहाँ से 4 important questions है. Earliest symptom night blindness, earliest sign conjunctival xerosis, most specific sign bite out spot, and it is reversible up to the stage X2, which is the stage of corneal xerosis. Now, what is the treatment of xerophthalmia? Chalo, what is the treatment of xerophthalmia? The treatment is vitamin A supplementation. The treatment is vitamin A supplementation. And how do you remember the dose? The dose is for children greater than equal to 1 year or greater than equal to 8 kgs. What is the dose here? The dose here is 2 lakh international units orally. 2 lakh international units orally, and the regimen is on day 0, day 1 and day 14. Day 0, day 1 and day 14. And for children less than 1 year or less than 8 kgs, the dose is 1 lakh international units orally. 1 lakh international units orally. The regimen remains the same, that is day 0, day 1 and day 14. Now, important thing to note here, जो I always tell in the class, that if the age and the weight do not match, तो हमें कैसे देना है? We have to give it on the basis of the weight only, which means that if the question says that there is a child who is like 1.5 years of age, but who is weighing only 6 kgs, तो हम कितना देंगे? वी विल गिव 1 लाख इंटरनेशनल यूनिट्स. तो अगर एज और वेट जो है वो मैच नहीं हो रहा है, तो हमें ऑलवेज वी हैव टू गिव ऑन द बेसिस ऑफ द वेट, विच मीन्स इट विल बी 1 लाख इंटरनेशनल यूनिट्स. 1 lakh international units. Okay, and इसके साथ साथ there is also an intramuscular dose. Intramuscular dose is given to children who are very very sick and cannot accept the oral dose, and the intramuscular dose is half of the oral dose. The intramuscular dose, it is half of the oral dose. Right? Chalo. So this is about xerophthalmia or vitamin A deficiency. Now, next I come to a very, very important topic, and this why I feel it is important is क्योंकि last time इसमें से कुछ भी नहीं आया है. Last exam there was no question from corneal infections, which is a little surprising क्योंकि हमेशा ही question होता है. So under infective keratitis, बच्चों, we will be revising quickly 4 important types: bacterial, fungal, viral and acanthamoeba keratitis. So let us start with the first one, that is bacterial corneal ulcer. बैक्टीरियल कॉर्नियल अल्सर. अब इसमें क्या क्या हम याद रखेंगे फॉर बैक्टीरियल कॉर्नियल अल्सर? What are the symptoms? The symptoms are pain, redness, photophobia and decrease in vision. If you look at the lesion, what does it look like? The lesion, it is a single lesion and the margins are well defined. So look at this. This can come as an image based question also. So look at this. This is your lesion. The lesion, it is a single lesion and the margins are well defined. And how about the hypopion? What is hypopion? Hypopion means pus in the anterior chamber, and the hypopion is sterile and mobile. Mobile means that if you change the position of the head, then the position of the hypopion will change with gravity. And sterile means it contains only pus cells, but it does not contain any bacteria. It contains only pus cells, but it does not contain any bacteria. So the symptoms are pain, redness, photophobia, decrease in vision. The signs are, it is a single lesion with well-defined margins, and the hypopion, it is sterile and mobile. If we are asked how do we treat it, we treat it with fortified antibiotic eye drops. So what is the fortified antibiotic that is used? Usually cefazoline 5% eye drops. And along with this, we have to give atropine eye drops. Atropine eye drops, why? Atropine eye drops, this is for pain relief. It is a cycloplegic and it is meant for pain relief. This is for bacterial corneal ulcer. This is for bacterial corneal ulcer. Okay, on the same lines, let's do the next one, that is fungal corneal ulcer. So this is bacterial corneal ulcer. बैक्टीरियल कॉर्नियल अल्सर. अब सेम चीज को फंगल कॉर्नियल अल्सर के लिए पढ़ते हैं. So for fungal corneal ulcer also the symptoms are the same only. So this is our fungal corneal ulcer. The symptoms are the same, but the symptoms they tend to be less pronounced. For fungal corneal ulcer, important thing to remember, the symptoms are less pronounced. But there will be a preceding history, or I should say there may be a preceding history of trauma with vegetative matter. This is usually mentioned in the question. This is one of the key words. Okay, so symptoms are less pronounced, but there is a history of trauma with vegetative matter. There is often a preceding history of trauma with vegetative matter. If you look at the lesions, they look like this. So what will you say? There are multiple lesions, that is satellite lesions, as you can see in this image. So here see, there is one large lesion and there are surrounding smaller lesions. So ye jo smaller lesions hain, they are called as your satellite lesions. The margins are typically described as feathery or fuzzy. Feathery or fuzzy margins. And what can we say about the hypopion? किसी को याद आ रहा है? What should we say about the hypopion? यहाँ पे we say that the hypopion, it is fixed. Why it is fixed? Meaning it doesn't move with the position of the head, and it is non-sterile. It is immobile or fixed, and it is non-sterile. Non-sterile means that if you aspirate that pus, you will get fungal hyphae. So I will just go over it once more. For bacterial corneal ulcer, the symptoms tend to be more pronounced. Pain, redness, photophobia, decrease in vision, symptoms are more pronounced. Number of lesions, single, well-defined margins, hypopion is sterile and mobile. For fungal corneal ulcer, the symptoms, they tend to be less pronounced, but in the question, generally they will mention that there is a preceding history of trauma with vegetative matter. Number of lesions, multiple. One large lesion surrounded by smaller lesions. The margins are feathery or fuzzy. The hypopion is fixed or it is immobile and it is non-sterile. What is the drug of choice that we have learned here? The drug of choice here is usually natamycin 5% eye drops. Why natamycin 5% eye drops? Because most of the ulcers in India, they are caused by aspergillus, and aspergillus is very, very sensitive to natamycin. So that's why natamycin is the drug of choice. And along with that, we also give atropine eye drops in this case. Why atropine? Again, it is for pain relief. And if we are asked that which is the drug that is absolutely contraindicated in both bacterial and fungal corneal ulcers, the drug that is absolutely contraindicated in both cases is topical steroids. In both bacterial and fungal corneal ulcers, the drug that is absolutely contraindicated is topical steroids. ठीक है, तो ये हो गया बैक्टीरियल एंड फंगल. ओके, सो ये लास्ट टाइम नहीं आया है. लास्ट टाइम we didn't have any question from here, and before that we had a question on viral. So ये 2-3 एग्जाम से नहीं आया है. That's why I feel it's important. Good. चलो, let's go to the next one. The next one is viral keratitis. Next one is viral keratitis. Viral keratitis, it is caused by herpes simplex virus, that is HSV. Viral keratitis that is caused by HSV, herpes simplex virus. Right? So यहाँ पे कैसा है? For HSV keratitis, it is divided into different types. So what are the different types? The first one, this is called as epithelial keratitis. The first subvariety, it is called as epithelial keratitis. Epithelial keratitis, it is caused by direct invasion of the epithelium by the virus. It is caused by direct invasion of the epithelium by the virus and active viral replication. An active replication of the virus. Active viral replication. It is caused by direct invasion of the epithelium by the virus and active viral replication. And look at this. Look at the first image. In the first image, you have a linear lesion with branches. And at the end of each branch, there is a terminal bulb like this. So linear lesion with branches. What is this called? This kind of a linear lesion with branches. This kind of a linear lesion with branches, ये बहुत ही commonly asked question है. This is called as the dendritic ulcer. So this one, this first one, this is the dendritic ulcer. And look at the next one. In the next one, it is kind of a shapeless lesion, and this is called as the geographic ulcer. The first one is dendritic ulcer. The second one is geographic ulcer. Another question that comes from here is, what is the stain that has been used here and what is the filter? So the stain that has been used here is the fluorescein stain. And what is the name of the filter? The filter is the cobalt blue filter of the slit lamp. The stain that is used here is fluorescein stain, and the filter is the cobalt blue filter of the slit lamp. Now, epithelial keratitis जो है, that is caused by direct invasion of the epithelium by the virus, and therefore what is the treatment? The treatment is antiviral, that is acyclovir. But we have to remember that acyclovir 3% is given in the form of eye ointment. Acyclovir 3% is given in the form of eye ointment, and here also absolutely contraindicated. ये ना rose bengal नहीं है. Rose bengal is pink in color. ये जो है, where you have a blue background and on top of that when you have this kind of a green looking lesion, this is fluorescein dye and the filter is cobalt blue. Rose bengal doesn't look like this. Rose bengal is also very rarely used. Rose bengal pink color का होता है. Okay, chalo. So acyclovir 3% ointment, and what is absolutely contraindicated in this case? Absolutely contraindicated in this case is topical steroid. Why topical steroid? Because see here, it is caused by an active invasion of the epithelium by the virus, and the virus is also in a state of active replication. So that is why in epithelial keratitis, drug of choice is acyclovir and contraindicated is steroid. Now, if you look at the other types of keratitis, the other types of keratitis are stromal keratitis. Stromal keratitis, we have disciform keratitis. Stromal keratitis, disciform keratitis. Yes, dendritic, geographic, in both cases, the dye that we have used is fluorescein and the filter is cobalt blue. Both of them. It is fluorescein only. See, when you have this blue background and on top of it you have this green colored lesion, now it is fluorescein stain and it is cobalt blue filter. Rose bengal is very unlikely to come in the exam. I would say it's not very likely because it's not commonly used. But agar if you have to remember that rose pink hota hai na, so rose bengal jo hai wo pink color ka stain hai. You will get a pinkish appearance. It doesn't look like this. Okay, so now let's come to the other one: stromal keratitis, disciform keratitis, and endothelial keratitis. So here, what do we have to remember? What is the mechanism? Here, they are caused by an immune reaction to the viral antigen. It is caused by an immune reaction to the viral antigen. So because all these three types are caused by immune reaction to the viral antigen, that is why here the drug of choice is topical steroids. So don't make a mistake with this. Okay, so for stromal disciform and endothelial keratitis, the drug of choice is topical steroids under the cover of oral acyclovir. Under the cover of oral acyclovir. And another important thing which we have to remember is, so what did I tell you? For epithelial keratitis, acyclovir is the drug of choice and contraindicated is topical steroids. For other varieties, stromal disciform and endothelial, topical steroids is the drug of choice under the cover of oral acyclovir. Next, yahan se what we need to remember is, what is the special feature of viral keratitis? This is one of the key words which will be mentioned in the question. The special feature is there is a decrease in corneal sensations. There is a decrease in corneal sensation, and this is usually mentioned in the question. There is a decrease in corneal sensation, so it is a painless ulcer. The ulcer is typically painless in the acute stage. Okay, so this is about your HSV keratitis. Where do you get pseudodendritic keratitis? Pseudodendritic keratitis is seen in herpes zoster. Herpes zoster keratitis is pseudodendritic. Just because you asked, I told you. अगर याद रखना है तो याद रख लो कि ये डेंड्राइटिक होता है, ये हर्पीस सिंप्लेक्स है, लेकिन हर्पीस जोस्टर इज स्यूडोडेंड्राइटिक. हालांकि ये पूछा नहीं है. आई डोंट थिंक दैट जस्ट बिफोर द एग्जाम यू शुड बर्डन योरसेल्फ विद थिंग्स व्हिच हैव नॉट बीन आस्क्ड. चलो, so we have come to bacterial, fungal and viral. Now the next one is acanthamoeba keratitis. Acanthamoeba keratitis के क्वेश्चन को कैसे आइडेंटिफाई करेंगे? What are the important things to remember under acanthamoeba keratitis? What is the most important risk factor? What is the most important risk factor here? The risk factor is misuse of contact lenses. The most important risk factor is the misuse of contact lenses. Now, what kind of misuse? That is use of tap water to clean the contact lens. Use of tap water to clean the contact lens. Use of tap water to clean the contact lens, that is the most important risk factor. But you have to remember one thing, that the most common organism that causes keratitis in a contact lens misuser, however, is not acanthamoeba. What is the most common organism that causes ulceration or corneal ulcer in a contact lens misuser? It is actually Pseudomonas. It is Pseudomonas. So acanthamoeba, the most important risk factor for acanthamoeba is misuse of contact lenses. However, the most common organism that is seen in a contact lens misuser is actually Pseudomonas. So what are the key things to remember here? The key things that you remember here, look at the shape of this ulcer. This ulcer is a ring ulcer. And also it has a special feature, that is keratoneuritis. Keratoneuritis means inflammation of the corneal nerves, and therefore this ulcer is excruciatingly painful. So this is the most painful corneal ulcer. Now how do you confirm the diagnosis? Ye recent PYQ hai, that's why I would want you to remember this. How do you scrape? The investigation is, you do a corneal scraping, and after you do a corneal scraping, what is the stain and what is the medium for culture? The stain that we use here is called as chalcofluor white stain. The stain that we use is called as chalcofluor white stain, and the medium for culture is non-nutrient agar enriched with E. coli. It is non-nutrient agar enriched with E. coli. Chalcofluor white stain and non-nutrient agar enriched with E. coli. This is the medium for culture. Okay. Now, what is the treatment of choice, or what is the drug that we have to remember? The treatment for this is PHMB eye drops. PHMB stands for polyhexamethylene biguanide. PHMB, polyhexamethylene biguanide, PHMB eye drop. PHMB eye drops. And often what is the term that is used to describe this? Generally na exam mein misuse of contact lens, some contact with water. Either they will say that tap water was used to clean the contact lens, or the question will say that the patient went swimming with contact lens, and after that there is a painful lesion which is in the form of a ring. So contact lens misuse and ring lesion, ये दोनों चीजें एक साथ mentioned होती हैं question में. And also they generally mention that the pain is out of proportion to the clinical signs. That is, there is a lot of pain which cannot be explained by the clinical signs. So these important words will be there in the question. Okay, and what is the treatment? The treatment is PHMB eye drops. ठीक है. So ये चार type of keratitis हो गए which I feel that we should know properly. I think अभी सबको याद आ गया है ना जो हमने पढ़ा था. बैक्टीरियल, फंगल, वायरल और एकांथमीबा के इंपॉर्टेंट पॉइंट्स याद आ गए सबको? चलो, लेट्स गो टू द नेक्स्ट टॉपिक. द नेक्स्ट टॉपिक इज केराटोकोनस. Chalo, let's come to keratoconus. Keratoconus is a non-inflammatory it is a non-inflammatory corneal ectasia. So it is what? It is a protrusion of the cornea which is also associated with thinning. So there is a bulging of the cornea and the portion that is bulged out, that portion is also thin. Protrusion associated with thinning. Protrusion associated with thinning. So both things are important. Protrusion bhi hai and thinning bhi hai. It is protrusion which is associated with thinning. Right. Next is that there is, what are the symptoms? The symptoms are these: frequent change of glasses and irregular myopic astigmatism. Because of this irregular myopic astigmatism, we are having a frequent change of glasses, and the question will say there is discomfort with glasses. There is discomfort with glasses. Another important question: because of this irregular myopic astigmatism, you get a special reflex on retinoscopy, which is called as scissoring reflex, which is the splitting of the retinoscopy reflex. This is an early sign. So, early sign of keratoconus is scissoring reflex on retinoscopy. नेक्स्ट है ये पिक्चर इस बार आया था, दैट इज Munson sign. What is Munson sign? Munson sign means that on looking down, when the patient is asked to look down, the bulging cornea is pressing on the lower lid. The bulging cornea is pressing on the lower lid. Next, Fleischer's ring. Fleischer's ring is what? Fleischer's ring is pigmented ring at the base of the cone. It's a pigmented ring or pigmented line at the base of the cone due to iron deposition. Pigmented ring at the base of the cone due to iron deposition. Then you have striae or stretch lines on the cornea, which are called as Vogue striae. So what are Vogue striae? These are striae on the Descemet's membrane due to stretching. These are striae on the Descemet's membrane due to stretching. Due to stretching. So let us just go over this once more. It's a protrusion associated with thinning. So it's not just bulging or protrusion. There has to be protrusion and thinning. Then only we can call it keratoconus. It presents with, the cause is that उसकी वजह से जो कॉर्निया का शेप है वो badly damage हो जाता है, giving rise to irregular astigmatism. And because of this irregular astigmatism, there is a frequent change of glasses and discomfort with glasses. Early sign is the scissoring reflex or splitting of the retinoscopy reflex. Next, ये picture, Munson sign, Fleischer's ring, that is pigmented ring at the base of the cone due to deposition of iron. Vogue striae, they are striae on the Descemet's membrane due to stretching, and very good, they are vertical in direction. We remember it as V for V. Vogue striae are vertical in direction. अब next है कि इसको investigate कैसे करना है. How do you investigate keratoconus? The best investigation is corneal tomography. Tomography is the investigation of choice. अगर tomography available नहीं है, then the next best is topography. और अगर ये भी नहीं available है, then we are going to do a keratometry and pachymetry. Keratometry में it will show that the curvature is increased, and pachymetry में it will show that the thickness is decreased. So keratometry shows increased curvature and pachymetry shows that there is decrease in the thickness. So if we are asked, इसको please ध्यान से सुनो, if we are asked which is the investigation of choice or which is the best investigation, it is tomography. अगर tomography option में नहीं है, then the option is topography, and if that's also not there, then we do keratometry and pachymetry. Let's come to the treatment. The treatment, what is the first line of management? The first line of management is RGP, that is rigid gas permeable contact lenses. Rigid gas permeable contact lens helps to correct the irregular astigmatism. But if the cornea is too much bulging and we are not able to fix the lens, then we will try to flatten the cornea by doing a procedure which is called as C3R. The full form of C3R is corneal collagen cross-linking with riboflavin. Corneal collagen cross-linking with riboflavin, that is C3R. अगर C3R से भी काम नहीं हो रहा है, the next option that can be done is intracorneal ring segments. Intracorneal ring segments or ICRS, that is inserting certain rings into the cornea to correct the irregular astigmatism. And last option, when nothing works, is cornea transplantation or keratoplasty. So these are the treatment options. So rigid gas permeable contact lenses, if we are not able to fit the lens, then flatten the cornea doing C3R. Then there is the option of ICRS, that is intracorneal ring segments, and last option cornea transplantation or keratoplasty. अब मुझे बताओ कि ये याद आ रहा है? All these topics that we have discussed under the cornea, see these are the things that should remain at the top of your mind. हमने बहुत कुछ पढ़ा है, बहुत कुछ डिस्कस किया है in our जो FMG प्रेडिक्टर सेशन था, उसमें सारे जो कंफ्यूजिंग इमेजेस थे, सब कुछ we have gone through them, but now it's the time to consolidate on the most important information and be positive. Tomo and topo are both same. They are not the same actually. Tomography is slightly better than topography. So option में अगर tomography है तो उसी को mark करना है. That is the best. But अगर tomography is not there in the options, then we mark topography. चलो. So with this, we finish the important topics in the cornea. Now let's come to the next set of topics, that is the refractive errors. Let's quickly run through the images of the refractive errors and then we'll quickly rush through the glass prescriptions also. So dekho, these are the parallel rays of light. They are meeting at this point F, which is in front of the retina. They are meeting at the point F, which is in front of the retina. This is called as myopia or simple myopia. This is myopia or simple myopia. Myopia या simple myopia में कैसा है? That here the distance vision is affected but the near vision is normal. In myopia, the distance vision is affected but the near vision is normal, and so this is called as nearsightedness. The near vision is normal and so this is called as nearsightedness or short-sightedness. Nearsightedness or short-sightedness. Next, let's have a look at the next image. In this image, see, these are the parallel rays of light. This is meeting at the point F, which is behind the retina. This is meeting at the point F, which is behind the retina. So this is simple hypermetropia. Simple hypermetropia. The other name for simple hypermetropia is farsightedness or long-sightedness. It is farsightedness or long-sightedness. Now let's come to pictures of astigmatism. Astigmatism जो है, in astigmatism, how do we identify that these are pictures of astigmatism? We identify it by the fact that the rays of light which are coming in, they are a single bundle, लेकिन अंदर में वो जो है, they are splitting into two parts. So this is the first one. I'm naming this as F1 and this as F2. So here see F1 is emetropic because F1 is meeting on the retina, and F2 jo hai, it is myopic because it is meeting in front of the retina. So this is what? This is SMA, simple myopic astigmatism. So this is simple myopic astigmatism or SMA. Next one iska counterpart hai. This is F2 and F1. So now here what will we say? We will say that F1 is normal या फिर emetropic, whereas what should we say about F2? F2 जो है, it is hypermetropic because, sorry, I named it opposite. So this is F1 and this is F2. So F1 is emetropic and F2 जो है, it is hypermetropic. So one axis is normal and the other is hypermetropic. What are we going to call this? This is SHA. Simple hypermetropic astigmatism. Simple hypermetropic astigmatism or SHA. Now the next one is this. Here see, this is F1 and this is F2. This is F1 and this is F2. So here what will we say? Here F1 and F2 are both myopic. Here F1 and F2 are both myopic, but they are not equally myopic. F1 is more myopic than F2. So here this is called as CMA, compound myopic astigmatism. F1, F2 are both myopic. In the next one also very similar. F1, F2 are both hypermetropic. Here F1 and F2, they are both hypermetropic. F1, F2 are both hypermetropic. Again, F1 more than F2. They are not equally hypermetropic. So this is called as CHA, compound hypermetropic astigmatism. Compound hypermetropic astigmatism. And the last one is this. This is F1, this is F2. F1, it is in front of the retina, so this is myopic. And F2, which is behind the retina, so this is hypermetropic. It is hypermetropic. So what is this? This is a mixed astigmatism. This is a mixed astigmatism. ये आई थिंक किसी को नहीं भूला होगा. दिस एवरीबडी रिमेंबर्स? यस ना बच्चों? यस एवरीवन? Now I'll quickly rush through any question that can come on glass prescription. So I'll just quickly revise what I had told you in the class कि glass prescriptions वाले questions को हमें कैसे solve करना है. So if we have a question on glass prescriptions, how will they ask these questions? They will ask these questions as images. ये question में सिर्फ image ही पूछ सकते हैं और कुछ नहीं पूछ सकते इसमें. These questions are always asked as images only. Next is the question on glass prescriptions. Give one example. They will give this image and they will ask identify the refractive error. So you have to identify the refractive error. That's what. Let us now quickly come to how to solve the questions on glass prescriptions. Now, if we get a question on glass prescription, if you remember, how did we learn treatment of refractive errors is glasses. The first line of management for refractive errors is glasses. So when we get questions on glass prescriptions, so then what will we do? I had told you that we will see whether it is a minus prescription or it is a plus prescription. Remember? So if it is a minus prescription, we follow the rule that is M for M. M for M means what? That if it is a minus prescription, then it is either myopia or myopic astigmatism. So in a glass prescription, suppose it is minus. If it is a minus prescription, then it is either myopia or myopic astigmatism. Whereas if it is a plus prescription, it is hypermetropia or hypermetropic astigmatism. So minus prescriptions can either be myopia, that is simple myopia, or it can be SMA, simple myopic astigmatism, or it can be CMA, compound myopic astigmatism. Right? Similarly, if it is a plus prescription के क्या क्या options बताए थे मैंने? That it will either be hypermetropia or it will be SHA or it will be CHA, right? Now, what was the trick for solving the question? That if it is, let's first come to minus prescriptions. अगर minus prescription है which is only a sphere, if it is a minus prescription which is only a sphere, then it is myopia. If it is a minus prescription which is only a cylinder, then it is SMA. And if it is a minus prescription which is both a sphere and a cylinder, a minus prescription which contains both sphere and cylinder, then it is CMA. Okay, so a minus prescription which is only a sphere, I told you this is myopia. A minus prescription only a cylinder is SMA, and a minus prescription with both sphere and cylinder, it is CMA. Same thing for plus. So देखो, a plus prescription which is only a sphere, it is hypermetropia. A plus prescription which is only a cylinder, that is SHA. And a plus prescription which is both sphere and a cylinder. A plus prescription which is both sphere and cylinder, that is CHA. Now let us try to apply this and solve the questions. अब इतना I hope सबको याद आ रहा है from what we had discussed, that a plus prescription which is only a sphere is hypermetropia, plus which is only cylinder is SHA, and plus which is both sphere and cylinder is CHA. So abhi I'll just let us solve the questions in the form of examples. So suppose if we have this prescription, a minus prescription which is only a sphere. Look at these examples. A minus prescription which is only a sphere like this. Minus food after sphere. Tell me what is this? I will wait for the answer. Chalo. A minus, see what is this? It's a minus prescription which is only a sphere. तो ये क्या है? A minus prescription which is only a sphere. What is this? चलो solve करो इसको, ऐसे ही question आएंगे ना. What is the see, this is the minus prescription which is only a sphere. A minus prescription which is only a sphere means it is myopia, correct? Now the next one is a minus prescription which is only a cylinder. Suppose I say that -2 cylinder cross 90. A minus prescription which is only a cylinder. This is SMA, simple myopic astigmatism. है ना? A minus prescription which is only a cylinder. And the third one is a minus prescription which has both. That is say -2 sphere and say -1 cylinder cross 90. ये क्या है? A minus prescription which has both sphere and cylinder. So this is CMA. A minus prescription which has both sphere and cylinder. This is CMA. Correct. Ab next wala. Next is a plus prescription which is only a sphere. A plus prescription which is only a sphere, something like this. Plus prescription hai, only sphere hai. This is hypermetropia. Next is a plus prescription which is only a cylinder. Say like this, +1 cylinder cross 90. What this is? This is SHA. Correct. And this one last is this, a plus prescription which has both a sphere as well as a cylinder. A plus prescription which has both a sphere as well as a cylinder. What is this? This is CHA. A plus prescription which has both sphere and cylinder. Last one, देखो +2 sphere and say +1 cylinder cross 90. ये plus prescription है, इसमें sphere and cylinder दोनों है ना? And the last one is something like this. See, -1 sphere and say +2 cylinder cross 90. तो यहाँ पे देखो there is a combination of plus and minus, and the cylinder is more than the sphere. There is a combination of plus and minus, and the cylinder is more than the sphere. This is a prescription of mixed astigmatism. This is a prescription of mixed astigmatism, a combination of plus and minus, and see the cylinder is more than the sphere. This is a prescription of mixed astigmatism. है ना? तो यहाँ तक याद आ गया सभी को? I hope everybody has been able to recall this. Yes, please give me a thumbs up. तो लास्ट वाला पार्ट जो है उसको एक बार रिवाइज कर लेते हैं. दैट इज विद द रूल एंड अगेंस्ट द रूल. याद आ गया ना यहाँ तक सबको? Yes. I hope everybody has remembered this. Now I'll just quickly revise what is with the rule and against the rule. How do we decide with the rule and against the rule? I had told you, look at the prescription. If you have a minus cylinder 180 degrees, or if you have a plus cylinder 90 degrees, this is with the rule. अगर इसके साथ मैच नहीं करता है तो it is against the rule. So see, a minus cylinder 180 degrees or a plus cylinder 90 degrees, this is with the rule. If it doesn't match with this, then it is against the rule. So prescription number 2 पे आओ. See, it is -2 cylinder cross 90. I am starting with prescription number 2. यहाँ पे देखो -2 cylinder cross 90. तो ये क्या है? ये इसके साथ मैच नहीं हो रहा है. So this is against the rule. This is against the rule. Similarly, look at prescription number 3. इसमें भी देखो minus cylinder cross 90 है. So this is also against the rule. Look at prescription number 5. Plus cylinder cross 90. So this is with the rule. Prescription number 6. Here also see plus 2 sphere plus 1 cylinder cross 90 plus cylinder cross 90. So this is also with the rule. The last one, this is also plus cylinder cross 90. So this is also with the rule. So minus cylinder cross 180 या फिर plus cylinder cross 90 मतलब with the rule. अगर इसके साथ मैच नहीं होता है so it is against the rule. याद आ गया ना सबको? I hope everybody has been able to recall this much about last prescriptions. These are the things जो बिल्कुल brain के top में होना चाहिए and also these are the things that give you confidence. ये एग्जाम जो है ना इट इज एज मच अबाउट कॉन्फिडेंस एज मच अबाउट नॉलेज. नॉलेज है तुम सबके बाद. तुम व्हाट यू हैव टू रिमेंबर इज दैट दिस इज इनफ. अपने आप को बार बार याद दिलाओ कि जो मैंने पढ़ा है वो इनफ है. उसमें से 150 टू गेट 150 आउट ऑफ 300 दैट इज इनफ. क्योंकि योर पासिंग एंड फेलिंग विल डिपेंड on the easy questions. This I have told you multiple times and I'm telling you again. जो पास और फेल है ना वो डिफिकल्ट क्वेश्चंस पे नहीं डिपेंड करता है. इट विल डिपेंड ऑन द इजी क्वेश्चंस. सो हमें क्या करना है, हमें अपने ब्रेन को शांत रखना है एंड जो हमें आता है उसको सही करके आना है. वी मस्ट नॉट मेक सिली मिस्टेक्स. जो क्वेश्चन हमें पता है, जो इमेजेस हमें आते हैं, जो चीज़ हम पढ़ के गए हैं उसको हमें एग्जाम में जाके स्ट्रेस में गड़बड़ नहीं करना है. दैट्स द ओनली थिंग यू हैव टू डू. जो डिफिकल्ट क्वेश्चंस हैं उसके ऊपर हमारा पास फेल डिपेंड नहीं करता है क्योंकि वी आर नॉट गोइंग देयर टू गेट 300 आउट ऑफ 300. हम 300 में 300 लाने के लिए नहीं आए हैं यहाँ पे. हमें 300 में से 150 चाहिए पास होने के लिए. और वॉट एवर यू हैव लर्नड वो 150 के लिए मोर देन इनफ है. वॉट यू मस्ट नॉट डू इन दी एग्जाम इज तुम वो डिफिकल्ट क्वेश्चंस को देख के पैनिक नहीं करना और पैनिक करके जो पता है उसको गलत मत करना. डोंट डू दैट मच. जो डिफिकल्ट क्वेश्चंस है उनमें से गलत हो जाएंगे तो उससे फर्क नहीं पड़ता है. दे विल नॉट डिसाइड वेदर यू पास और यू फेल. द इजी क्वेश्चंस विल डिसाइड. एग्जाम के स्ट्रेस में इजी चीजें रॉन्ग हो जाती हैं, वो नहीं करना है हमें. So if whatever you know is more than enough to get pass marks. So that's why in this last 5 or 7 days that you have, just revise the high yield topics, revise the PYQs, look at the most important images and stay positive. That is very very important. Mindset जो है when we go into the exam in exam hall, it has to be positive. हमें we have to believe कि मुझे जो पता है उससे I am going to pass. अगर वो सेल्फ डाउट आने लगा ना कॉन्फिडेंस डाउन हो जाएगा. एंड डू नॉट पैनिक इन द एग्जाम. एग्जाम में प्लीज रिमेंबर कि ये जो क्वेश्चंस हैं वो बिल्कुल रैंडम है. तो अगर हमारे पास एक मॉड्यूल आता है जिसमें बहुत सारे क्वेश्चंस डिफिकल्ट हैं तो पैनिक मत करो. इट जस्ट मीन्स दैट ये सेट खराब है. लेकिन अगर एक सेट खराब है देर इज इट इज़ वेरी वेरी लाइकली कि एक सेट बहुत ईजी भी होगा क्योंकि क्वेश्चंस बस रैंडमली सिलेक्ट होके आए हैं ना. तो सारे क्वेश्चन डिफिकल्ट नहीं हो सकते. इट विल नॉट बी डिफिकल्ट. So that's why you have to make sure that you get the easy questions correct. And I'll tell you something, हर पेपर में ना around 120 questions doable होते हैं. They are. तो what you have to do is out of those 120 questions समझो अगर हमने 105 question correct कर लिया, बाकी 180 questions में से हम कुछ भी मार्क करें हमें 45 आ जाएगा. So the passing will depend, again I'm telling you, on the easy questions. So out of the 120 125 easy questions we have to get most correct. उसमें से अगर हमें 105 या 110 मिल जाता है, बाकी सारे questions में it doesn't matter, कुछ भी मार्क करो 45 आ जाएगा. Okay, so please be positive and revise the high yield stuff. चलो, let's go to the next topic, that is the extraocular muscles. So under the extraocular muscles, we know that we will be discussing the 4 rectus muscles. We will be discussing the 4 rectus muscles and the 2 oblique muscles. 4 rectus muscles and 2 oblique muscles. Now quickly, let us quickly revise the extraocular muscles and the yoke muscles. So extraocular muscles में which are the elevators? Which are the elevators of the eye? Which are the muscles which are responsible for elevation? Elevators are superior rectus and inferior oblique. If we have, which are the depressors of the eye? The depression, inferior rectus and superior oblique. Which are the intortors? Which are the muscles responsible for intorsion? It is we remember it as sin. Superiors are intortors. So the intortors are SO and SR. Which are the extortors? Extortion. So extortion is a function of IO and IR. तो इंटॉर्शन को हम याद रखते हैं as sin. Superiors are intorters. And which are, if we have to remember, which are the adductors and which are the abductors? The main adductor is medial rectus and it is minimally assisted by superior rectus and inferior rectus. MR, SR and IR, these are the adductors. And which are our abductors? The abduction is done by LR mainly and it is assisted by SO and IO. Medial rectus, superior rectus, inferior rectus. Lateral rectus, superior oblique and inferior oblique. These are our abductors. Now for one-liner question, they often ask what is the primary function? We have to learn the primary function of these 6 muscles. So which is the primary function? The primary function for superior rectus, the primary function is elevation. For inferior rectus, the primary function is depression. For superior oblique, the primary function is intorsion. And for inferior oblique, the primary function is extorsion. Please remember this. Remember that for the oblique muscles, the main function is torsional. The primary function is rotation. And we remember is that sin. Sin means superiors are intorters. So SO का primary function है intorsion and IO का primary function है extorsion. And for superior rectus, it is elevation and for inferior rectus, it is depression. Right? Now we come to the yoke muscles. The yoke muscles for the 6 cardinal positions of the gaze. We will learn the yoke muscles for the 6 cardinal positions of the gaze. So देखो, I'll just draw the positions quickly. So ये right है, ये left है. So I will start with dextroversion and levoversion. Dextroversion and levoversion. So for dextroversion, which are the muscles? Dextroversion. Dextroversion means I'm looking to the right side like this. Okay. So this is dextroversion. It's a binocular movement. Dextroversion matlab, see the right eye abducts and the left eye it adducts. Right eye abducts, left eye adducts. So right eye के लिए कौन सा muscle है? Lateral rectus. And left eye के लिए medial rectus. These are the yoke muscles for dextroversion. Dextroversion. Now let's look at levoversion. Levoversion matlab, levoversion means left eye abducts and right eye adducts. So left eye abducts means the muscle is left eye lateral rectus and right eye medial rectus. So levoversion means left eye abducts and right eye adducts. So left lateral rectus and right medial rectus. Then now we come to the ones which are more difficult to remember, that is dextro elevation and levo elevation. अब इसमें हमने क्या ट्रिक सीखा था? वी हैड लर्न दैट जब भी डेक्स्ट्रो या लीवो एलिवेशन पे क्वेश्चन आएगा, वी विल फर्स्ट राइट डाउन द नेम्स ऑफ द एलिवेटर्स. So we first write down superior rectus and inferior oblique, which are the elevators, SR and IO. And then we are going to apply the trick. The trick is the rectus muscle belongs to the side of the movement. This is the trick. Rectus muscle belongs to the side of the movements. So if it is dextro elevation means it is a right sided movement, and the trick is rectus muscle belongs to the side of the movement. So for dextro elevation it's a right sided movement, so rectus muscle belongs to the right side. So that's why it is right superior rectus, so automatically it will become left inferior oblique. So the rectus muscle belongs to the right side, so it will be right superior rectus and automatically left inferior oblique. अब सेम ट्रिक को लीवो एलिवेशन के लिए, लीवो एलिवेशन इज अ लेफ्ट साइडेड मूवमेंट विच मीन्स द रेक्टस मसल बिलोंग्स टू द लेफ्ट साइड, so therefore the other muscle belongs to the right side. ठीक है, नेक्स्ट है डिप्रेशन. सो डेक्स्ट्रो डिप्रेशन एंड लीवो डिप्रेशन, इसको भी द सेम ट्रिक से हम सॉल्व करेंगे, दैट इज डेक्स्ट्रो डिप्रेशन एंड लीवो डिप्रेशन. So we will first write down the names of the depressors. So which are the depressors? Which are the depressors? The depressors are inferior rectus and superior oblique. The depressors are inferior rectus and superior oblique, and we had learned the same trick. Rectus muscle belongs to the side of the movement. So dextrodepression is a right-sided movement. So rectus muscle is of the right side. So right inferior rectus and left superior oblique. Same levo depression के लिए, levo depression is a left-sided movement. So left inferior rectus and right superior. Left inferior rectus and right superior. याद आ गया सबको योक मसल्स? Yes everyone. This also last time nahi aaya. This is something which comes very often, but it has not come last time. So that's why like possibility. Okay. Now, because we are discussing muscles, let us quickly go through the different types of nerve palsies and their images. So let's come to third cranial nerve palsy. Third cranial nerve palsy में important चीजें क्या याद रखेंगे? What are the muscles which are affected? And what are the features that we get to see in third nerve palsy? In third nerve palsy, the first muscle that is affected is LPS. What is LPS? Levator palpebrae superioris. Levator palpebrae superioris. Please repeat. Okay, I'll just take a couple of minutes to go through these yoke muscles. So yoke muscles mein na, the problem is with dextro-levo elevation and dextro-levo depression. So when you get a question on dextro or levo elevation, first write down the names of the elevators. तो एलिवेटर्स कौन से हैं? SR and IO. तो हमने पहले SR IO लिख लिया. Then we apply the trick that the rectus muscle belongs to the side of the movement. So देखो the rectus muscle belongs to the side of the movement. अब अगर तुम dextro elevation देखोगे, हमने SR and IO लिख के रखा है. And because it's a right-sided movement, the rectus muscle is of the right side. So the superior rectus is of the right side. So that's why the inferior oblique automatically becomes of the left side. ये सेम चीज जो है हम लीवो एलिवेशन के लिए भी अप्लाई करेंगे. इन लीवो एलिवेशन देखो द रेक्टस मसल इज ऑफ द लेफ्ट साइड यहाँ पे, बिकॉज ये जो मूवमेंट है ये लेफ्ट साइडेड मूवमेंट है, so automatically other muscle belongs to the right side. Same for dextro and levo depression. We first write down the names of the depressors, that is IR and SO, and then we apply the same rule कि rectus muscle is on the side of the movement. तो देखो dextro depression में right sided movement है, so rectus muscle is of the right side. So inferior rectus right side का है, so automatically other muscle is of the left side. Levo depression में rectus muscle is of the left side, so inferior rectus left side का है, so automatically the other muscle belongs to the right side. चलो, नाउ लेट्स कम टू द नर्व पाल्सी. तो शुरू करते हैं विद थर्ड नर्व पाल्सी. थर्ड नर्व पाल्सी में क्या है? थर्ड नर्व पाल्सी में सबसे पहले विच आर द मसल? सबसे पहले लीड में एलपीएस. बिकॉज द एलपीएस इज अफेक्टेड वी विल हैव अ सीवियर टोसिस. सीवियर टोसिस ये देखो इस इमेज में भी दिख रहा है, somebody is pulling up the lid, somebody is pulling up the lid, मतलब टोसिस जो है वो सीवियर है. नेक्स्ट इट सप्लाइज द सीलियरी मसल. So ciliary muscle is also affected here. So ciliary muscle is affected, matlab there will be a loss of accommodation. Loss of accommodation. Third, next it affects the sphincter pupillae muscle. It affects the sphincter pupillae muscle. Sphincter pupillae muscle को affect करता है, meaning it is the constrictor muscle which is lost, so the pupil will be dilated. So you have a dilated and fixed pupil. Have a dilated and fixed pupil. Now comes the extraocular muscles. All the extraocular muscles are affected except the SO and the LR. Except the SO and the LR. तो ये जो SO है ना, it's the depressor, and जो LR है, it is an abductor. So these two muscles are still working. Now because these two muscles are still working, the SO will pull the eye down and the LR will pull the eye out. So therefore the eye is deviated downwards and outwards, जो you can see in the image. Downwards and outwards. So eye is deviated downwards and outwards. Right, so these are the features. तो इमेज में हमें क्या क्या दिख रहा है? We are seeing that somebody is pulling up the lid क्योंकि ptosis जो है वो severe है, and you can make out that the eye is down and out. So severe ptosis, there is a loss of accommodation because the ciliary muscle is affected. The pupil is dilated. The pupil is dilated and fixed. All the extraocular muscles are affected except the SO and the LR. All the extraocular muscles are affected except the SO and the LR, meaning SO and LR are still functioning. SO जो है वो depressor है and LR abductor है. So the eye is downwards and outwards. So quickly in your mind, just run over the features. Severe ptosis, loss of accommodation, dilated and fixed pupil, eye deviated downwards and outwards. This is third cranial nerve palsy. This is third cranial nerve palsy. On the same lines, चलो fourth cranial nerve palsy. Fourth cranial nerve जो है, it supplies the superior oblique. Superior oblique is the muscle that is affected. So therefore, what are the movements that are lost? The movements which are affected are, the two important movements of the SO are intorsion and depression. So the two important movements of the SO, they are intorsion and depression. So देखो, if the intorsion is lost, so इस eye को सोचो, if the intorsion is lost, the eye will be extorted and it will be elevated. So there is extortion and there is elevation. So extorsion with hypertropia, this is the squint. Because of the squint, the patient has a diplopia which is essentially vertical and also torsional. So vertical diplopia means two images, one on top of each other, and they are also tilted. The diplopia is maximum in down gaze. Why is it maximum in down gaze? Because the SO is a depressor. Because the SO is a depressor, and therefore, but the SO is a depressor, therefore the maximum problem is in down gaze. When the patient tries to look down, then he has maximum problem, and therefore the activities that are affected are reading, writing and climbing down the stairs. Reading, writing and climbing down the stairs. Okay, and what is the head posture? The head posture is a head tilt to the opposite side. If you remember, I had told you that this eye is already extorted. So if you tilt the head to the same side, it will become worse. So that's why you tilt the head to the other side to partly overcome the extortion. So ये eye जो है वो already extorted है. So when you tilt the head to the same side, it becomes worse. But if you tilt the head to the other side, then the extortion gets corrected partly. So it is corrected by tilting the head to the other side to overcome the extortion. So see, ये सबसे complicated है. I'll just go over it once more, then I will tell you the trick. कौन सा word इसमें key word होता है? जैसे fourth nerve palsy, the muscle is SO, superior oblique. Its functions are intorsion and depression. Now, because the intorsion is lost, the eye is extorted. Because the depression is lost, the eye is elevated. The diplopia is vertical and torsional, and it is maximum in down gaze because SO is a depressor. The activities affected are reading, writing, and climbing down the stairs, and there is a head tilt to the opposite side. There is a head tilt to the opposite side. So यहाँ पे ना usually the key word in the question is that they will say that the patient has problem in reading, writing, that is there is jumbling of letters while reading or writing, or they will say that the patient has difficulty in climbing down the stairs, and they will mention that the patient has a head tilt. तो इस क्वेश्चन में ये चीजें होती हैं, ये दोनों चीजें अगर क्वेश्चन में मेंशन्ड है तो you can try thinking in terms of SO palsy. These are the key words. So the key words are these, that there is a problem in climbing down the stairs, there is a jumbling of letters while reading and writing, and the patient has a head tilt. ये words अगर mentioned है तो then think of SO palsy and then try to apply the question. ठीक है, so this is fourth nerve palsy. Next is sixth nerve palsy. The muscle that is affected here is lateral rectus. What is the movement that is lost? The movement that is affected, is abduction. Now, because the abduction is affected, so let us look at this eye. Suppose the abduction is lost. So the eye will be in a position of esotropia, that is convergence squint. There is diplopia, and the diplopia is maximum on the same side. The diplopia is maximum on the same side, and therefore there is a face turn to the same side. The maximum diplopia is on the same side, so there is a face turn to the same side. ठीक है? Now, ये तीनों में I'll just go over the important points once more. So these three, like in case of third nerve palsy, when the question comes, the key words to look for are severe ptosis, eye is down and out, dilated and fixed pupil. ये तीन चीजें question में ढूंढो. Severe ptosis, eye down and out, dilated and fixed pupil. Look for these things in the question. For fourth nerve palsy, as I told you, important words to search for the question is there is jumbling of letters while reading or writing, the patient has difficulty in climbing down the stairs, and head tilts to the opposite side. These are the key words. Jumbling of letters while reading and writing, difficulty in climbing down the stairs, and head tilt to the opposite side. ये चीजें mentioned होती हैं इसमें. In sixth nerve palsy, the question will usually say the patient has esotropia, face turned to the same side. Esotropia and face turned. So if it says esotropia in the left eye, it will say esotropia in the left eye with a face turned to the left side. Okay, so esotropia and face turned to the same side. These are the key words for sixth nerve palsy. अब इस image को देख लो. The first image, what is the first image? This is the image of the primary position. This is the primary position. In the primary position, see the right eye is normal and look at the left eye. The left eye is showing ESO. The left eye is showing esotropia. Now here, this is actually the left gaze. This is a picture of the left gaze. So when the patient is looking to the left side, this eye is moving, but this eye is not moving. So in the left eye, there is a limitation of abduction. The left eye should have actually moved to this corner. तो इस आई को इधर मूव होना चाहिए था, पर वो मूव नहीं हुआ है. This eye should have come here, but it has not come. Why? Because there is a limitation of abduction. So there is a limitation of abduction in the left eye. So this is left-sided sixth nerve palsy. There is a left-sided sixth nerve palsy. Okay, so this is about third, fourth and sixth nerve palsy. ये याद आया क्या सबको? I hope you have been able to recall this. चलो 2-3 questions I'll just tell you. यहाँ से 2-3 चीजें commonly पूछते हैं. That is the most common cause of third nerve or sixth nerve palsy. The most common cause of third nerve or sixth nerve palsy is microvascular infarct. It is microvascular infarct. The most common cause of third nerve or sixth nerve palsy is microvascular infarct, that is causes like diabetes, hypertension and hyperlipidemia. Most common cause of third nerve or sixth nerve palsy is microvascular infarct like diabetes, hypertension or hyperlipidemia. Now एक और चीज जो पूछते हैं, what is the special feature of microvascular cause of third nerve palsy? So if it is a third nerve palsy because which is caused by microvascular cause of third nerve palsy, इसका special feature क्या है? Microvascular cause of third nerve palsy, it may be pupil sparing. It may be pupil sparing. So which means that यहाँ पे अगर हमें पूछते हैं pupil sparing third nerve palsy, what is the cause? The pupil sparing third nerve palsy, the cause is microvascular infarct. This I had told you in the previous session also, but I just want to repeat it, that the most common cause of third nerve and sixth nerve palsy is microvascular infarct, that is diabetes, hypertension, hyperlipidemia. And microvascular cause of third nerve palsy may be pupil sparing. तो ये क्वेश्चन कैसे पूछते हैं? दे आस्क इट एज pupil sparing third nerve palsy is seen in. Pupil sparing third nerve palsy is seen in microvascular infarct, that is causes like diabetes, hypertension and hyperlipidemia. ठीक है? Now, next on the same lines is Horner syndrome. Now, Horner syndrome, what is the other name for Horner syndrome? The other name for Horner syndrome is oculosympathetic palsy. Oculosympathetic palsy. So, it is a paralysis of the sympathetic nerve supply to the eye. And यहाँ पे what are the muscles affected? The muscles which are affected are the Muller's muscle of the lid. Now, because the Muller's muscle of the lid is affected, that's why you have a mild ptosis. That's why you have a mild ptosis. So, इसमें देखो, look at the right eye. There is a mild ptosis. Next, what is affected? The dilator pupillae muscle is affected. Now, because the dilator muscle is affected, the pupil is constricted. So, the dilator pupillae is affected. So, therefore, there is miosis. The dilator pupillae is affected, so there is miosis. And the sweat gland is affected. The sweat gland is affected, and therefore there is anhidrosis. Anhidrosis. Mild ptosis, miosis, and anhidrosis. This is Horner syndrome, also called as oculosympathetic palsy. So abhi I have discussed this previously also. देखो, whenever in a question there is ptosis, तो दो चीजें प्राइमरीली इंस्टेंटली याद आना चाहिए कि जब भी किसी क्वेश्चन में टोसिस मेंशन्ड हो तो दो चीजें इंस्टेंटली याद करना है, थर्ड नर्व पाल्सी या फिर हॉर्नर. यूजुअली इन दोनों में से कोई ही आंसर होता है. सो इफ इट इज अ क्वेश्चन ऑन थर्ड नर्व पाल्सी, व्हाट आर द की वर्ड्स टू लुक फॉर? आई टोल्ड यू द की वर्ड्स आर सीवियर टोसिस, eye down and out, dilated and fixed pupil. So severe ptosis, eye down and out, and dilated and fixed pupil, matlab third nerve palsy. But if the question says that it is a mild ptosis and there is miosis, then the answer is Horner. Mild ptosis with miosis, the answer is Horner. Right? So this is about the muscles and the nerve palsies. Now let's come to one very important part. ये भी पिछले एग्जाम में नहीं आया है, so which is was very surprising. That is the visual pathway. Visual pathway से हमेशा कुछ ना कुछ आता ही है, बहुत rarely ऐसा हुआ है कि नहीं आया है. And last exam was one of them. So I'm just hoping कि this time we'll get something from here. So चलो, lesions of the visual pathway. So what are the site of the lesion? Number one is lesion in the optic nerve. Lesion in the optic nerve. Lesion in the optic nerve, what is the defect that we expect? Lesion in the optic nerve, it is monocular blindness. Lesion in the optic nerve, it is monocular blindness. Next is lesion in the optic chiasma. Lesion in the optic chiasma. So what are the lesions in the optic chiasma? First of all, the lesions in the optic chiasma, it can be either pituitary adenoma, which tract and optic radiation. These are commonly affected by vascular infarcts. Optic tract and optic radiation, they are commonly affected by vascular infarct. And what do we get here? If optic tract or optic radiation is affected, we will get a homonymous hemianopia. In this case, we get homonymous hemianopia. Optic tract and optic radiation, if they are affected, we get homonymous hemianopia. Right? And the last one is lesion in the occipital cortex. The last one is lesion in the occipital cortex. Occipital cortex lesion means it's a PCA infarct. It is an infarct in the territory of the posterior cerebral artery. Sorry, nahi sunai de raha hai kya? I'll just be a little louder. Yeah. Am I audible now? Is the voice audible now? Hello? Hello? Yeah, okay. Okay, so now we were talking about the optic tract and optic radiation. Optic tract and optic radiation, these are commonly affected by vascular infarcts. And when there is a lesion in the optic tract or optic radiation, what do we get? We get a homonymous hemianopia. And the last one is occipital cortex. Occipital cortex, the lesion that we expect is an infarct in the territory of the PCA, posterior cerebral artery. And here, what do we get? इसको सिर्फ होमोनिमस, इसको सिर्फ मैक्युलर स्पेयरिंग करके बाय हार्ट मत करो. इट इज होमोनिमस हेमियानोपिया विथ मैक्युलर स्पेयरिंग. It is homonymous hemianopia with macular sparing. Homonymous hemianopia with macular sparing. So occipital cortex or lesion in the PCA, posterior cerebral artery. Yeah, I will just repeat it once more. We'll just go through it one more time. So chalo, what did we learn or what did we revise? Sorry, that these are the 5 main lesions that come in the exam. Lesion in the optic nerve. Lesion in the optic nerve causes monocular blindness. Lesion in the optic chiasma. So what are the lesions in the optic chiasma? Optic chiasma may be affected by commonly by pituitary adenoma, less commonly by craniopharyngioma, and also by aneurysms. So this is bitemporal. It causes bitemporal hemianopia, which is also called as heteronymous hemianopia. Then lesion number 3 and 4 are lesion in the optic tract and optic radiation. Optic tract and optic radiation, they are affected by vascular infarct. So if there is a lesion in the optic tract or optic radiation, you end up with a homonymous hemianopia. The last is lesion in occipital cortex. Lesion in occipital cortex means that it is an infarct in the territory of the posterior cerebral artery, and here we have homonymous hemianopia with macular sparing. Right? अब ये है direct question. If the question comes as there is a patient who has a pituitary adenoma pressing on the visual pathway, what is the defect? So देखो pituitary adenoma मतलब which part of the visual pathway is it pressing? It is pressing the optic chiasma. So therefore the answer to this will be bitemporal hemianopia. Or the question may say that a patient suddenly suffers from a PCA infarct. What is the expected defect in this patient? So PCA infarct matlab it will affect the occipital cortex. So the lesion will be homonymous hemianopia with macular sparing. Right? तो ये हो गए direct questions. So optic nerve के लिए monocular blindness, chiasma के लिए bitemporal hemianopia और heteronymous hemianopia, optic tract और optic radiation homonymous hemianopia, occipital cortex homonymous hemianopia with central or macular sparing. Now the same thing लेकिन उल्टा, the image is given to us and we have to identify the site of the lesion. तो देखो ये है. So जब भी ना you get a lesion, always mark out the right left. और यहाँ पे I had told you that that always ये जो right और left है, that is according to our own right hand and left hand. This is only for images of the visual pathway. Normally ना जब हमें कोई भी image मिलता है तो हम इसको right mark करते हैं और इसको left mark करते हैं. This is how we mark out right and left. Right, but in pictures of the visual pathway जिस तरफ मेरा right hand है उसी को right mark करना है and जिस तरफ left hand है उसको left mark करना है. But this is only for images of the visual pathway. And also mark out the inner part as nasal and the outer part as temporal. Now why am I telling you this? Because in the stress of the exam, I don't know why, जब भी कोई image आता है वो instantly students को हमेशा bitemporal hemianopia ही लगता है. But to minimize this mistake, mentally mark out the nasal and the temporal. So देखो inner part जो है वो nasal है, outer part is temporal. So in this case, you will see that the temporal field of both eyes are lost. So ये क्या है? This is bitemporal hemianopia. And bitemporal hemianopia means site of the lesion is the optic chiasma. The site of the lesion is the optic chiasma. Bitemporal hemianopia means site of the lesion is the optic chiasma. Next, look at the next one. This is right and this is left, right? So देखो, this inner part is nasal, outer part is temporal. So nasal field of one eye and the temporal field of the other eye are lost. The nasal field of one eye and the temporal of the other eye are lost. So this is called as homonymous hemianopia. अब homonymous hemianopia मतलब either the optic tract or the radiation will be affected, but most cases में it is the optic tract. So homonymous hemianopia, site of the lesion is the optic tract. Next is this. Have a look at this image. इसमें भी देखो, let's mark out the right and the left, the nasal and the temporal. यहाँ भी you will see that the nasal field of one eye and the temporal of the other are affected, but the central part is clear. So this is homonymous hemianopia with macular sparing. Homonymous hemianopia with macular sparing means site of the lesion is the occipital cortex. Homonymous hemianopia with macular sparing, the site of the lesion is the occipital cortex. So this all of you know. I will just show you two more images. Just revise these two images also. That look at this. यहाँ पे देखो, this particular part is, it is a homonymous hemianopia, but only one quadrant is involved. It's an incomplete homonymous hemianopia where only the upper quadrant is involved. This is called as pie in the sky defect. And pie in the sky defect means site of the lesion is the temporal lobe of the brain. Pie in the sky lesion defect means that the site of the lesion is the temporal lobe of the brain. Okay, and look at this one. Here also you have a homonymous hemianopia, but it is only inferior. So this is called as pie on the floor. And pie on the floor defect means that the site of the lesion is the parietal lobe. The site of the lesion is the parietal lobe. I'll just go over these images once more. इसको wrong नहीं करना है. ठीक है, look at the first image. Whenever you get images, mark out the nasal and the temporal. The inner part is nasal, the outer part is temporal. So first image में देखो, the temporal of both eyes is black. So that is a bitemporal hemianopia. So the site of the lesion is the optic chiasma. Look at the next picture. Next picture में देखो, the nasal of one eye and the temporal of the other. This is blacked out. Nasal of one eye and the temporal of the other means homonymous hemianopia. Homonymous hemianopia में site of the lesion is the optic tract or radiation, but more commonly it is the optic tract. अब ये लास्ट वाला पिक्चर देखो, इसमें भी nasal of one eye and the temporal of the other are lost, but central part is clear. So this is also a homonymous hemianopia, but with macular sparing. So site of the lesion is the occipital cortex. Next, these two are, they are less likely to be asked, but I don't want you to leave out anything from this topic. अब ये दोनों पिक्चर्स जो है इनको देखो, इन बोथ दीज पिक्चर्स यू विल सी दैट एक में अपर क्वाड्रेंट इन्वॉल्व है, एक में लोअर क्वाड्रेंट इन्वॉल्व है. जिसमें अपर क्वाड्रेंट इन्वॉल्व है वी कॉल इट पाई इन द स्काई, साइट ऑफ द लीशन इज द टेम्पोरल लोब. एंड जिसमें लोअर क्वाड्रेंट इन्वॉल्व है ना वी कॉल इट एज पाई ऑन द फ्लोर एंड द साइट ऑफ द लीशन इज द parietal lobe. So pie in the sky, temporal lobe, pie on the floor, parietal lobe. चलो, so these are the lesions of the visual pathway. याद आ गया ये सबको? यस ना? यस बच्चों, याद आ गया? चलो, लेट्स गो टू द नेक्स्ट वन. चलो, आई एम ग्लैड दैट यू पीपल वर एबल टू रिकॉल. राइट एंड लेफ्ट. ओके, आई जस्ट गो थ्रू इट वंस मोर. जो राइट एंड लेफ्ट वाला पार्ट है ना, सी ऑलवेज मार्क द राइट एंड लेफ्ट अकॉर्डिंग टू योर ओन राइट हैंड एंड लेफ्ट हैंड. एंड सी वेयर इज द ब्लैकनिंग. जो बाइटेम्पोरल हेमियानोपिया है उसमें राइट लेफ्ट नहीं होता. Why? Because bitemporal hemianopia is seen by lesion in the optic chiasma and it's a midline structure. So for bitemporal hemianopia, right optic chiasma, left optic chiasma नहीं होता है, because bitemporal hemianopia is caused by lesion in the optic chiasma which is a midline lesion. But homonymous hemianopia can be classified as right or left. So यहाँ पे look at this image. In this image, you will see that the blackening, the nasal half of the left eye and the temporal half of the right eye are lost. है ना? So if the nasal half of the left eye and the temporal half of the right eye are lost, the blackening is on the right hand side. सोच के देखो, the nasal half of the left eye and the temporal half of the right eye. So nasal half of left eye, temporal half of the right eye are both on the right hand side. So this is called as right homonymous hemianopia. And right homonymous hemianopia means site of lesion is the left optic tract. समझ आया? So see, if you look at homonymous hemianopia, see the nasal half of the left eye and the temporal half of the right eye are lost. So the blackening is on the right hand side. So it's right homonymous hemianopia. Site of lesion is the left optic tract. Yes. Now in this image, yeah, sorry, this is right and this is left. This is right and this is left. Thank you. So once again, see the darkening is on the right hand side. So it's a right homonymous hemianopia with macula sparing, and therefore the site of the lesion is the left occipital cortex. Why? Because the blackening is on the right hand side. So because the blackening is on the right hand side, it is a right homonymous hemianopia with macula sparing, and so site of lesion is the left occipital cortex. Yes, thank you for pointing it out. So see, even after doing it for so many years, it goes wrong. So you have to be very, very careful in the exam. Right and left पूछना नहीं चाहिए, but अगर पूछते हैं याद रखो that always in case of lesions of visual pathway, right and left has to be marked according to our own right hand and left hand. तो ये हमारा right है, ये left है, ठीक है? Good, thank you. Let's now go to the next question. The next question is the pupillary reflex pathways. Next topic. So pupillary reflex pathway. So pupillary reflex pathway, what is the pupillary reflex? Let us first start with the light reflex. The light reflex pathway is what? The light reflex pathway, what is the afferent? So quickly let us, light reflex means that when I put light in one eye, the pupil constricts in both eyes. Okay, the pupil constricts in both eyes. So what is the afferent? The afferent is the optic nerve, the optic chiasma and the optic tract. The optic nerve, the optic chiasma and the optic tract. What is the center? The center is the pretectal nucleus in the dorsal midbrain. So this is the center for the light reflex. The pretectal nucleus in the dorsal midbrain. The pretectal nucleus which is located in the dorsal midbrain. And what is our efferent? The efferent is bilateral. The efferent is bilateral. Bilateral, we start with this. This is called as the Edinger-Westphal nucleus. EW nucleus, that is the Edinger-Westphal nucleus. And the Edinger-Westphal nucleus, this is the parasympathetic nucleus of the third nerve. So therefore, see the nerve that is coming out from here, ये कौन सा nerve है? This is the third nerve. And the third nerve relays in this structure, which is your ciliary ganglion. And beyond the ciliary ganglion, we have this set of nerves which are called as the short ciliary nerves. So the efferent is the EW nucleus, then the third nerve, then the ciliary ganglion, then the short ciliary nerves. Then the short ciliary nerves. Okay, so what is the afferent? The afferent is the optic nerve, optic chiasma, optic tract. The center, it is the pretectal nucleus in the dorsal midbrain. The efferent is bilateral. Why bilateral? Because even when I put light in one eye, the pupil has to constrict in both eyes. So bilateral EW nucleus, that is Edinger-Westphal nucleus. Then the third nerve, then ciliary ganglion, then short ciliary nerves. And what kind of reflex is this? This is a parasympathetic reflex. Why are we saying it is a parasympathetic reflex? Because the EW nucleus is the parasympathetic nucleus of the third nerve. Okay, so it's a parasympathetic reflex. Right, now let's come to what are the near reflex. What are the components of the near reflex? The components of the near reflex are accommodation, convergence and meiosis. Near reflex ka pathway yaad karo. Near reflex mein we had learned that the pathway is what? The pathway is the afferent is not very clear. The center, it is located in the ventral midbrain. तो यहाँ पे देखो pretectal nucleus is in the dorsal midbrain, but near reflex के लिए the center is in the ventral midbrain and the efferent is the same. So these are the two reflexes in which the pupil participates. The first one is the light reflex. Light reflex mein the afferent is optic nerve, optic chiasma, optic tract. The center is the pretectal nucleus in the dorsal midbrain. The efferent is bilateral EW nucleus, then third nerve, then ciliary ganglion, then short ciliary nerves. The effector muscle for this reflex is the sphincter pupillae and the type of reflex is parasympathetic. Okay, now what are the defects of the pupillary pathway? The defects of the pupillary pathway, the first one is the RAPD, relative afferent pupillary defect. And the other name is Marcus Gunn pupil. The site of the lesion is the optic nerve. And it is tested clinically by what? It is tested clinically by the swinging flashlight test, which you see in this image. So here always the light, it starts with which eye? With the normal eye. So here when you put light in the normal eye, both eye pupils constrict. When we put light in the normal eye, then both eye pupils constrict and this is the normal response. But when you move the light from the normal eye to the abnormal eye, then both eye pupils will dilate. Then both eye pupils dilate and this is called as paradoxical dilatation. So this is right eye RAPD. So if we are asked that what is the site of the lesion in this case, it is the right sided optic nerve. Okay, so this is Marcus gun pupil or relative afferent pupillary defect, where the site of the lesion is the optic nerve. It is tested clinically by swinging flashlight test. When we put light in the normal eye, both eye pupils constrict. So here the left eye is normal, and when you move the light from the left to the right eye, then both eye pupils dilate. So here the right eye is showing RAPD and the site of the lesion is the right-sided optic nerve. Next, Wernicke's hemianopic pupil. Wernicke's hemianopic pupil is actually a theoretical concept, and the site of the lesion is the optic tract. The third one, light near dissociation. Light near dissociation means what? Light reflex is absent and the near reflex is present. This is seen when there is a damage to the pretectal nucleus. And where is the pretectal nucleus? It is in the dorsal midbrain. So if there is a damage to the pretectal nucleus in the dorsal midbrain, we get this light near dissociation, and here the light reflex is absent but the near reflex is present. The typical example of this is the Argyll-Robertson pupil that we see in neurosyphilis. Argyll-Robertson pupil in neurosyphilis. The next one is AD stonic pupil, the site of the lesion, postganglionic nerves. The postganglionic nerves are what? They are the short ciliary nerves. The postganglionic nerves means the nerves beyond the ciliary ganglion, that is the short ciliary nerves. So here both the light and the near reflexes are affected, and therefore the pupil on that particular side, it is large and dilated. And so what you end up with is anisocoria. What is anisocoria? Anisocoria means that there is a difference in pupillary size between the two eyes. So one side has a normal pupil, the other side has a dilated pupil. So there is a difference in pupillary size, which is called as anisocoria. So this is your AD stonic pupil. So these are the defects of the pupillary reflex pathways. याद आ गया ये? I hope everybody has recalled this. Defects of the pupillary pathway. Chalo. Now, these are the important topics that I wanted to discuss in neuroopthal. Ab we will discuss a few topics from retina. So let's come to the important topics from retina. The first one is CRAO, Central Retinal Artery Occlusion. Central Retinal Artery Occlusion में this usually will come as a case-based question. So case-based question में देखो, how will the patient present? The patient presents with a sudden, painless and very severe loss of vision. So when you examine, the patient's visual acuity is very poor. That is, it will be counting fingers at 1 meter or half meter. The anterior segment is normal and the retina shows cherry red spot. So what is cherry red spot? This is the cherry red spot. This is a very commonly asked image in the exam. कैसे identify करेंगे? See, the whole retina appears pale and edematous. The retina is edematous and pale. The retina is edematous and pale, and only the fovea it appears bright. Edematous and pale retina, and the fovea it appears to be bright. Okay, so this is CRAO, Central Retinal Artery Occlusion. Now, this is an ocular emergency. Why it is an ocular emergency? Because it has to be treated within the initial few hours of onset. And if it is not treated, the patient will go blind. But unfortunately, the treatment options available are limited. What is the idea? The idea is that you have to suddenly lower the IOP. So when there is a sudden lowering of IOP, it creates a jerk effect, and this jerk may help to dislodge the thrombus. So what are the methods to do this? One is vigorous ocular massage. When you massage the eye vigorously, the aqueous humor flows out and causes a sudden drop in IOP. Next, intravenous mannitol, and third is paracentesis. Paracentesis means aspiration of aqueous humor. So these are the methods: massage, mannitol, and paracentesis. Apart from this, we can have inhalation of carbogen. Why inhalation of carbogen? Because carbogen is considered to be a vasodilator. And it may help to improve the blood supply to the optic nerve. So blood supply to the retina. It is a vasodilator and may help to improve the blood supply to the retina. But these methods are very empirical, and therefore, despite everything, the prognosis of arterial occlusions is poor. So, massage, mannitol and paracentesis and inhalation of carbogen. These are the treatment options for CRAO. ये ना अब तक they used to give it like this: a patient presents with sudden painless severe loss of vision, and they used to give the picture of this cherry red spot, and they used to ask what is the diagnosis. But it is more probable that this time if it comes, they will give the image and they will ask what is the treatment. So treatment options को ध्यान से पढ़ो. It's an emergency. The treatment options are massage, mannitol and paracentesis, which cause sudden lowering of IOP, or inhalation of carbogen, because carbogen is a vasodilator and may improve blood supply to the retina. But despite all this, the prognosis is poor. On the same lines, next, I will go to the next one, that is CRVO, Central Retinal Vein Occlusion. Here also the patient presents with the complaints are the same: sudden and painless decrease in vision. But the visual acuity is not as bad as it is in CRAO. So, yahan pina, if it comes as a case-based question, it will say that the patient presents with decrease in vision. The visual acuity may be as bad as 3 by 60 or 2 by 60, or it may be as good as 6 by 12, 6 by 9 also. The anterior segment is also normal, but the fundus or the retina looks like this. So what is this fundus appearance called? It is called as splashed tomato appearance. That means that the whole fundus is full of hemorrhages, extensive intraretinal hemorrhages. The whole fundus is full of hemorrhages. So you have extensive hemorrhages throughout the retina. So now let's come to the treatment. So देखो treatment में the good part about venous occlusions, if you remember, I had told you that most of the cases are mild cases. Most of the cases are mild cases, and the mild cases, they resolve spontaneously over 6 months. Most of the cases are mild cases and they resolve spontaneously over 6 months. Therefore, for the mild cases, the treatment remains only observation, that is, wait and watch. Careful observation or wait and watch is the treatment. The problem is with the severe cases, but fortunately, that's just about 10 to 20%. The severe cases are called as ischemic CRVO. Why? Because they give rise to retinal ischemia. And when there is ischemia, what will happen? There will be increase in a mediator, that is VEGF. And because of increase in VEGF, there will be neovascularization. And therefore, for the severe cases, what are the treatment options? The treatment options for the severe cases which give rise to neovascularization are laser photocoagulation, you can give intravitreal anti-VEGFs or intravitreal steroids. Intravitreal anti-VEGF or intravitreal steroids. Okay, so what is the prognosis of venous occlusions? See, prognosis of venous occlusions is good only because most of the cases they end up being mild and they resolve by themselves over a period of 6 months. Only for about 20% cases which can become ischemic, you may need to give these treatment options, that is laser, intravitreal, anti-VEGFs or steroids. Now, the thing is that these severe cases, if untreated, what will happen to them? If the severe cases are left untreated, then they will progress to end stage NVG. They will give rise to neovascular glaucoma over a period of 3 months. And this neovascular glaucoma is called as 100-day glaucoma. This is also PYQ. So untreated ischemic CRVO progresses to end stage neovascular glaucoma over a period of 3 months. 3 months is roughly 90 to 100 days. It's 90 days, but it is called as 100-day glaucoma. So the severe cases, that is the ischemic CRVO left untreated, progresses to end-stage neovascular glaucoma, and that's called as 100-day glaucoma. याद आ गया treatment of CRAO and CRVO? I hope you will be able to answer the questions from here. I wanted to discuss the important things so that you feel confident. Yes, बच्चों याद आ गया? चलो, let's go to the next topic from retina, that is retinoblastoma. Retinoblastoma by far is one of the most important topics that is there. So retinoblastoma, what are the important things to remember? Everything about retinoblastoma is important to remember actually. Retinoblastoma, this is the most common intraocular malignancy in children. Most common intraocular malignancy in children. It is the most common intraocular malignancy in children. The gene that is responsible is RB gene. The location of the gene is 13q14. The age of presentation is around 1 to 2 years. Roughly, they say 1.5 years or 18 months. And the most important presenting feature is what you see in this image, that is leukocoria or white pupillary reflex. So look at this image, look at the left eye here. The left eye is showing white pupillary reflex or leukocoria, and that is the most important or the most common presenting feature. Right, now let us come to what is the treatment. What is the treatment for retinoblastoma? What are the treatment options? So retinoblastoma mein na, there are three types of questions which come. First is if the question is on intraocular retinoblastoma. Intraocular retinoblastoma means that it is confined to the eyeball. Now it is going to depend on whether it is a small mass or it is a large mass. If the mass is large, meaning it occupies more than 50% of the globe, then the treatment for this is enucleation. अब enucleation का क्या मतलब है? Enucleation means removal of the globe or removal of the eyeball with a portion of the optic nerve. Removal of the globe with a portion of the optic nerve. Okay, by the way, what is the most common route of spread? The most common route of spread is direct spread via the optic nerve. The most common route of spread is direct spread via the optic nerve. This is also PYQ, most common route of spread. The most common route of spread is direct spread via optic nerve. It is direct spread via the optic nerve, and that is why see in enucleation you remove the globe with a portion of the optic nerve. So intraocular retinoblastoma, more than 50% of the globe, the treatment is enucleation, that is removal of the globe with a portion of the optic nerve. But if it is intraocular retinoblastoma occupying less than 50% of the globe, then the treatment is focal therapy. Focal therapy means that you treat the tumor without removing the eyeball. And the options of focal therapy are, we have the option of laser therapy, we have the option of cryotherapy, and we have the option of brachytherapy. तो ये क्वेश्चन आता है यहाँ पे फॉर इंट्राऑक्यूलर रेटिनोब्लास्टोमा. नेक्स्ट क्वेश्चन जो यहाँ से आता है दैट इज रेटिनोब्लास्टोमा विथ मेटास्टैसिस. यही पूछते हैं व्हाट इज द ट्रीटमेंट फॉर रेटिनोब्लास्टोमा विथ मेटास्टैसिस. मेटास्टैसिस मीन्स इट हैज स्प्रेड टू द डिस्टेंट ऑर्गन्स एंड देयरफॉर द ट्रीटमेंट फॉर दिस इज palliation, palliative chemotherapy. Now another PYQ from here is, what are the chemotherapy drugs which are used here? The chemotherapy drugs which are used here, it is remembered as VEC, that is vincristine, etoposide and carboplatin. Vincristine, etoposide and carboplatin. So retinoblastoma with metastases, the treatment is palliative chemotherapy, and the chemotherapy drugs are VEC, vincristine, etoposide and carboplatin. Next, when we do an enucleation for retinoblastoma, we send the specimen for histopath. And when you send the specimen for histopath, देखो ये भी PYQ है, you will see that the tumor cells are arranged around the central lumen. And this arrangement is called as the rosette pattern. And the important rosette that we have to remember for retinoblastoma is this one. This is called as the FW rosette, that is the Flexner-Winter-Steiner rosette. The FW rosette or the Flexner-Winter-Steiner rosette. Right? समझ याद आ गया ये रेटिनोब्लास्टोमा मोस्ट कॉमन इंट्राक्युलर मैलिग्नेंसी इन चिल्ड्रन. अब याद करो यहाँ पे रिसेंटली एक PYQ था, व्हाट इज द मोस्ट कॉमन इंट्राक्युलर मैलिग्नेंसी इन अडल्ट्स. The most common intraocular malignancy in adults is choroidal metastases. The most common intraocular malignancy in adults is choroidal metastases. Choroidal metastases. Most common intraocular malignancy in children is retinoblastoma. Most common intraocular malignancy in adults is choroidal metastases. Let's go to the next one. So these are the important topics that I wanted to go through in retina. Ab chalo, we'll just go through a few important topics, a few important images in cataract. Chalo, look at these images. What are these images? ये जो image है सबसे पहला है, this is an image of snowflake cataract. This is an image of snowflake cataract. Where do we get snowflake cataract? Snowflake cataract, this is seen in diabetes mellitus. This is seen in diabetes mellitus and this is caused by the accumulation of sorbitol. All these are PYQs. This is caused by accumulation of sorbitol. Next one, have a look at this image. This image is the oil droplet cataract. This image, this is the oil droplet cataract. An oil droplet cataract कहाँ पे होता है? It is seen in galactosemia. Oil droplet cataract is seen in galactosemia. Next one is this. This is called as the sunflower cataract. This is called as the sunflower cataract. Sunflower cataract is seen in Wilson's disease. Sunflower cataract, this is seen in Wilson's disease. Next, have a look at this. This is rosette cataract. This is rosette cataract. Rosette cataract, this is seen in case of blunt trauma. This is seen in case of blunt trauma. Rosette cataract, this is seen in case of blunt trauma. Next one, this is called as Christmas tree cataract. This is Christmas tree cataract. And where do we get to see Christmas tree cataract? This is seen in myotonic dystrophy. Christmas tree cataract, this is seen in myotonic dystrophy. So these are a few important cataract images which may come in the exam. अब मुझे बताओ, what is the most common drug associated with cataract? Which is the most common drug associated with cataract? The most common drug that is associated with cataract is systemic steroids. The most common drug that is associated with cataract is systemic steroids, and this steroid-induced cataract is typically posterior subcapsular cataract. All these are PYQs. It is a posterior subcapsular cataract. The most common drug associated with cataract is systemic steroid, and this steroid-induced cataract is a posterior subcapsular cataract. Is a posterior subcapsular cataract. अब चलो कुछ इंपॉर्टेंट चीजें रिवाइज करते हैं फ्रॉम कैटरैक्ट विच कैन कम एज केस बेस्ड क्वेश्चंस. सो फॉर एग्जांपल न्यूक्लियर कैटरैक्ट. Nuclear cataract which is seen in elderly people. Nuclear cataract में what are the important things to remember about nuclear cataract? What are the important things to remember about nuclear cataract? In nuclear cataract, there is myopia. There is myopia in an elderly patient, which is called as index myopia. And because of the index myopia, there is a sudden improvement in near vision. Because of index myopia, there is a sudden improvement in near vision. Sudden improvement in near vision, and that's called as second sight. Sudden improvement in near vision, which is called as second sight. Next, जो important है, that is posterior subcapsular cataract. Posterior subcapsular cataract. For posterior subcapsular cataract, two important things to remember. For posterior subcapsular cataract, two important things to remember. What are they? For posterior subcapsular cataract, it causes difficulty in vision in bright light. Difficulty in vision in bright light. Difficulty in vision in bright light. And another feature about posterior subcapsular cataract that we need to remember is it causes glare. Glare due to scattering of light. Glare due to scattering of light. Next पूछते हैं. So this is about posterior subcapsular cataract, difficulty in vision in bright light when the pupil is constricted and glare due to the scattering of light. So nuclear cataract हो गया. Next posterior subcapsular. Next cataract that is asked is mature intumescent cataract. Mature intumescent cataract. In a mature intumescent cataract, what happens? A mature intumescent cataract, it absorbs water and it swells, and the swollen lens pushes the iris forward and causes glaucoma. This glaucoma is called as phacomorphic glaucoma. Phacomorphic glaucoma. Mature intumescent cataract, intumescent means swollen. It absorbs water. It absorbs water and it swells, and this swollen lens pushes the iris forward, closes the angle, causing phacomorphic glaucoma. Next, what we have is the hypermature Morganian cataract. Hypermature Morganian cataract. 1 minute. Yeah. Hypermature Morganian cataract. Now, what is a hypermature Morganian cataract? In a hypermature Morganian cataract, the peripheral cortex liquefies and the nucleus sinks to the bottom. The peripheral cortex liquefies and the nucleus sinks to the bottom. This liquefied cortex, it leaks out and it blocks the pores of the trabecular meshwork, and this glaucoma, it is called as phacolytic glaucoma. It is called as phacolytic glaucoma. So here the liquefied cortex leaks out and blocks the pores of the trabecular meshwork, causing phacolytic glaucoma. याद आया सबको? So phacomorphic in mature and intumescent, and phacolytic in hypermature Morganian cataract. You're able to recall everyone? Chalo. Now we'll just revise a few other small topics. Let's come to a few important instruments that we have. So what is the name of this instrument? The name of this instrument is Goldmann applanation tonometer. The name of this instrument is Goldmann applanation tonometer. What is the use of Goldmann applanation tonometer? The Goldmann applanation tonometer, what is its use? It is the gold standard for IOP evaluation. It is the gold standard for IOP evaluation. It is the gold standard for evaluation of IOP, or gold standard for tonometry. Next, look at this instrument. How do we identify this instrument? There is a handle and there is a head and there is a dial at the side. This instrument, this is called as the direct ophthalmoscope. This instrument is called as the direct ophthalmoscope. Direct ophthalmoscope mein what are the things to remember? Ophthalmoscope jo hai, that is meant for evaluation of what? It is meant for evaluation of the retina. So in the direct ophthalmoscope, what is the magnification? The magnification is very high. It's around 15 times. The magnification is very high, it's around 15 times, but because the magnification is high, that's why the area that is seen is less. So here the field of view is limited to the central retina. The field of view is limited to the central retina. So what is the central retina? Limited to the central retina means you are able to see mainly the optic disc and macula. You're able to see the optic disc and the macula. And what kind of image is this? This is a virtual and erect image. This is a virtual and erect image. So the magnification is 15 times. And the field of view is limited to the central retina, that is the optic disc and macula. It's a virtual and erect image. This is a uniocular instrument. It's a uniocular instrument, which means that the examiner can use only one eye, and that's why it gives a non-stereoscopic view. Non-stereoscopic means that the perception of depth is not very good. It's a non-stereoscopic view. Next one. Look at this one. This is the instrument is worn on the head, and what is this called? This instrument, this is called as the indirect ophthalmoscope. This is called as the indirect ophthalmoscope. And in order to use the indirect ophthalmoscope, you have to use an additional lens. This is called as the 20 diopter lens. It's called as the 20 diopter lens. So with the indirect ophthalmoscope, the magnification is much lesser. The magnification is only 3 to 5 times. Some books will say 2 to 5 times. But because the magnification is less, that's why the field of view is much more. The field of view, this is up to the peripheral retina. It is up to the retinal periphery. And what kind of image is this? This is a real and inverted image. The type of image that you see here, it's a real and inverted image. And this is a binocular instrument. And because it is a binocular instrument, meaning it allows the examiner to use both eyes, that's why it gives you a stereoscopic view. Stereoscopic view means that it gives better perception of depth. So it's a binocular instrument, and so it gives a better perception of depth. That's called as the stereoscopic view. So these two instruments, that is the direct and the indirect ophthalmoscope, they are used for examination of the retina. So if we are asked which are the instruments for retina examination, retina can be examined with the direct and indirect ophthalmoscope. But there is another instrument by the name of the retinoscope. Now, this is a common mistake. Iska naam, there is an instrument called retinoscope, but though its name is retinoscope, the name is misleading. The use of the retinoscope is for refraction. It is used for refraction. So retinoscope, though uska naam retinoscope hai, it is used for refraction, whereas direct and indirect ophthalmoscope, these instruments, direct ophthalmoscope and indirect ophthalmoscope, they are used for evaluation of the retina. Okay, so these are the topics that I wanted to discuss today. I have kept the session short क्योंकि मुझे पता है कि एग्ज़ाम बहुत पास में है and you have lots of things to revise. So I wanted to keep the session crisp and short and to discuss things which are important. तो ये जो topics हैं, these are the things that should be there at your fingertips. इसके अलावा हमने जो FMG प्रेडिक्टर सीरीज में डिस्कस किया है एंड जो हमने TND में डिस्कस किया था, all these together, those are the important things in opthal. So जो थोड़े से भी difficult वाले topics थे, जो difficult confusing images थे, I have already done them in the FMG predictor, so that's why I did not do them again today. So these are the most important topics. So thank you very much everyone, all the very very best for the exams. एंड दो तीन चीज़ें एग्जाम के लिए आई विल जस्ट टेल यू बिफोर आई एंड द सेशन. सबसे पहले एग्जाम में क्वेश्चंस को बहुत ध्यान से पढ़ना है एंड यू हैव टू कीप योर आईज ओपन फॉर 2 वर्ड्स, दैट इज नॉट एन एक्सेप्ट. इन दोनों वर्ड्स के लिए इनको ना ध्यान से ढूंढो क्योंकि ये मिस नहीं होना चाहिए, क्योंकि नॉट और एक्सेप्ट अगर मिस हो गया क्वेश्चन रॉन्ग हो जाएगा. सो एक्टिवली कीप योर आईज ओपन फॉर दीज 2 वर्ड्स, दैट इज नॉट एन एक्सेप्ट. सेकेंड, चारों ऑप्शन को पढ़े बगैर कोई भी क्वेश्चन मार्क मत करना. नाउ व्हेन आई एम सेइंग दिस, ये बहुत सिली लग रहा है, लेकिन एग्जाम में क्या होता है कि हम जब क्वेश्चन पढ़ते हैं और हमें लगता है कि हाँ यही आंसर होगा, और वही जब पहला ऑप्शन होता है हम उसको मार्क कर देते हैं। ऐसा नहीं करना है। रीड ऑल द 4 ऑप्शंस। कभी कभी जब 4 ऑप्शन तुम पढ़ते हो तो तुम्हारी सोच जो है वो चेंज होती है। सो डू नॉट बी ट्रिगर हैप्पी, डू नॉट मार्क द फर्स्ट ऑप्शन इफ इट अपियर्स टू बी राइट। चारों ऑप्शन को पढ़ के ही मार्क करना है। थर्ड इम्पॉर्टेंट थिंग इज, एक बार वंस यू आर डन विद अ क्वेश्चन, सोच के जब उसके आंसर को मार्क कर लिया है, तो प्लीज बार बार उसको वापस आके चेंज मत करो। बिकॉज जो फर्स्ट इंस्टिंक्ट में लगता है मोस्ट ऑफ द टाइम दैट इज व्हाट इज द राइट आंसर। इफ यू चेंज इट देन देर इज अ हाई लाइकलीहुड इट विल गो रॉन्ग। तो बार बार आंसर्स को चेंज नहीं करना है। एक बार सोच के, एक बार अच्छे से डिसाइड करके जो मार्क कर दिया, लीव इट एज इट इज, दैट इज प्रोबेबली द राइट आंसर। Then do not panic. This is very very important. As I told you, there will be some difficult questions, लेकिन वो difficult questions को देख के panic अगर, if you go into that panic mode, तो जो known चीज़ें हैं वो गलत हो जाएंगी। And that's why do not panic. If there are difficult questions, be assured that there will be easy questions also. सारे question difficult नहीं होते हैं और सारे question difficult आ भी नहीं सकते। So that is why अगर difficult question है तो ठीक है। Our passing and failing depends on the easy questions. So do not panic. Panic नहीं करना है, काम रहना है, टाइम को अच्छे से मैनेज करो। You must attempt all questions. Questions छोड़ के नहीं आना है हमें, because that is something which we have to manage our time properly. ठीक है? So all the very very best and keep काम। एंड दो पेपर्स के बीच में प्लीज अपने दोस्तों के साथ क्वेश्चन आंसर्स डिस्कस मत करना। डू नॉट। नथिंग एवर गुड हैज कम आउट ऑफ डिस्कसिंग आंसर्स। तो उससे क्या होता है, कंफ्यूजन क्रिएट होता है, और इट, मतलब when जब बच्चे एग्जाम से निकलते हैं सबको लगता है कि एग्जाम खराब ही हुआ है, बट फिर भी बच्चे पास होते हैं। सो दैट्स व्हाई इट डजंट मैटर व्हाट यू फील एट दैट पॉइंट इन टाइम। when the result comes then only you will know। एग्जाम से जब हम निकलते हैं our head is in such a muddle that we feel कि नहीं अच्छा हुआ है, but that's how everybody feels, but so many students are passing also every time, right? So you don't have to let that get to your head, and please do not discuss between two papers। do not, बिल्कुल एक दूसरे से क्वेश्चन मैच नहीं, right? So thank you very much everyone. All the very very best for the exams. Be positive, believe in yourself, और ये last 1 week में you have to maintain a positive mindset. That is most important for passing. चलो, bye bye.
Everyone, a very good evening. Hello, everyone. Very good evening to all of you. So, let me know if the video and audio is fine. And once I get a go ahead with you guys, we will start with the marathon of pediatric section. Good evening, Dr. Khan, Dr. Shashikant, Preeti. Okay, so the audio and video is fine. Now let's start with the pediatric section. So pediatrics आपके FMG में बहुत ही straight forward आता है, right? Rarely they give some difficult question. जो difficult question आते हैं वो NRP के section से आते हैं, वो हम concept wise अच्छे से depth में करेंगे. And more or less it's very straightforward, very simple, very basic concepts, right? So let's start without further ado. Firstly we will start with general pediatrics. ठीक है, तो जनरल pediatrics में सबसे important topic और सबसे important section है आपका growth curves. Normal growth pattern पता होना चाहिए, तभी आप abnormal बता पाओगे, right? So सबसे पहले growth curves. ये 4 curves बहुत famous है आपके FMG के एग्जाम में, right? So can you tell me what is this first curve? Curve A. देख रहे हो आप curve A? क्या दिख रहा है curve A में? कि दिस टिश्यू इज ग्रोन, इस टिश्यू की ग्रोथ 2 years तक मैक्सिमम है ना, बहुत ऑलमोस्ट 90% ऑफ द ग्रोथ इज अचीव्ड बाय 2 years ऑफ एज एंड देयर आफ्टर वेरी लिटिल टू नो ग्रोथ, एक प्लेट्यू सा है. सो व्हाट इज दिस? दिस इज नथिंग बट न्यूरल ग्रोथ, राइट? This session will be around 2 to 2.5 hours, right? Okay, neural growth, brain developed. Yeah, Preeti is right, Dr. Khan is right, right? This is for the neural growth. Ads भी आती है ना, Horlicks के ad you must have seen कि बच्चे के दिमाग का विकास सबसे ज़्यादा initial 2 years of life में होता है. So this is what is happening, right? So in the initial first 2 years of life, the growth of the brain tissue or the neural tissue is 90%, and thereafter the remaining 10% happens, right? So this is nothing but neural tissue growth development. Now let's look at the second curve, curve B. What is happening over here? In this tissue grows rapidly. Then there is a plateau. Then again by the age of 10 to 12 years, there is rapid growth. What is this? This is an S-shaped curve. This is an S-shaped curve जिसको हम somatic भी बोलते हैं, right? Somatic, S-shaped somatic, right? S-shaped somatic. So this is for somatic growth curve. S-shaped sigmoid curve जहाँ पे भी आपको दिखे, this is somatic growth curve, right? Somatic growth curve. Now let's move to the next question. Graph C. क्या दिख रहा है graph C में? In this, the tissue has no development by 10 to 12 years of age, and thereafter there is sudden spike. What is this? This is for puberty. Once the puberty is hit, there is sexual growth. So this is sexual growth curve. And lastly, can you see over here D? What is happening? This tissue has a growth in between 4 to 8 years of life. उसके बाद regression है, उससे पहले भी growth नहीं है. So this is nothing but lymphoid tissue growth. अगर आप 4 to 8 years of life में किसी बच्चे को examine करोगे, you will notice enlarged lymph nodes, you will notice enlarged thymus on the X-ray. So this is nothing but lymphoid growth. So these are the four somatic, four growth curves. These curves are also known as human growth curves or Scammon curves. ये आपकी टिप पे होना चाहिए क्योंकि बहुत बार पूछा हुआ है, राइट? रिमेंबर न्यूरल में क्या होगा? इनिशियली बाय 2 years ऑफ लाइफ 90% ऑफ द ग्रोथ, देयर आफ्टर लिटिल टू नो ग्रोथ. बी इज सिग्मोइड शेप कर्व और एस शेप्ड कर्व. दिस इज फॉर द सोमैटिक ग्रोथ. C is your sexual growth, right? Spike after 10 to 12 years of age. And if you notice a peak, a tent-like structure in between 4 to 8 years of age, this is nothing but lymphoid growth, right? So this is about your human growth curves or Scammon curves, right? Moving to the normal growth pattern. So normal growth pattern में सबसे important आपका है weight. So can you tell me what is the average weight of a term child in India? टर्म बच्चा जो पूरे टाइम से हो जाता है इंडिया में, उसका एवरेज वेट कितना होता है? What is that? Yes, it's 3 kgs, right? It's 3 kgs. So this weight, this 3 kgs, what do you think? कि ये constant बढ़ता है एकदम से या initially loss भी होता है? Initially there is some loss. What is that loss? There is up to 10% of loss in the first 7 days of life, right? ये सब बच्चों में होता है. In the very 7 days, what will happen? There will be 10% weight loss. जो birth weight है उससे 10% loss हो जाएगा. Why this loss is happening? Because of the loss of interstitial fluid. And डरने की बात नहीं है, because this is regained by day 10 of life. This is regained by day 10 of life, right? And उसके बाद कैसे बढ़ता है? For एक ready reckoner है हमारे पास. So if the birth weight was X, by 5 months it will double. By 1 year it will triple. By 2 years it will quadruple. It will become 5 times. By 3 years of age it will become 6 times. By 5 years of age, and finally 7 times by 7 years of age, right? Ready reckoner. Okay, now moving to length. जैसे एवरेज बर्थ वेट आपने बताया 3 kg होता है. व्हाट इज द एवरेज लेंथ ऑफ अ टर्म चाइल्ड एट बर्थ? व्हाट इज द एवरेज लेंथ? yes, this average length is 50 centimeters. 50 centimeters. So ये जो birth पे 50 centimeters होती है, ये कैसे बढ़ती है further? So in the first year of life there is gain of 25 centimeters. So by the end of 1 year कितनी हो जाएगी length बच्चे की? It will become 75 centimeters, right? In the next year कितना gain होता है? In the next year you will see 10 to 15 centimeters gain. So by the end of 2 years it will be 85 to 90 centimeters, right? Thereafter length बहुत plateau हो जाती है, right? There is 6 centimeters per year gain till puberty. Puberty के बाद spurt आएगा, right? Puberty के बाद spurt आएगा. So in males it can go up till 10 centimeters per year, and in females it can go up to 8 centimeters per year. 8 centimeters per year, right? तो अगर मैं आपसे पूछूं 3 years पे कितना हो जाएगा? मैंने आपको बताया 6 centimeters per year होना है, तो by the end of 3 years 96 centimeters हो जाएगा, right? So this is the average length and the growth pattern that you normally see. अब ये MCQs आपके आते हैं कि वेट कब डबल होता है, वेट कब ट्रिपल होता है, हाइट या लेंथ कब डबल होती है, ट्रिपल कब होती है, चाइल्ड हाफ ऑफ द अडल्ट हाइट कब होता है. तो ये कुछ MCQs हैं. वेट आपने पढ़ा था डबल कब होता है? 5 months of age पे, राइट? सो वेट डबल्स बाय 5 months of age, triples बाय 1 year of age. What about height or length? Remember, height or length doubles by 4 years of age and it triples by 12 years of age. Triples by 12 years of age. फिर अब ये बहुत favorite question है कि child is half of the adult height at what age? So what is the average adult height? Average adult height अगर आप देखो तो that's 160 centimeters. तो उसको half कर दोगे it becomes 80 centimeters. So 80 centimeter what do you think कब होगा? 85 centimeter तो होता है 2 years पे, तो close to 2 years ही 80 centimeter होगा. I can say 1.5 to 2 years के बीच में. So the correct answer, the most appropriate answer here would be 18 to 24 months. 18 to 24 months of age, right? So this is about the average length at birth and how it increases. और कुछ MCQs जो आपसे एग्जामिनर पूछता है कि वेट कब डबल होता है, वेट कब ट्रिपल होता है, हाइट या लेंथ कब डबल होती है, कब ट्रिपल होती है, and child is half of the adult height at 18 to 24 months of age, right? Moving to the next question, head circumference. So how do you measure head circumference? I take a measuring tape, place it over the supraorbital ridge anteriorly and posteriorly on the highest point on the occiput, or overlap कराते हैं over the parietal region, right? This way we take the head circumference. So what is the average head circumference at the time of birth of a term baby? Average weight आपने बताया, average length आपने बताया. What is the average head circumference? So if you talk about the average head circumference, what is that? It's 33 to 35 centimeters. 33 to 35 centimeters. राइट क्या होता है, कैसे बढ़ती है ये हेड सर्कमफ्रेंस? सो इन द इनिशियल 3 months ऑफ लाइफ, कैसे बढ़ेगी? 2 centimeters per month. 2 centimeters per month, right? In the next 3 months, मतलब 3 to 6 months of age में, it's 1 centimeters per month. And in the next 6 months, that is 6 months to 12 months of age, it increases by 0.5 centimeter per month. तो देखते हैं कितना कितना बढ़ता है. आपको मैंने बताया 0 to 3 months में कितना बढ़ता है, 2 centimeter per month. तो that means 2 into 3 कितना बढ़ेगा, 6 centimeter. Next 3 months में 1 centimeter per month है, तो 3 into 1 that is 3 centimeters. And lastly in the next 6 months it's 0.5 centimeter per month. So 0.5 into 6 that is again 3 centimeters per month. तो कितना हो गया 1 year of life में, 6 plus 3 plus 3 that is 12 centimeters. 12 centimeters in the 1 year of life कितना head circumference बढ़ जाएगा, 12 centimeters. And we all know that 90% of the adult head circumference is achieved by neural growth. याद है, it's achieved by 2 years of age. 2 years of age, right? फिर एक और क्वेश्चन पूछता है एग्जामिनर कि एट द टाइम ऑफ बर्थ जो बच्चे की हेड सर्कमफ्रेंस है वो एक अडल्ट हेड सर्कमफ्रेंस के कितने परसेंटेज पे होती है. सो रिमेंबर एट द टाइम ऑफ बर्थ हेड ऑफ द चाइल्ड इज क्वाइट बिग एज कंपेयर टू द बॉडी. इट्स एक्चुअली 60% ऑफ द अडल्ट हेड सर्कमफ्रेंस, 60% ऑफ द अडल्ट सर्कमफ्रेंस, राइट. सो ये आपके इंपॉर्टेंट एमसीक्यू सारे कवर हो गए इस स्लाइड में. नाउ मूविंग टू पीरियड्स ऑफ ग्रोथ, राइट. जब भी हम ग्रोथ की बात करते हैं तो पीडियाट्रिक्स में नो न्यूनेट इज सिमिलर टू इन्फेंट. इन्फेंट इज नॉट लाइक अ टॉडलर, टॉडलर इज नॉट लाइक अ प्री स्कूल चाइल्ड, अडोलेसेंट चाइल्ड इज वेरी डिफरेंट फ्रॉम अ टॉडलर, राइट. तो एज ग्रुप के हिसाब से हमने कुछ कुछ नाम दिए हुए हैं. तो इन पीरियड्स ऑफ ग्रोथ को डिवाइड किया हुआ है इनटू एंटीनेटल पीरियड, पोस्ट नेटल पीरियड एंड अडोलेसेंट पीरियड. एंटीनेटल मीन्स व्हेन द चाइल्ड इज इन द वूम ऑफ द मदर. तो सबसे पहले क्या होता है, देयर इज फर्टिलाइजेशन ऑफ द ओवम विद द स्पर्म और बनता है जाइगोट. सो व्हेन डू यू लेबल दिस प्रोडक्ट ऑफ कंसेप्शन एज फर्टिलाइज्ड ओवम और जाइगोट. रिमेंबर जाइगोट जी ऐसे लिखते हैं ना, जी ऐसे लिखते हैं, ये 2 जैसा है. तो रिमेंबर अप टू 2 weeks you will label this as zygote. Up to 2 weeks this is zygote. To 2 weeks this is zygote. Then comes embryo. E for embryo, E for 8, right. So 2 to 8 weeks is embryo. F को अगर आप मिरर इमेज बनाओ तो ऐसे बनेगी, that becomes 9. So fetus 9 weeks onwards till birth it's called fetus. सो ये 3 इंपॉर्टेंट टर्म्स हो गई. जाइगोट कब बोलोगे, एम्ब्रियो कब बोलोगे, फीटस कब बोलोगे, राइट. बिफोर नाउ गोइंग टू पोस्ट नेटल एज ग्रुप्स, एक ओवरलैप पीरियड है दैट इज पेरीनेटल पीरियड. इस पेरीनेटल पीरियड में एंटीनेटल पीरियड भी आता है, पोस्ट नेटल पीरियड भी आता है, राइट. सो पेरीनेटल पीरियड कौन सा होता है, 22 वीक ऑनवर्ड्स till 7 days post birth, 7 days post birth, right. So this is perinatal period. Now moving to postnatal, जैसे ही बच्चा पैदा होता है, postnatal, what do you say this child as, what do you label this child as? This child is a neonate. The first 28 days of life this child is a neonate. This is further divided into early neonatal period and late neonatal period. Early neonatal period होगा आपके first 7 days of life and thereafter 8 to 28 days is going to be late neonatal period. Infant, you all know, a child who is less than 1 year is infant. तो मतलब एक neonate भी infant है, yes. And every neonate is an infant, but remember every infant is not a neonate, right. Postnatal neonate period क्या होता है, post neonate period हो गया 28 days से लेकर 1 year तक. This is a post neonatal period, 28 days to 1 year of life. Then you have toddler, T for toddler, T for 3. So 1 to 3 years of age, this is a toddler. 3 to 6 years is a preschool. S for school going, S for 6. So 6 to 12 years is a school going child. Now coming to adolescent period. Adolescent किसको बोलते हैं, adolescent 10 to 20 years of age में हम बोलते हैं this is adolescent. 10 to 20 years is adolescent. Recent गई आपकी 20 बोलते हैं, not 19, right. So 10 to 20 years is the adolescent period. It is further divided into early adolescence, mid adolescent and late adolescence. Early कौन सा है, early is 10 to 13 years of age, mid is 14 to 16 years of age, and then 17 to 20 years of age is the late adolescent period. Okay, so this is about the periods of growth. Moving to now assessment of growth. So आपने normal growth pattern पढ़ लिया. We have read about the normal growth pattern. We have read about the periods of growth. Now coming to assessment of growth. How will you assess growth of a child? So we have different parameters with us to assess the growth of the child. Some of those parameters are age dependent. Some of those are age independent. What do you mean by that? If I say that I have a newborn with me and the weight is 3 kg. That's fine, right? You know, that's the average birth, that's fine. But if I say this is a 1-year-old child and the weight is 3 kg, then this is not right, right? Something is wrong over here. So weight is something which is dependent upon the age. It is an age dependent parameter. Same goes for the length, same goes for the head circumference. So these are the age dependent parameters. So what are the age independent dependent parameters? We have weight, we have length or height, we have head circumference. And what are the age independent parameters? Age independent parameter mean this parameter would be same independent of the age, right? What are these? We have two, remember. First is MUAC, that is mid upper arm circumference, and second is skin fold thickness. One by one we are going to ask about this, right? Okay. So firstly, let's go towards assessment of the weight. So to assess the weight, we have different instruments with us. So these instruments are very important for your FMG exam, right? Most of the times they give this picture and ask what instrument is this. So very easy trick to remember. See the first instrument, we have a dial like this that is going to show you the weight. We have a hook over that and a bag attached below in which you place the child. Right? What is this instrument? Remember, with this hook. This is an S-shaped hook, right? So this is nothing but a spring balance. This is a spring balance. Right? So this is the spring balance. And what about the second image? Can you notice over here? What is there? So I have a scale like bar, and I have a plate in which I make the child lie down like this, and it gives me a reading of the weight. So what is this? This is a beam balance. It is a beam balance. Now you have fancy electronic scales also that looks like this. Instead of this bar, we have a digital board that shows the weight, right? So this is beam balance and spring balance. Okay. Moving to now measuring the length or height. So these length and height are not the same. How they are different? So what do I mean by length? In length, I make the child lie down and measure head to toe, right? Or head to feet. On the other hand, when I'm measuring the height, I mean the standing height. I make the child stand and take and measure from the top of the head till the feet. Right? So why these two different things we have to measure? So firstly, I understand that when I'm making the child lie down and measuring like this, this is measurement of length. So till when you are going to measure this length? Remember, till 2 years of age. You are going to measure the length. Why? Because till 2 years of age, there is physiological bowing of legs. Right? I know at 1 year of age the child can stand, I can take the standing height also, but still till 2 years of age you have to take this length because there is physiological bowing of legs. So I take the child, make him lie on this fancy device on which head end is fixed and foot end is mobile, and you measure the length. What is this device called? That is used to measure the length. Remember this, the name of this device is infantometer. Now don't get confused with the name. I know infant is someone who is less than 1 year of age, but remember length is measured till 2 years, not 1 year. Right? So infantometer, till 2 years of age, you're going to use this. After that, you take the standing height, make the child stand like this along this bar and measure from the top of the head till the feet. What is this device? This device is a stadiometer. So after 2 years of age, you use the stadiometer to measure the height of the child. Right? So moving to now age independent parameters, So when you look about okay. Dura matter, I've told you that the height of a child is half of the adult around 18 to 24 months of the age. We have discussed it very nicely in detail, right? 160 is the normal average adult height. We divided by 2, it comes out to 80 centimeters. And we know at the age of 2 years, the child is going to be 85 to 90. So 80 centimeter would be around 18 to 24 months only, right? Yes, everyone has already asked, what is this? This is a Sharker's tape. We use the Sharker's tape. This colorful tape is Sharker's tape, and we use it to measure this mid upper arm circumference. So we all know that this mid upper arm circumference is an age independent parameter. Why this is age independent parameters? Because in the age group 6 months to 5 years of age, what happens? Initially, if you have seen a child, an infant around 6 years of age, you must have noticed that they are very chubby, right? They're very chubby. They are full of fat, baby fat, but as they grow, this fat is lost and muscle is gained. This is known as reversal of the adiposity. So what happens? There is loss of fat and gain of the muscle. So overall, the circumference of the arm stays the same. Initially it was full of fat, then fat goes and it is replaced by the muscle. The overall circumference remains the same. That's why mid upper arm circumference is an age independent parameter. And we use this Sharker's tape for community screening of malnutrition. So how do we use? Why this tape is colorful? Look, when you are screening in a community, even if you don't know how to read numbers, you can see the colors, right? So if the child is lying in the green zone, that means if the mid upper arm circumference of this child is 12.5 centimeters and above, this is green zone. That means the child has normal nutrition. If the child's mid upper arm circumference is less than 11.5 centimeter, it is the red zone. That means the child has severe malnutrition. And in between, that is 11.5 to 12.5 centimeter, it is the yellow zone, where the child is still malnourished, but it is not severe malnutrition, right? So how do you use this Sharker's tape? You place it over the mid upper arm. Now the question comes, how do you define that this is the mid of the upper arm? How do you mark that? So if you look at the child, we take two bony points. First point is above. This is nothing but the acromion process, and below we have the olecranon process. You draw a line joining these two, and at the middle of that line you measure with this measuring tape, right? So this is all about mid upper arm circumference. Now moving to the second age independent parameter, that is skin fold thickness. How do you measure the skin fold thickness? Using this device. I know this device you must have seen in your physics practicals back down in 11th and 12th. This is a caliper. What is the full name of this caliper? This is Harpendon's caliper. So skin fold thickness mein, what are we looking for? We are looking for the thickness of the skin and the subcutaneous fat. So if it is less than 6 mm, it is indicative of severe malnutrition. And above 10 mm, it is considered as normal. Above 10 mm, it is normal. So what are the sites where you're going to check for the skin fold thickness? Remember, the most common site where we check is the triceps muscle, right? So around over the triceps, you measure this skin fold thickness. Apart from that, you can also measure in the subscapular region, interscapular region, biceps region, right? So subscapular, interscapular. So this is about skin fold thickness. So we have covered age independent and age dependent parameters. centimeters. So moving on to your puberty section. So we have already discussed what is adolescent. Adolescence तो एक age group एक period है. This is an age period 10 to 20 years of age. What is puberty? Puberty is the appearance of secondary sexual characters, right? So how they are different? How puberty and adolescence is different? Adolescence is just an age group 10 to 20 years of age, but puberty is appearance of secondary sexual characters. Appearance of secondary sexual characters. So now what examiner asks is the sequence of puberty. How does these secondary sexual characters appear? So to remember that sequence of puberty, remember the mnemonic TPM. In both males and females, you are going to follow this mnemonic. So what is the sequence in females? First T, what is T? T is thelarche. That means appearance of breast, right? Thelarche. Then you have P. P is pubarche, appearance of pubic hair. And lastly, you have menarche, that is onset of menses. And what about boys? In boys, firstly, what is the first T? T is for testicular enlargement. Testicular enlargement. Then again you have P. This is for the penile growth and pubarche. And lastly, M is for manly. What is manly? That means appearance of your beard, deepening of the voice, all other things, right? So these are the sequence of puberty in males and females. Now coming to the questions that examiner is fond of asking. The very first question is, what is the first biochemical evidence of puberty? So remember, what is the first biochemical evidence? It is the GnRH pulse. GnRH pulse. But if they ask what is the best marker for puberty, so remember best marker would be LH FSH, and if you have to choose one, choose LH over FSH, right? Now to assess the puberty, we have a staging. What is the name of that staging? That is an SMR staging or Tanner staging. Sexual maturity rating staging or Tanner staging. And they ask in which stage of this Tanner staging you see growth spurt in females and when do you see growth spurt in males. So remember, females mein growth spurt would be earlier. Males mein it is later. In females, you see growth spurt in the SMR stage 3. SMR stage 3. And in males, you see in stage 4. In stage 4. Now let's discuss in detail about these stages. So firstly, let's look at the SMR staging for males. So it's very easy to remember. How? You can remember stage 1 would be the pre-pubertal stage, right? Pre-adolescent stage. Here, all the organs would look infantile. That means all the organs won't be looking like they have undergoing changes of puberty, right? So 1 is going to be pre-pubertal and 5 is going to be adult-like. So very easy. In both of these stages, you will notice stage 1 is pre-pubertal, and stage 5 would be adult-like, right? In between, there are going to be changes. Let's look at the first change that is going to happen. The first change that is going to be happen is increase in the testicular volume. Remember, as soon as the testicular volume crosses 4 ml, this is indicative of puberty in males. So remember, if there is increase in testicular volume more than 4 ml, this is indicative of puberty. Here, what you start to notice in stage 2, you start to notice that the pubic hair starts coming. But here, the pubic hair are very sparse pubic hair. In stage 3, now the pubic hair will undergo more coarsening, more curling, right? So pubic hair will become more coarse, will curl. And also there is increase in the penile length. Then stage 4, I told you there happens growth spurt, and now there will be increase in the penile width, and also pubic hair will also increase in density. The major difference between stage 4 and stage 5 is, in stage 5, now the pubic hair would also be on medial thigh, pubic hair on medial thigh. right? On the other hand, in stage 4, you will see dense pubic hair, but they won't reach to the medial thigh. So this is all about the Tanner staging in males. To another important MCQ that they ask. They ask when the scrotal reddening happens and when scrotal darkening happens. So remember in stage 2, you will see scrotal reddening, right? So in stage 2, you're going to appreciate scrotal reddening. And scrotal darkening would be in stage 4. Scrotal darkening. Right? So this is all about the staging, the Tanner staging in males. Now let's move towards the Tanner staging in females. Tanner staging in females. Any doubt about the Tanner staging in males? Okay, now let's move to the female section. So simple rule again, in stage 1 it will be prepubertal and in stage 5 it will be adult, like that means the hair would be on the medial thigh as well. So prepubertal stage 1 and adult, like that means hair on the medial thigh, hair on the medial thigh. Now let's see what happens in stage 2. In stage 2 what happens? Firstly there is appearance of the breast part, and again there will be sparse pubic hair, What happens in stage 3? We all know growth spurt happens in the stage 3 and again pubic hair will become coarsen, will curl, right? And in stage 4 again you will see dense pubic hair, adult like, except the pubic hair would not be on medial thigh, and in stage 4 there is formation of secondary mount on the breast, right? So this is about Tanner staging, right? I'm not ignoring anyone's question. Growth spurt is not something that we are discussing right now. When we discuss, I'll be covering the downs then, right? Okay, so now let's move to short stature assessment. So what is short stature? When do we call a child short? So remember, when do we call a child short? If the height for the age and sex of a child is less than -2 standard deviation, this is nothing but short stature, right? And how do you get to know that this is a short stature? Obviously, you will plot it on the charts and get to know that this is a short stature, but not all short stature is pathological. Some is physiological also. For that, you need to know the target height. What is the target height? I am short because my parents are short. My genetic potential is such that I am going to be short. So how do you take the target height? You ask about the mother's height, father's height, average it out and add 6.5 centimeter if it is a boy and subtract -6.5 centimeter if it is a girl, right? So how do you calculate the target height? You take the mother's height, father's height, average it, add 6.5 centimeter if it is a boy and subtract 6.5 centimeter if it is a girl. So examiner can sometimes give you mother's height and father's height and ask you to calculate the target height of that particular child. If it is a boy, then add 6.5. If it is a girl, then subtract 6.5, right? So moving to short stature. So as I told you, not all the short stature is pathological. Some of the short stature is physiological. So in physiological short stature, you have two things: constitutional delay in growth and puberty, and the second is familial short stature, right? Wrongly here, both the categories are same. So remember, one is the constitutional delay in growth and puberty, and second is familial short stature. Familial short stature. The familial short stature we have just discussed. I am short because my parents are short. So that means both the parents are short. That's why the child is short. So here you will have history of short parents. If you look at the final height of these children, obviously these children are going to be short only. Their puberty would be at their time. Their height age definitely would be less as compared to their chronological age. And what about the bone age? Bone age would be fine, their puberty is fine, otherwise growth is fine, right? So there comes the concept of bone age, height age, and chronological age. So remember, what is chronological age? Chronological age means your actual age. So today the date is 21st June 2026. So if a child was born on 21st June 2025, so today the child is 1 year of age, right? Today is his first birthday. This is chronological age. So chronological age is age since the birth, right? So this is age since the birth. What is bone age? Bone age is when you look at the x-rays of the child and you notice the number of ossification centers, at what age this particular x-ray is visible, that is the bone age. That is the maturity of the bones, right? So bone age you will calculate from the atlases, comparing it to the atlases. And lastly, you have the height age. What is height age? So remember, for example, if I tell you the height of the child or the length of the child is 75 centimeters, what do you think the age of the child would be? So immediately you will think the average height is 50 centimeter. In 1 year 25 centimeter gain is there. At 1 year of age, usually average height would be 75 centimeters. So this child must be 1 year of age, right? So by just telling the height, you were able to guess that this child should be 1 year of age. So height age is that only. This is that particular age at which the height is at 50th centile, right? 50th centile. So if on charts you notice that 75 centimeters is at 1 year of age, so the height age of this child would be 1 year, right? So that was the difference I was telling over here, that in familial short stature the bone age of the child would be equal to the chronological age. That means because the child's growth is going fine, every puberty is also fine. But what about constitutional delay in growth and puberty? The name itself says there is just a delay. Here what happens, you will have a history in parents that their puberty and their spurt was also delayed. We all have that one friend that was initially short, but one fine summer holidays and vacations caught up the height in 9th or 10th standard, and then from the initial first to two position in the assembly, he moved back to the last or the second last position, right? So what was that? That was constitutional delay in growth and puberty. Here the parents also give the history that our puberty was also delayed. We also caught up height later on. Their final height is going to be normal, but remember here is a delay. So puberty would be delayed. Bone age would be delayed, right? So let's enumerate the differences over now. So what is the history over here? History. So in constitutional delay in growth and puberty, there will be history of delay of puberty in parents. On the other hand, in familial short stature, there will be history of short parents. Final height and constitutional delay in growth and puberty would be normal. In familial short stature, the final height will be less only. Puberty here is delayed. Here puberty would be at the normal time. Height age definitely is less over here. That's why it is short stature. In familial short stature also, the height age is delayed. What about the bone age? Bone age is delayed over here. Bone age is normal over here. So now looking at the relationship of the chronological age, height age and bone age, it's very easy to understand. Remember, एक चीज constant रहेगी. This is short stature because the height age is less, right? The child has presented to you because his height doesn't seem like his of age. So that means ये तो rule ही रहेगा कि height age is less than chronological age in both of the cases. Height age is less than chronological age in both of the cases. But one thing that I know is that the bone age is also delayed in constitutional delay of growth and puberty, right? Bone age be delayed है. सो बोन एज इस साइड पे आ जाएगी, लेस वाली साइड पे आ जाएगी. बोन एज इज इक्वल टू द हाइट एज. ऑन द अदर हैंड यहाँ पे बोन एज इज नॉर्मल, सो वो chronological एज के साइड पे आ जाएगी. राइट, सो दिस इज हाउ यू इजिली रिमेंबर. ओके, growth velocity. So growth velocity, remember, in physiological short stature, growth velocity would be normal. In pathological, that velocity is abnormal because of that pathology. Velocity pattern आपको यहाँ पे same दिखेगा. Moving to short stature topic per se. So जब भी हम short stature की बात करते हैं, a very important ratio you should know, that is the upper segment lower segment ratio. How do we calculate this upper segment lower segment ratio? We make the child stand like this, right? Take the measurement from the top of the head till pubic symphysis. This is the upper segment. Remaining, अगर आप height में से upper segment को minus कर दोगे, remaining is the lower segment. So why this ratio is important? Remember, how does the child grow? The growth is proximal to distal. Right? If you have ever looked at a child, the child's head look much bigger. And as the child grows, the trunk grows, the limb grows, because the direction of progression of growth is proximal to distal. Cephalocaudal and proximal to distal. So as the child grows, what is going to happen? My lower segment is going to increase, right? So normally, what is the normal upper segment lower segment ratio? Normal upper segment lower segment ratio at birth is 1.7:1. Now as the child will grow, my lower segment will increase, so that means this ratio is going to decrease. So at 3 years of age, it becomes 1.3:1. At 6 years of age, it becomes 1.1:1. At 10 years of age, it becomes 1:1. And after 10 years, adult ratio of 0.9:1, or we can also write as 1:1.1 is achieved. Now why this ratio is important? Remember, if the child is short because of some pathology, a known pathology, what will happen? Either both upper segment lower segment ratio would be impacted, right? This is proportionate bacha, proportionate short stature. But if just the upper segment is affected or just the lower segment is affected, my normal ratios won't be there. I will have either increased upper segment lower segment ratio and decreased lower segment upper segment lower segment ratio. So depending upon that, I can guess what is the pathology behind. So firstly, let's look at increased upper segment lower segment ratio. What do you mean by increased? Increased upper segment lower segment ratio means, if I give you example, if a child is 3 years of age and his upper segment lower segment ratio is 1.5:1. So I know that at 3 years of age, this upper segment lower segment ratio should be 1.3:1. But now this ratio is high. That means my upper segment looks big and my lower segment is short. So this is short limb dwarfism. Short limb dwarfism. Where do you see this short limb dwarfism? Remember 3 conditions. This you should be able to recall in your sleep also. What are these 3 conditions? First condition is rickets. Second is achondroplasia. Third is congenital hypothyroidism. Congenital hypothyroidism. So these are the 3 conditions where you see increased upper segment lower segment ratio or short limb dwarfism. Now moving to the second condition where we have decreased upper segment lower segment ratio. That means my upper segment is short here. So this is a short trunk dwarfism. This is short trunk dwarfism. So why my upper segment is affected? So what is basically your upper segment? My trunk basically has spine, right? So if spine and the ribs obviously, so if my spine is affected, my upper segment won't grow. So all the conditions where spine would be affected would be under this category, right? So if there is any vertebral anomaly, TB spine, pot spine, storage disorders like mucopolysaccharidosis, right? Spondyloepiphyseal dysplasia, So all of these would be under short trunk dwarfism, right? So this is about the disproportionate short stature, why it is important that you need to know this upper segment, lower segment ratio. So with that, we cover our growth segment. Now we will move to development, right? Whenever we talk about development, developmental milestone is something that unfortunately you have to mark up. But remember, sequence important है. अगर आपको sequence याद है, you'll be very easily able to recall that in the exam. So always remember the sequence. Sequence is important. So one by one each domain के बारे में बात करेंगे. We have 4 major domains: gross motor, fine motor, social and language. So what is gross motor? That means by gross bodily movements, gross movements, right? Fine motor में क्या होगा? Fine movements of the hands आ जाएगा. So gross motor में सबसे पहले remember कैसी ग्रोथ होनी है, डेवलपमेंट कैसे होनी है, व्हाट इज द डायरेक्शन ऑफ डेवलपमेंट. अगेन इट्स फेलोकॉर्डल, और लिम्स में इट इज proximal to distal, proximal to distal, proximal to distal, cephalocaudal and proximal to distal. On the other hand, growth में कैसे हो रही थी? cephalocaudal but distal to proximal, right? So remember, cephalocaudal सबसे पहले neck holding आएगी, then sitting, then standing, then walking, then running, right? So at 3 months of age, you notice neck holding, neck holding. At 6 months, the child can sit, but the sitting will be with support. At 8 months, finally, the child can sit without support. At 9 months, now the child can stand, but again with support. 10 months, now the child can walk holding the furniture, and also comes a very important milestone of creeping. Right? So remember, creeping also happens at this stage, creeping. And when does crawling happen? Crawling happens at 8 months. So what is crawling? What is creeping? Child moving on all the 4 limbs. If abdomen is touching the ground, abdomen touching the ground, it's crawling. If abdomen is lifted off the ground, it's creeping. Right? Remember, creeping and cruising happens at 10 months of age. Then comes the first birthday, that is 12 months of age. What happens at the first birthday? Now the child can stand independently, right? So a child can stand without support. So on the first birthday, the child will stand without any support and cut the cake himself. But to walk and collect gifts or to give return gifts, the child has to take support, right? Take support of his parents. So remember, stand without support but walk with support. And finally, walking without support comes at 15 months. Walk without support comes at 15 months. Then at 18 months, like all of us, when we turn adults, we run here and there. The child also at 18 months of age will run and explore the drawers, right? Exploratory phase. Then at 2 years of age, the child will jump, climb the furniture, at 3 years of age, the child will try to ride a 3-tire bicycle, that is a tricycle, right? Three-wheel cycle, that is a tricycle. And then at 4 years of age, hopping and skipping will come. Initially, the child will hop or skip on one foot. And finally, at 5 years of age, hopping and skipping on both feet. Right? So this was about the major gross motor milestone. When we are talking about the major gross motor milestone, a very important milestone is the stair milestone. So what is stair milestone? So initially, what is, remember what is easier, going upstairs or downstairs? Going upstairs is easier, coming downstairs is tough. So initially, what does the child do? Child will use both of the feet on one step. Place both of feet on one step, then both feet on one step, then both feet on one step. So this way, the child will go upstairs and downstairs. Then the child will use the stairs like we do. That is 1 feet on one step. Initially, the child will learn to do that going upstairs, then going downstairs, right? So remember, firstly, the child uses 2 feet on one step and goes upstairs and downstairs. This happens at 2 years of age. Then 1 foot per step upstairs at 3 years of age, and then 1 foot downstairs at 4 years of age. So 2, 3, 4, remember the stair milestones. Right, after gross motor milestones, now let's move to the fine motor milestones. So fine motor is the fine movements of the hand. So initially what happens, the child has a palmar grasp. That means if you stroke the hand of the child will reflexly grab it. This is palmar grasp. This palmar grasp has to be lost so that the child can voluntarily grasp things. So that voluntary grasp comes around 3 months of age. The child will be grasping toys, rattles. Then at 4 months of age, the child will use these grasp objects and bring it closer to the mouth. That is mouthing. At 5 months of the age, the child will now hold the object with both the hands. This is known as bidextrous grasp. Bidextrous grasp. Then the child will realize I can hold the thing with one hand also. This is unidextrous grasp, comes at 6 months. Then at 9 months, the child will be doing pincer grasp. Initially, this pincer grasp will be immature. That means the child will be using the accessory fingers to hold the object, right? So remember, pincer grasp will come at 9 months, but this pincer grasp is an immature pincer grasp. Mature one comes at 12 months of age. What do I mean by mature one? In mature pincer grasp, the object will be held in between thumb and the index finger. Okay sign would be there. Immature accessory fingers would also be used, right? At 15 months, now the child, because pincer grasp is fine, the child can hold a pencil and scribble. So at 15 months, the child will start scribbling. And after that, the child will draw very beautiful things. Now let's see the drawing skills. So what will happen at 2 years of age? The child will be able to draw a line. Line has 2 points, remember? So 2 points, 2 years. So at the age of 2 years, the child will be able to draw a line. At the age of 3 years, the child will be drawing a circle. Circle at 3 years. At 4 years, the child can draw this plus sign or cross. At 4.5 years, a rectangle. At 5 years, a triangle. At 7 years, a diamond. Then at 9 years, a cylinder. And lastly, a cube at 11 years of age. So these are the different drawing skills that the child can achieve according to his age. Now, when we are talking about the fine motor skills, dressing skill is something that is a very important fine motor skill that we do use every day, right? Fine motor skill से आप buttoning, unbuttoning, dressing, undressing करोगे. So remember what is easier? जैसे हमने stairs में पढ़ा था, going upstairs is easier, downstairs is tough. तभी upstairs पहले आएगा, downstairs बाद में आएगा. Similarly for dressing skills, remember undressing is easier, right? सबको अच्छा लगता है undress करना. Undressing is easier. So initially the child will learn how to undress, then dress. And पहले कैसे undressing करेगा, dressing करेगा with help and then without help. Right? So remember, firstly, there will be undressing with help. This happens at 2 years of age. Then the child will be dressing with help at 3 years of age. And finally, the child will learn to dress and undress without help at 5 years of age. And in dressing also, a very integrated function is buttoning, unbuttoning. इसमें भी unbuttoning firstly learn करेगा and then buttoning. So unbuttoning happens at 3 years of age and buttoning at 4 years of age. 4 years of age, right? So this is about the dressing skill. So we are done with gross motor and fine motor milestones. Now moving to the social milestones. So social milestones means how the child interact with the society around. Social milestones, right? So firstly, the child gives a social smile. What is the social smile? Anyone comes and do something around the child will pass a smile, respond by giving a smile. So the social smile comes at 2 months of age, right? But sooner the child realizes that I don't need to smile and give regard to everyone. My mother is very important. She gives me milk. She takes care of me. So the child develops a mother regard at 3 months of age. So mother regard at 3 months of age. And finally at 6 months, what will happen? The child will look in the mirror and play with the mirror. and think how sexy I am. So remember, S for sexy, S for 6. So at 6 years of age, there will be mirror play. Right? So now the child knows who's the mother, child knows who the child is. That means the child recognizes self and the mother. So now every stranger that comes into the picture, there will be anxiety. So at 7 months, remember, there will be stranger anxiety. Stranger anxiety. Now comes a very important milestone, that is 9 months. What happens in 9 months? Remember, before 9 months, what happens? If you show an object to the child and then hide it and remove that object from the vision of the child, what will happen? The child will forget about that object. Why? Because there is no object permanence. Child thinks whatever is in the front is just in my universe. Anything not in my vision is not in my universe. What a beautiful word to live in, right? But at 9 months, object permanence comes. So if you show a toy and then hide it, the child will try to find that object. The child now understands that whatever is not in my vision doesn't mean that it is not in the universe. It's still in the universe. So there is object permanence. Object permanence. And once this object permanence happens, the child also learn to wave goodbye. Waves bye-bye. Then comes 12-month period. In 12-month period, now the child will try to act and imitate. 18 months, now the child will do domestic mimicry. That means the child will follow the day-to-day activity that the child is seeing in the household. In the 3 years of age, remember, the child will be able to tell 3 things. What are the 3 things? The child will be able to tell the age, name and gender. Age, name and gender. And also by 3 years of age, handedness comes. Handedness comes. That means the child will be either using right hand or the left hand, right? More preferential usage of one side of the hand. Before 3 years of age, the child uses both the hands equally. But at 3 years, handedness comes. If the child is right-handed, the child will be using right hand more. If left-handed, left hand more. And at 4 years of age, there is right to left discrimination. That means the child can differentiate that this is right, this is left. Right? So do not confuse handedness with discrimination. Handedness means just using one side more as compared to the other. But the child will realize that this is the right side, this is the left side at 4 years of age. So this is about the social major milestone. Important social milestone is interaction and playing around. So firstly, the child is mostly at home with the parents. So the child will be developing a strong bond with the parents. Initially at the 15 months, the child will hug the parents. Now the child will develop an even stronger bond and start kissing the parents at 18 months. Right? Now, when the child is so close to the parents, hugging the parents, kissing the parents, now when this parent will leave and go for work, what will happen? The child will develop separation anxiety. Separation anxiety. So remember, the separation anxiety is also at 18 months. Now the child will realize that I need to go out and make new friends also. I cannot stay together with parents all the time. The child will go out and start playing with other kids. So what happens initially? 2 kids will be sitting and playing parallelly. Right? Remember the first day of your MBBS, what was happening? Your now best friend was just sitting beside you, but you two were too very hesitant to talk to each other. You must be on your phone, he must be on his phone, sitting together but not talking as if, right? Not exchanging things, just playing on their own. So this is parallel play. This parallel play happens 2 to 2.5 years of age. So remember, initially there will be a parallel play. When will they start talking and doing a cooperative play? This cooperative play starts happening at 3 years of age. And finally, they will make a group of friends and do role play, group play at 4 years of age. right? So this is about the social milestones. Now moving to the language milestone. So we discussed what was social milestone, that the child, how the child interacts with the society around. In language milestones, how the child tried to communicate with the society around, right, using words, language. So initially the child just produces some sounds, the cooing sounds, agoo like sounds, right? So these cooing sounds come at 2 months of age. Then at 4 months of age, the child will laugh out loud, lol. Then at 6 months, the child will say monosyllables. Monosyllables. What are monosyllables? Like ma, pa, ba, da. At 9 months of age, now the child will say bisyllables, join and say bisyllables. That means the child will join two monosyllables, ma, ma, ba, ba, da, da. Then at 12 months of age, the first real word the child will say. First real word. What do I mean by first real word? So if you ask your parents that what was my first word, so most of you will get an answer like mama, papa, dada, something like that only. That was not your first real word. That was actually you joining two monosyllables together. You didn't know the meaning of the word per se. The real word means you know the meaning of this word. So the first real word comes at 12 months of age. After that, the vocabulary will increase. By 15 months, you will know 4 to 6 words. Then 8 to 10 words around 18 months of age. Then by 2 years of age, you will be able to form 2-word sentences. 2-word sentences like khana do, pani do, give water, give food. And the vocabulary has increased to 50 to 100 words. Then by 3 years of age, the child starts using pronouns. I, me, you, main, tum, aap. Right? By 4 years of age, now the child will be very active, telling stories, poem. And how do you start a story? Once upon a time. That means past tense. So here the child will also be telling things about past. So past tense comes. And at 5 years of age, your future tense come, that the child will be able to tell about the future things. We are going to go tomorrow, something like that. And the child will also be asking about the meaning of words. So this is about language milestones. Now that we are done with the major 4 domains, gross motor, fine motor, social, language, one special milestone I want to discuss over here, क्योंकि आपके FMG में बहुत बार question पूछा गया about the vision milestones. To how do you check the vision? So we check the vision, the following of the object, the tracking of the object. We take a red dangling ring and keep this red dangling ring around 8 to 10 inches from the child. Right? We make the child lie down and look at this ring. So if the child is able to follow till 45 degrees, this is a milestone that you see in newborns. If this range is increased to 90 degree, this is a 1-month-old child, and by 3 months the child will be able to follow till 180 degree. And remember, binocular vision is established by 4 months of age, 4 months of the age, right? So these are some important MCQs that you see, appreciate while learning these vision milestones. So we are done with the milestones. So now moving to nutrition aspect of general pediatrics, that is micronutrients. So we have fat soluble vitamins and water soluble vitamins. This you must have covered in biochemistry also. So what are the water soluble vitamins? Water soluble vitamins are your B complex and C. So we have B complex vitamins and vitamin C. Right? And what about the fat soluble vitamins? Vitamin A, vitamin D, vitamin E, vitamin K. So one by one, we are going to discuss about their deficiencies and what are the particular symptoms that you notice over here. So firstly, we are starting with the water soluble vitamins, B1. What is the other name of B1? It is thiamine. So thiamine deficiency causes beriberi. It could be dry beriberi or wet beriberi. In dry beriberi, my nerves are affected, and in wet beriberi, cardiac tissue is affected. And in alcoholics, you see this thymine deficiency, and the name of the syndrome that you see in alcoholics with thymine deficiency is Wernicke-Korsakoff syndrome. How to remember the symptoms of this Wernicke-Korsakoff syndrome? Remember, you see a triad, and you can remember this triad by the mnemonic GOA. G is for global confusion. Global confusion. O is for ophthalmoplasia. Ophthalmoplasia. And A is for ataxia. So this is Wernicke-Korsakoff syndrome that you see in alcoholics presenting with thymine deficiency. Then we have B2. What is the name of B2? Riboflavin. So ribo, so remember red, right? So you'll see red things happening here and there, right? Ribo for red. So what red you can see? Can you see here the tongue hair is reddish, that is magenta colored tongue. And also, can you look at the angles? There is ciliitis, angular ciliitis, glossitis, cheilitis. And also, can you see sprouting red blood vessels in the cornea? This is corneal neovascularization that you again see in riboflavin deficiency, right? Then we have B3. This B3. What is the name of B3? B3 is niacin. And we all know niacin deficiency causes pellagra. This pellagra is also known as 3D disease. What are the 3Ds? We have diarrhea, dementia, and dermatitis. And sometimes they include this fourth D, that is death, right? Typical dermatitis pattern you can see in this image. What is this? Right? Rash, a photosensitive rash in the exposed areas. This is Casal necklace, Casal's necklace, Casal's necklace. Again, you see this in niacin deficiency. We'll talk about niacin deficiency more in detail, but these are the more broader things that you need to know about pellagra. There's something not anything like B4. We have B5. B5 name is pantothenic acid. And what happens with this pantothenic acid deficiency? How do you wear pants? From your foot. So remember, pantothenic acid deficiency will cause burning foot syndrome. Burning foot syndrome. Then you have B6. The name of B6 is pyridoxine. What happens with pyridoxine deficiency? Anemias happen. And yet another important cause of neonatal seizures is pyridoxine deficiency. So remember, this is an important deficiency point, neonatal seizures. So deficiency of pyridoxine can cause neonatal seizures. Then comes B7. What is B7? B7 is biotin, right? And if you are a skincare enthusiast, you know this biotin is frequently advertised, right? Good for your skin, good for your hair. So if biotin deficiency is there, what will it lead to? It leads to alopecia, dermatitis. Then there is nothing like B8. We have B9. What is the other name of B9? B9 is folic acid, and we all know folic acid deficiency leads to anemia, megaloblastic anemia. And also, if a mother is deficient in folic acid, then the child can have neural tube defects. Then you have B12, that is cobalamin acid, cobalamin. And again, it leads to megaloblastic anemia and a condition known as subacute combined degeneration. Lastly, water-soluble vitamin, vitamin C. We all know this is ascorbic acid and very important in collagen synthesis. Plays a very important role in the collagen synthesis step, right? Hydroxylation of chlorine and lysine. So if vitamin C deficiency is there, my collagen synthesis would be defective, and collagen is a very important connective tissue. So all the areas where this connective tissue could be there, skin, joints, hair, all of these would be manifesting with some issue. So you can see bleeds because of the fragile blood vessels, the collagen deficiency is there. In skin, what do you notice? You notice perifollicular hemorrhage, along with that corkscrew hair. right? In joints, you see this typical picture. Can you notice this typical picture? What do you see over here? Firstly, I can notice bleed beneath the periosteum. This is subperiosteal bleed. Look at the epiphysis, ring epiphysis. What is this white line called? This is known as white line of Frankel, right? At the edges of this white line of Frankel, this is known as Pelkan spur, Pelkan spur. Beneath this white line, can you see a black zone? This black zone is known as Forbitic zone or Trummerfeld zone, right? So these are the important features that you should be able to identify in the X-ray of scurvy. Moving to fat soluble vitamins, vitamin A. So again, vitamin A, a very important vitamin. If deficient, what are the features that you're going to see? Firstly, in the skin. In skin, you will notice dryness of skin, dot-like skin. In eye, they ask about what is the first eye symptom and what is the first eye sign. Eye symptom means what the complaint the patient presents with, and sign is what do you notice on the examination first. So what is the first eye symptom? The first eye symptom is night blindness. And what is the first eye sign? It is corneal xerosis, right? Corneal xerosis. WHO classification is important. I know the opthal session just happened and you must have studied about this. We are going to just revise the WHO classification. So firstly, we have XN, that is for the night blindness. Then you have drying of the conjunctiva, here the first eye sign is conjunctival xerosis. So you have drying of the conjunctiva. So firstly you see conjunctival xerosis. Then we have X1B. B is for the bite dot spot. You can see in this picture, what is this bite dot spot? You see this white flaky thing over the conjunctiva. This is bite dot spot. Then in X2, what will happen? Now the dryness would involve the cornea too. So there will be corneal xerosis. Then there will be ulceration in the cornea, corneal ulceration. Now, whether this ulceration is involving less than 1/3 of the surface area of the cornea or more than 1/3, we divide it into X3A and X3B. If the ulceration is less than 1/3, then it is X3A, more than 1/3, X3B. Then you have corneal scarring, XS, and then finally fundal changes, XF. Right, so this is the WHO classification of vitamin A deficiency, right? Second, after vitamin A, we have vitamin D. We all know what do we see in vitamin D deficiency? We see rickets. Vitamin D deficiency in growing bones, you see rickets, and grown bones, and you and me, if vitamin D deficiency happens, that's osteomalacia. So remember the 3 MCQs firstly. What is the first sign that you notice in rickets? The first sign is craniotabes or ping pong skull. That means the skull of the child would be very soft. Have you seen a ping pong ball? If you indent that ball, if you press and make pressure over that ball, there is an indentation seen. Same thing happens in a child with rickets. The skull is so soft that if you make a pressure over one point, you can appreciate the indentation over there, right? So this is known as craniotabes or ping pong skull. In chest, you see pigeon chest. That is also known as pectus carinatum. In lower limb, you can see different things, right? Basically, bowing of legs, you are going to see bowing of legs. If the legs are like this, that means the knees are apart. This is known as genu varum. If we notice legs like this, that means knees are touching each other as if they are glued together by a gum. So this is genu valgum. And lastly, if you see that the knees are moving in one direction, either left or right, this is wind-swept deformity. Wind-swept deformity. Right? Wind-swept deformity. Now moving to the X-ray, the typical X-ray you can appreciate over here. The 3 things you remember: cupping, That means there will be cupping like this over the joints. There is splaying, that means widening, and fraying, lastly fraying, right? So cupping, splaying, and fraying, the three things that you need to remember in X-ray of vitamin D. Now moving to the lab investigations. Vitamin D plays a very important role for the absorption of calcium and phosphate and mineralization of the bone. So if vitamin D is deficient, what will happen? My calcium would be low, my phosphate would be low. Whenever the calcium is low, my parathyroid senses that and releases parathyroid hormone. So my parathyroid hormone will increase and start releasing this calcium from the bones, mobilizing the calcium. So my calcium levels can come normal. ALP levels will increase. So this is the classical picture that you see over vitamin D deficiency, which is of nutritional nature. And they ask what is the most important marker over here. So remember ALP rise. If ALP is not increased, just rule out the nutritional deficiency. So ALP increase is the most specific marker, right? Moving to the treatment, how do you treat? Obviously, we are going to supplement the vitamin D. Either we can give a high dose regimen or a low dose regimen. What is a high dose regimen? High dose regimen is 60,000 international units per week for 10 weeks. So very high dose, 60,000 international unit every week we give for 10 weeks. So that means total 6 lakh international units. And what is low dose? Low dose but every day. So 6,000 international units per day for 3 months. This is low dose. This is low dose. Which is preferred, high dose or low dose? Remember, low dose is preferred. Low dose is preferred. And what is the response to the treatment that you see? You see a white line of calcification, right? So white line of calcification, white line of the calcification on X-ray gives a sign that the treatment response is there. Then after vitamin D, let's move to vitamin E. In vitamin E, you see hematological as well as neurological problems. Vitamin E deficiency, hematological, remember, it can lead to hemolytic anemias. And there is spinocerebellar ataxias as the neurological component. Vitamin K deficiency, you all understand, vitamin K is deficient in breast milk, and that's why we give that vitamin K shot at the time of birth. If we don't give that, you can see hemorrhagic disease of the newborn, right? HDN, hemorrhagic disease of the newborn, and the bleeding tendencies would be increased in vitamin K deficiency. So this was all about the micronutrients. Now let's move to the core topic, that is malnutrition, very important for your exam, right? Every year at least one question you expect. One is the minimum I'm telling. Most of the times they give 3 to 4 questions from this segment only. Kwashiorkar and marasmus is very famous. SAM is very famous. So let's revise the important topics as far as malnutrition is concerned. Remember, whenever I say malnutrition, it actually means both the things. That means overnutrition and undernutrition. But because we stay in a country like India, undernutrition is more prominent. So whenever I am saying malnutrition, we usually mean we are talking about undernutrition. And a very simple thumb rule when it comes to criteria's definition is that anything that is beyond plus minus 2 standard deviation is abnormal, and anything that is beyond plus minus 3 standard deviation is severely abnormal, right? So if I say the child's weight is very less for his height, that means the child is wasted. So if it is beyond plus minus 2 standard deviation, it is wasting. But once it turns minus 3 standard deviation, it will be severe wasting, right? Same goes for height. When do we say short stature? Less than minus 2 standard deviation. This is short stature, stunting. But if it goes beyond minus 3, it will be severe stunting. So these are the few criteria, and now let's decode each of them. Firstly, weight for height in between minus 2 to minus 3 standard deviation. So would this be wasting or severe wasting? Definitely this is wasting. Then less than minus 3 standard deviation, we have severe wasting. Now let's go to the other aspect, that is overnutrition. Here the weight for height is plus 2 to plus 3. So it is beyond +2, so that means something abnormal is there. This child is overweight or obese? This child is overweight. And once weight for height is more than +3 standard deviation, now this child is obese. Height less than -2 to -3 standard deviation, this is stunting. And beyond that, this will be severe stunting. Right? So these are the criteria and the nutritional status, how you have to interpret. Now, yet another important concept is acute and chronic malnutrition. So what is acute malnutrition? So if you go from your home and join MBBS and you have hostel food, poor hostel food, and sometimes avoid or skip the meal, what will happen? You will lose a lot of weight after going into the college, right? So this is acute malnutrition. Your weight will decrease, but this won't definitely affect the height. Same goes for a child. If a child turns sick, right, and didn't eat much for a week, definitely his weight will decrease, but height won't be affected, right? Height will stay the same. This is acute malnutrition. But if due to poverty or due to some other chronic problem, the child is not consuming enough nutrients, enough nutrition for a long period of time, now not just the weight but height would also be affected, right? So in acute malnutrition, what will happen for weight for age? Definitely it will decrease. What about height? Height will stay normal. Height is normal. What about weight for height? Weight is decreased. Height is normal. So obviously ratio would be less. Ratio would be decreased. Chronic malnutrition, the weight for age will decrease. Height for age will also be decreased. But if you take the ratio weight for height, it may be normal because both are decreasing, right? So maybe normal. So now the examiner asks what is more best marker for acute malnutrition. So the best marker for acute malnutrition you can see is weight for height. And what is a good marker for chronic malnutrition? It would be height for age. And what is common for both? Weight for age, right? So these are the 3 MCQs. They ask what is common for both acute and chronic malnutrition. It is weight for age. It will be decreased in both. Acute malnutrition, more reliable marker would be weight for height, right? Because weight is impacted, height is normal, so it will be less obviously. What would be best for assessing the chronic malnutrition? Height would be best for assessing the chronic malnutrition, so height for age, right? So this is about acute versus chronic malnutrition. Now let's move to the severe forms of malnutrition, which is very top favorite of your FMG exam, right? Look at this child A, child B. Look at this, these children. Both are extreme forms of malnutrition. This child A, you can see, has turned very thin, cachexic, right? Skin and bones maybe look like just the child has skin and bones, nothing else, no fat whatsoever, right? So this is a marasmus child. Can you look how alert this child is? If you offer food to this child will voraciously eat everything, right? So for example, take this child is 2 years of age. Normally at 2 years, the child can have 1 chapati. His appetite is so much that he can have 4 chapatis in one go. That means if offered food, he can have a lot of things and gain weight again. So the prognosis here is better. On the other hand, look at child B. This child is also malnourished. But instead of losing the fat from the body, the child has turned edematous. The child has swelled up, looking like a fat sugar baby, right? And can you look how this child is lying down listlessly? Not alert at all, lethargic. If you offer food to this child, the appetite of the child is also very low. So this child definitely has poor prognosis as compared to the marasmus child, right? Because the child is not having much food, has swelled up, is very lethargic. So this is nothing but a kwashiorkor child. So now let's jot down the differences between the two. We have seen both the children, right? So what could you see in marasmus? The child was wasted or not? Yes, the child was wasted. Even visible severe wasting is there. You could see the bones of the child, right? So you can appreciate wasting over here. This is visible severe wasting. What about kwashiorkor child? Could you see wasting? The child was edematous, so that wasted was hidden, right? So wasting is here also, but that's hidden, right? That is hidden, that is masked by edema. What about the general status? How was the marasmus child looking? The child was sitting, the child was alert. Kwashiorkor child was lethargic. Appetite, I told you the appetite of a marasmus child is voracious appetite. He can eat a lot of food, right? Voracious appetite. On the other hand, the kwashiorkor child, the appetite is low. Age at onset. So marasmus, remember broad concept that marasmus happens because of the general calorie deficit. So it can happen anytime. It can happen anytime. But usually kwashiorkor is due to protein deficit diet. So usually when the child's diet is switched to a more carbohydrate based diet after 1 year of age, you can appreciate kwashiorkor. Prognosis in marasmus is good. Here the prognosis is poor. Then you have skin and hair changes. Skin and hair changes, remember, you can see in both marasmus and kwashiorkor, but more appreciable, more in kwashiorkor, right? If you look at the liver, skin, liver would be shrunken over here, and fatty liver is seen in kwashiorkor. Now moving to the skin and hair changes. What all skin and hair changes you see? Three things, remember. Firstly, in hair. In hair, what will happen? What will you see? You will see a flag sign. Area of hyperpigmentation, hypopigmentation. In skin, you will see two things. First is flaky paint dermatosis, as if the skin is chipping off like a paint, flaky paint dermatosis. And crazy pavement appearance, crazy pavement appearance. Right? Now moving to the next topic, SAM. So whenever we discuss SAM, remember the utmost important thing is knowing what is SAM. So remember, how do we define SAM, or what is the criteria for SAM? To define a child as SAM or to label a child as SAM, you need any one. Remember, any one out of the three. What thing? Firstly, severe wasting. That means weight for height less than -3 standard deviation. That is severe wasting. Second is MUSE. Obviously, you will employ this for a child who is 6 months to 5 years of age. Right? MUSE less than 11.5 centimeters. And lastly, you have nutritional edema. Nutritional edema. So you need any one out of these to label a child as SAM. Right? So if a child has nutritional edema, and you will label it as SAM. If the MUSE is less than 11.5, you will label the child as SAM. If the weight for height is less than minus standard deviation, that less than 3 standard deviation, this is again SAM, right? So you don't need all three, you need any one out of these to label a child as SAM. So with that, we cover the general pediatrics and the nutrition aspect. Now we'll move down to genetics. And in genetics, the most important syndrome that we are going to cover is Down syndrome. What is Down syndrome? In Down syndrome, we have one extra chromosome, that is 21st chromosome. So this is nothing but trisomy 21. Trisomy 21. Right? What is this feature that I have shown over here? Can you see a single palmar crease? What is this? This is known as a simian crease. Simian crease seen in Down syndrome. What else? This is the hand finding. What about the foot? If you look at the foot of this child, you will notice a gap in between the grade toe and the other toes. This is known as sandal gap. Again seen in Down syndrome. What else do you notice over here? Look at the features. Notice the eyes. The outer canthi of the eye is up, pointing upwards, right? This is mongoloid slant. This is known as a mongoloid slant. If it goes down, this is known as the anti-mongoloid slant, right? So what can you see? Overall flat features. Eyes, you can see a mongoloid slant. What else? You can see an open mouth, protruding tongue. You can see epicanthal folds, flat facial profile. You can see redundant skin over the neck, right? Nuchal thickness, which is appreciated on the ultrasound. Small ears. All of these are the features of Down syndromes. Now, what is important for your exam are the association. That what are the most common associated finding in the cardiovascular system in a child with Down syndrome, GI finding, SMAT finding, endocrine finding. So, firstly, let's talk about the CVS finding. Remember, the most common cardiac heart CHT, most common CHT that you notice in Down syndrome patient is endocardial cushion defects. Endocardial cushion defects. Then in GIT, you notice annular pancreas, duodenal atresias. In hematological, remember these children have more chances of developing leukemias. And in leukemias, remember ALL more than AML. But when we talk about AML per se, then M7, that is megakaryocytic leukemias, is more common. In endocrine, remember these children have more chances of congenital hypothyroidism. Skeleton issue, they have problems with atlantoaxial dislocations, atlantoaxial dislocations. In neurological, very important, they have universal, remember, universal mental retardation is there. Universal mental retardation is there. Mental retardation is universal. So once Down syndrome child has happened, this child definitely is going to have low IQ as compared to the peers, right? So we don't want such a child to be living in the society, right? So it's very important that parents should be counseled around this condition, and thorough screening has to happen antenatally, so that if this Down syndrome is detected, we can counsel the parents and plan abortion as we go further, right? So antenatal screening, remember trimester wise, first trimester, second trimester, and first trimester we do dual test and ultrasound. In ultrasound, you basically look for the nuchal thickness. If the nuchal thickness is more than 3 mm, this is suggestive of Down syndrome. And blood test, we go for dual test. In dual test, we look for beta HCG and PAPE. Beta HCG and PAPE. Right? In second trimester, you are going to do triple test. In triple test, we do beta HCG. We go for Inhibin. Beta HCG, you look for unconjugated estriol and alpha fetoprotein. Quadruple test is nothing but triple test along with Inhibin. Now the examiner asks which increases, which decreases. So very simple trick to remember. Remember H for high. And Inhibin, I for increase. So these two things will increase, rest all will decrease. So if you look at the dual test, beta HCG and PAPA, so beta HCG would be high, PAPA would be low, right? Similarly, in triple test, what will happen? Beta HCG would be high, rest would be low, right? Inhibin would be high. So this is how you remember the antenatal screening of Down syndrome. Now, after trisomy, now let's talk about this monosomy, that is Turner syndrome. So we all know that what happens in Turner syndrome, there is monosomy XO. We have one less chromosome, 45 XO is the karyotype, right? 45 XO. So if there is no Y chromosome, what will happen? The sex here is going to be female. The IQ of these females is actually normal, but unfortunately they cannot reproduce because they have streak ovaries. So they usually present with amenorrhea, and they have an associated cardiac defect. We have left-sided heart defect. What is on the left side? Left atrium, left ventricle, aorta. So they have bicuspid aortic valve and coarctation of aorta as the common associations. Moving to Noonan syndrome. So why I am mentioning Turner syndrome and Noonan syndrome together? Because sometimes Noonan syndrome is labeled as male Turner. But remember, this is not male Turner, right? Here, the problem is a genetic problem, a gene problem, PTPN11 gene mutation. It could be in either 46XX, 46XY. This is an autosomal gene, right? Not related to any sex karyotype. So this can be either a male or can be a female. So the term male Turner is not justified, right? It could be a male, it could be a female. Here the IQ is low, but their reproductive capacity is intact, right? Males can just have undescended testes, otherwise they are fertile. Here you see right-sided heart defects. On right side you have right atrium, right ventricle, pulmonary artery. So you have pulmonary stenosis, right? So this is about Turner and Noonan syndrome. These are the typical features that you see. You see short stature, broad chest, increase in the carrying angle, streak ovaries, short fourth metacarpal, webbed neck, congenital heart defects, as I told you, low hairline, knee deformity. All of these are typical of Turner syndrome. Moving to the next genetic problem, Dye-George syndrome. Dye-George syndrome is actually a microdeletion disorder. Here what happens? The defect is in the chromosome number 22, right? Long arm of chromosome number 22. Because of this defect, there is defective third and fourth pharyngeal arch development, right? And because of that, you see a constellation of things. How do you remember it? Dye-George syndrome, catch 22. What is C? C is for the cardiac issue. What cardiac issue you see over here? We see conotruncal defects. Most common is conotruncal defect or TOF. Conotruncal defect or TOF. Then A is for abnormal faces, right? T is for your thymus. There will be thymic aplasia. C is cleft lip, cleft palate. H, remember, is hypocalcemia, hypocalcemia. And 22 is for the chromosomal defect, that is your chromosome number 22q11, right? So this is all about Dye-George syndrome. With that, we have covered genetics. Now let's move to an important section, that is neonatology. In neonatology, one of the most important segment is the respiratory distress problems in newborns. So one problem here would be in a preterm child, that is the child who is born prior to the term gestation. One problem you will see in a term baby and one problem in a post-term baby. So firstly, let's talk about the preterm baby. So preterm baby is born before the time, right? So his bodily organs are not mature, his lungs are not mature, the surfactant is also not mature. So because the surfactant is not mature, what will happen? The alveoli will collapse, there will be no air in the alveoli and it will look as a white out lung. How can we prevent this? We can prevent it by giving antenatal steroids, and finally the treatment here is CPAP or surfactant therapy. This condition is known as respiratory distress syndrome or hyaline membrane disease. तो क्या हो रहा है respiratory distress syndrome और hyaline membrane disease में? There is deficiency of mature surfactant, deficiency of mature surfactant. And what do you see on this X-ray? We see white out lung, white out lung. क्योंकि अब alveoli कोलैप्स कर गए हैं, वहाँ एयर नहीं है, लार्जर एयरवेज में बस दिखेंगी हमें एयर, जो कंडक्टिंग एयरवेज है. सो इट गिव्स अ एयर ब्रोंकोग्राम पैटर्न. सो यू विल सी एयर ब्रोंकोग्राम एंड वाइट आउट लंग. How can we prevent it? We can prevent it by giving antenatal steroids, and treatment you give CPAP therapy, or in severe distress we give surfactant by Ensure technique. What is Ensure technique? You intubate, give surfactant and then extubate. So this is all about RDS or highly membrane disease. Then you have a condition known as transient tachypnea of newborn. What happens in transient tachypnea of newborn? A term baby born via cesarean section. So normally what happens if the baby is born via vaginal birth? What will happen? The baby will be squeezed through the narrow vaginal canal. Inside the womb, the baby's lungs are not functional. They are filled up with amniotic fluid. So when the child through the vaginal birth comes out, all this excess fluid that is in the lungs is expelled through the mouth and nose. But when the child is delivered via C-section, what can happen? This amniotic fluid could be retained. There could be retained fluid in the lungs, and because of that, there is tachypnea. But this is a transient condition, right? The child will improve as soon as this fluid is resorbed. The child will improve. That's why it's a transient condition. So, what is this? The cause here is retention of fluid in lungs. Retention of fluid in lungs you see in C-section delivered babies. What do you see in X-ray? Again, you will see fluid in the X-ray. So this fluid you will see around the hilum, that is perihilar infiltrates. Also you will see in the fissures. You all understand there are fissures dividing the lungs into lobes. So you will see fluid in the interlobar fissures, right? So this is what all you see in the X-ray. First we see sunburst appearance, which is basically the perihilar infiltrates, and you will see fluid in the interlobar fissure. It is a transient condition, just supportive treatment has to be done, nothing else. Lastly, you have meconium aspiration syndrome. So if a child has crossed the term gestation, the child is a post-term child, or there is some intrauterine stress, what can the child do? The child can pass meconium. This meconium can be aspirated. Once this meconium aspirated, it can do three things. First, it can go and block one of my bronchioles, and that particular segment will definitely collapse because of that complete blockage. Or what can happen? It can not completely block but make a valve like mechanism in which the air can go inside but cannot escape. So there will be hyperinflation on that side. And overall, because meconium is a chemical substance, it can lead to inflammation, chemical pneumonitis. So these are the three things you will see. You will see collapse, that is atelectasis, right? So in those places where there is complete blockage, there will be collapse. So there is segmental collapse. Second, there is hyperventilation, hyperinflation. Third, you see chemical pneumonitis. Here also just supportive treatment has to be done. Sooner or later, this meconium will be eaten up by the macrophages and cleared up. Moving to the X-ray pictures that you're going to see. Look at the first picture. Can you notice? White out lung, right? Only you can see the big airways in their impression. So this is a white out lung that you see in RDS. Second, look at this picture. Can you notice collapse in one area, overall widening of the ribs, that is hyperinflation. This is meconium aspiration syndrome. Lastly, notice over here. Can you notice this white arrow? Fluid in the interlobar fissure, perihilar infiltrates. This is the sunburst appearance. So this is nothing but transient tachypnea of newborn, right? Okay, so any doubt till now? Okay, so if no doubt, Now let's go further. So अभी हमने पढ़ लिया respiratory distress की problems ना newborns में. There are different problems that are happening in newborns. अब one fine night, neonate comes to you with respiratory distress. You manage the child, give oxygen, give CPAP therapy, right, and stabilize the child. You were very hardworking, very sincere throughout the night. And in morning, when the consultant comes, your senior professor comes, you tell that, sir, this child came with severe distress. I managed the child, and the child is improving now, right? Consultant will look at you, look at the baby, and will ask, मुझे तो अभी भी लग रहा है distress है. How should I believe that you were very sincere in the night and you did a lot of things? So you should have a definite score with you, that when the child came, the distress was say 10 on 10, and now the distress has reduced down to 5 on 10, right? So there should be a score to tell me that when do you say this child is in severe distress, when do you say this child is improved and now it's mild distress. So there should be an objective scoring system for the respiratory distress in newborns, right? So we have different scores. We have two scores. One score is for term babies and one score is for preterm babies. So firstly, let's talk about the score in preterm babies. So preterm babies कैसे हैं? Small babies हैं. The name of their score is actually big. For small babies, that is preterms, the name of the score is big. What is that score? The score name is Silverman-Anderson score. Silverman-Anderson score. Right? So in this Silverman-Anderson score, we have 5 components: upper chest retractions, lower chest retractions, xiphoid retractions, nasal flaring, and grunting. Firstly, let's look at retractions. Very easy, right? ये 3 बहुत easy है. अगर mild retractions है 0, moderate 1, severe 2. Same goes for xiphoid. Mild 0, moderate 1, severe 2. जैसे जैसे स्कोर बढ़ रहा है वैसे वैसे डिस्ट्रेस बढ़ रहा है. सेम गोज फॉर नेजल फ्लेयरिंग. इफ देर इज नो नेजल फ्लेयरिंग, 0. If the nasal flaring is, let's say, mild, moderate to severe, right? Then you have grunting. If no grunting, 0. If the grunt is audible with just stethoscope, that means when the child comes, you cannot appreciate grunting, but as soon as you place your stethoscope, you can hear grunting. This is 1. So if the grunting is audible with stethoscope, it's 1. If you don't need a stethoscope, it's audible, even mother can hear the grunt. So if it is audible with naked ear, it's 2. Lastly, important है upper chest retractions. So remember what happens in upper chest retractions. Normally, if the child is lying like this, the chest and the abdomen movements are synchronous, right? The child breathes, the abdomen move follows, right? So the synchronous movement is there. If the child has distress and the chest movement is quite fast, what will happen? Initially, there will be a lag. Firstly, you see a lag on inspiration, and finally, you will see a complete dissociation. There will be seesaw movement of chest and the abdomen. This is score 2, right? So, firstly, in upper chest retractions, if the movement is synchronous, you label it as 0. If there is a lag on inspiration, 1. If there is seesaw movement, 2. So, this is all about your Silverman-Anderson score. Now I told you we have a score for term also. For term bachcha is bada bachcha, the name of the score is chota. Down syndrome. Here, to remember the components of Downey syndrome, we have a mnemonic GRACE, right? What is G? G is for grunting. R is for the respiratory rate. A is for air entry. C is cyanosis. And then you have retractions, right? Retractions is again very easy. No retractions, 0. Mild retractions, 1. Severe retractions, 2. Grunting is also same. No grunting, 0. Audible with stethoscope, 1. Audible with naked ear, 2. Then you have respiratory rate. The normal respiratory rate of a newborn is less than 60, right? Less than 60. If the respiratory rate is less than 60, 40 to 60 is the normal range. So if it is less than 60, it's normal, 0. If it is 60 to 80, 1. Above 80, 2. Air entry, if air entry is equal, normal, 0. If the air entry is decreased, 1. If the air entry is absent, 2. Then comes cyanosis. If there is no cyanosis, 0. If you notice that there is cyanosis, but as soon as you give oxygen, the cyanosis disappear, it's 1, right? So if there is cyanosis only on room air, cyanosis on room air, this is 1, right? But if you give oxygen despite giving 30%, oxygen, if still the child is cyanosed, this is 2. So if there is cyanosis on more than 30% oxygen, on 30% oxygen, this is 2, right? So this is about the respiratory distress scores in newborns. In neonatology, yet another topic is neonatal sepsis. Now let's move to that topic. So sepsis सबको पता है, infection हो गया, sepsis हो गया. What is the most common organism? कौन सा most common organism है neonatal sepsis कराने के लिए? Depend करता है examiner क्या पूछ रहा है. अगर पूछ रहा है what is the most common cause of neonatal sepsis in India, so remember, then the answer would be Klebsiella. But if the question says what is the most common cause of neonatal sepsis worldwide, then the answer is group B, Streptococcus. Group B, Streptococcus. Right? Now, depending upon कि ये इन्फेक्शन कहाँ से आया, ब्रॉडली हम डिवाइड कर सकते हैं न्यूनेटल सेप्सिस को इनटू अर्ली ऑनसेट न्यूनेटल सेप्सिस एंड लेट ऑनसेट न्यूनेटल सेप्सिस. राइट, अर्ली ऑनसेट एंड लेट ऑनसेट. अर्ली ऑनसेट मतलब बहुत जल्दी कहीं से इन्फेक्शन आ गया है. ये आप अर्ली न्यूनेट या लेट न्यूनेट से कंफ्यूज मत करना. रिमेंबर आपको बताया था न्यूनेट क्या होता है, फर्स्ट 28 डेज ऑफ लाइफ, राइट. अर्ली न्यूनेट इज द फर्स्ट 7 डेज, उसके बाद आता है लेट न्यूनेट. तो ये उससे कंफ्यूज नहीं करना है. ये अर्ली ऑनसेट न्यूनेटल सेप्सिस है, लेट ऑनसेट न्यूनेटल सेप्सिस है. सो अर्ली ऑनसेट न्यूनेटल सेप्सिस मतलब ये बहुत अर्ली इन्फेक्शन कहीं से मिल गया. कितना अर्ली? लेस देन 72 आवर्स ऑफ बर्थ, राइट. लेस देन 72 आवर्स ऑफ लाइफ में अगर बच्चे को कहीं से इन्फेक्शन मिला है, दैट्स अर्ली ऑनसेट सेप्सिस. आफ्टर दैट, आफ्टर 72 आवर्स, इट्स द लेट ऑनसेट सेप्सिस. सो अर्ली ऑनसेट सेप्सिस का सोर्स क्या होगा? इतना अर्ली तो मदर के पास ही रहता है बच्चा, तो मदर ही मेजरली सोर्स है. सो इफ there is prolonged labor for more than 24 hours, that's again a source of infection risk factor. If there is prolonged rupture of membranes more than 24 hours, again a risk factor. Spontaneous prematurity, risk factor. If birth asphyxia is there, risk factor. Multiple times अगर मदर का PV हुआ है, right, there are multiple times PV. Multiple times क्या कंसीडर करते हैं? 3 or more sterile or a single unsterile is a risk factor, right. And lastly, if the mother has chorioamnitis, that is also a risk factor. What about late onset sepsis? Late onset आप सबको पता है कहाँ से आएगा? After that हमारे आसपास सराउंडिंग से आएगा. सो कम्युनिटी एक्वायर्ड, हॉस्पिटल एक्वायर्ड होगा. सो व्हाट आर द रिस्क फैक्टर्स फॉर दैट? इफ देयर इज पुअर हाइजीन, if the child has been fed through bottle feeding, right. Cord care is not fine, poor cord care. All of these are the risk factors for late onset sepsis. Now, whenever a child presents to you with sepsis, I know sepsis है तो इसमें गोल्ड स्टैंडर्ड इन्वेस्टिगेशन क्या होगी? गोल्ड स्टैंडर्ड इन्वेस्टिगेशन होगी गो फॉर ब्लड कल्चर। ब्लड कल्चर में हमें पता चलेगा इन्फेक्शन है, सो गोल्ड स्टैंडर्ड इज blood culture. But we all know blood culture takes time 3 to 5 days. तब तक हम क्या करेंगे? तब तक हम एक स्क्रीनिंग टेस्ट करते हैं, दैट इज नोन एज सेप्सिस स्क्रीन। सेप्सिस स्क्रीन में कुछ कंपोनेंट्स हैं। क्या कंपोनेंट्स हैं? सबसे पहला कंपोनेंट है एब्सोल्यूट न्यूट्रोफिल काउंट। इफ एब्सोल्यूट न्यूट्रोफिल काउंट इज लेस देन 1800, दिस इज कंसीडर्ड एबनॉर्मल। फिर हम देखते हैं इमेच्योर टू टोटल न्यूट्रोफिल रेशियो। अगर इमेच्योर न्यूट्रोफिल ज़्यादा है, दैट मीन्स मोर देन 20% और 0.2, दिस इज एबनॉर्मल। We look for CRP if it is more than 1 nanogram per ml. And lastly, micro ESR more than 15 mm per hour. राइट, सो ये कंपोनेंट्स हम देखते हैं और ये एबनॉर्मल वैल्यूज हैं। टू लेबल द सेप्सिस स्क्रीन एज पॉजिटिव आई नीड 2 और मोर एबनॉर्मल वैल्यूज, राइट। सो अगर आपको 2 या मोर देन 2 एबनॉर्मल वैल्यूज दिखती हैं, यू से सेप्सिस स्क्रीन इज पॉजिटिव, सेप्सिस स्क्रीन इज पॉजिटिव, राइट। सो अब इन बच्चों का जिनका सेप्सिस स्क्रीन पॉजिटिव आएगा या ब्लड कल्चर में कुछ आएगा, उनको मुझे एंटीबायोटिक स्टार्ट करनी है। और कौन सी एंटीबायोटिक देनी है, कितनी ड्यूरेशन के लिए देनी है, उसके लिए कुछ हमारी एल्गोरिथम है। तो फर्स्टली हमारे पास एम्पेरिकल एंटीबायोटिक होती है जो हम उन बच्चों की स्टार्ट कर देंगे, एम्पेरिकली स्टार्ट कर देंगे बिफोर द ब्लड कल्चर इज वेटेड ऑब्वियसली, राइट। सो व्हाट आर द एम्पेरिकल एंटीबायोटिक्स? यू स्टार्ट विद एम्पिसिलिन एंड जेंटामाइसिन, राइट। अगर 48 आवर्स में कोई रिस्पॉन्स नहीं है तो we will upgrade to third generation cephalosporin. And remember, if the child has meningitis, तो आप ये empirical antibiotics नहीं देंगे, you will straight away start with this third generation cephalosporin. अब कितने ड्यूरेशन के लिए देना है? इफ सेप्सिस स्क्रीन इज पॉजिटिव, ब्लड कल्चर में कुछ नहीं आया, तब जस्ट 7 डेज के लिए देना है। इफ ब्लड कल्चर हैज कम आउट टू बी पॉजिटिव, तो 14 डेज के लिए देना है। और अगर मेनिंजाइटिस है तो 21 डेज के लिए देना है। सो वेरी इजी टू रिमेंबर, 1 वीक, 2 वीक, 3 वीक, राइट, right? So this is the antibiotic, the choice of antibiotic and the duration of antibiotic that you need to give. Okay. So moving to next important topic of neonatology, that is necrotizing enterocolitis. Necrotizing enterocolitis. So necrotizing enterocolitis एक बहुत ही severe form of sepsis है जो हम देखते हैं neonates में। तो नाम में ये देखो क्या है, itis inflammation हो रही है किसकी? enterocolitis, मतलब इंटेस्टाइन और कोलॉन की, स्मॉल इंटेस्टाइन और कोलॉन की। मोस्ट कॉमनली अफेक्टेड सेगमेंट कौन सा होता है आपका? मोस्ट अफेक्टेड सेगमेंट होगा आपका ascending, sorry, terminal colon, terminal ileum and your ascending colon. ये मोस्ट कॉमन सेगमेंट होता है जो अफेक्टेड होता है। और ये इन्फ्लेमेशन के बाद नेक्रोसिस हो जाती है, इन्फ्लेमेशन के बाद नेक्रोसिस हो जाती है। तो द बेल स्टेजिंग इज़ वेरी इंपॉर्टेंट। तो क्या हो रहा है यहाँ पे? इन्फ्लेमेशन हो रही है गट की, और इन्फ्लेमेशन होने के बाद नेक्रोसिस हो रहा है। नेक्रोसिस होने के बाद परफोरेशन हो जाता है गट का। परफोरेशन हो गया तो मतलब जो भी गट के कंटेंट्स हैं वो बाहर निकल जाएंगे, पेरिटोनाइटिस कराएंगे और गैस भी निकल जाएगी, एयर अंडर डायफ्राम की तरह दिखेगा आपको, नीमोपेरिटोनियम दिखेगा, राइट। सो डिपेंडिंग अपॉन कैसे इन्फ्लेमेशन चल रही है, बेल स्टेजिंग है हमारे पास, स्टेज 1, 2 एंड 3। जैसे जैसे बढ़ेंगे स्टेजिंग में वैसे वैसे वर्सन होगा चाइल्ड। तो मैं सारे पॉइंट्स वो एग्जाम पॉइंट ऑफ व्यू की तरह बताने वाली हूँ कि जो जो आपके लिए इंपॉर्टेंट है। सबसे पहले स्टेज 1। स्टेज 1 में आपको बेसिकली क्लिनिकल फीचर्स दिखते हैं, इमेजिंग में कुछ नहीं दिखता, राइट। द चाइल्ड विल बी सिक, फीड इंटॉलरेंस होगी, एब्डोमिनल डिस्टेंशन होगा, ब्लड एंड स्टूल्स हो सकता है। सो डिपेंडिंग अपॉन वेदर यू कैन एक्चुअली सी ब्लड विद योर नेकेड आइज या फिर आपको माइक्रोस्कोप के अंडर ब्लड देखना पड़ रहा है, वी कैन डिवाइड द स्टेज 1 into 2 stages, स्टेज 1 एंड स्टेज 2, राइट। स्टेज 1A एंड 1B, राइट। सो 1A में क्या होगा, आपको ब्लड देखने के लिए माइक्रोस्कोप चाहिए होगा। सो देयर इज occult blood and stools, occult blood and stool, Second, we have 1B. 1B में you can actually see the blood and stool. मदर को भी दिख रहा है, gross blood है, gross blood and stool. Now moving to stage 2. स्टेज 2 में वो सारे क्लिनिकल फीचर्स तो हमें दिखेंगे स्टेज 1 वाले. उसके अलावा वी सी अ पर्टिकुलर ट्रायड. दिस ट्रायड इज नोन एज अ मेटाबॉलिक ट्रायड. क्या दिखता है इस मेटाबॉलिक ट्रायड में? 3 चीजें दिखती हैं. सबसे पहले एसिडोसिस, मेटाबॉलिक एसिडोसिस. वी सी हाइपोनेट्रीमिया एंड वी सी थ्रोम्बोसाइटोपिनिया. थ्रोम्बोसाइटोपिनिया, राइट. और यहाँ हम इमेजिंग के बेसिस पे 2 स्टेज को डिवाइड करते हैं इनटू 2A एंड 2B. 2A में आपको दिखता है कि एयर जाके विद इन द इंटेस्टिनल वॉल ट्रैप हो गई है. दिस इज नोन एज न्यूमोटोसिस इंटेस्टिनालिस. न्यूमोटोसिस इंटेस्टिनालिस. एंड स्टेज B में आपको दिखता है कि एयर जाके पोर्टल वेन में ट्रैप हो गई है. दिस इज pneumatosis potalis. Pneumatosis potalis. Then moving to stage 3. अब स्टेज 3 में सारे 2 वाले फीचर्स तो दिखेंगे. उसके अलावा अब यहाँ परफोरेशन स्टार्ट हो गई है. परफोरेशन स्टार्ट हो गई तो गट के कंटेंट बाहर जाएंगे. देयर विल बी पेरिटोनाइटिस. सो फर्स्ट 3A इज योर फीचर्स ऑफ पेरिटोनाइटिस. Features of peritonitis, that is guarding rigidity, rebound tenderness, right. एंड 3B में आपको एक्सरे पे दिखेगा एयर अंडर डायफ्राम. दैट इज नीमोपेरिटोनियम. नीमोपेरिटोनियम, right. So this is about the bell staging. Any doubt in this bell staging? If not, then we can move ahead with a major topic, सबसे important topic आपके एग्जाम के लिए, that is neonatal resuscitation. बहुत important है. Give me 2 minutes and then we will start with neonatal resuscitation. Okay, so we are back. So we are back and we are starting with neonatal resuscitation. So whenever we discuss about neonatal resuscitation, remember 2 things. राइट जब बॉलीवुड मूवीज में हमने देखा है कि जब भी कोई कोलैप्स करता है वी स्टार्ट विद द चेस्ट कंप्रेशंस एंड एवरीथिंग, but here the focus is on the breath first. Neonatal resuscitation we won't focus on the heart, we focus on the breath first. Why? Remember, as a babies are born with a good heart and bad lungs, good heart and bad lungs. So we will focus on the lungs first. एक बार अच्छे से ventilation हो जाए, good ventilation हो जाए, then we will move to heart, right? So the cornerstone of NRP, remember, is ventilation. The cornerstone of NRP is effective ventilation. Right? After that, we will go for the heart. We will do chest compressions, give epinephrine and everything else. Right? So remember, at birth, firstly, there are 4 questions that you need to know. So pre-birth questions, whenever you are called for a delivery, you have to ask these 4 questions. First question, कैसा बेबी है, gestation age कैसी है, term है या pre-term है. Right? Second question, कोई risk factor, maternal risk factor है कोई. Then you have to ask about amniotic fluid, कि meconium है या नहीं है. And lastly, delayed cord clamping, that is cord care, cord management. Right? That is basically delayed cord clamping. कितनी delay करते हैं हम cord clamping? 60 seconds. Right? So this is about the pre-birth questions. क्यों पूछे हैं हमने pre-birth questions? देखने के लिए कि कोई risk factor है या delivery में या नहीं है. क्योंकि normally we say for a delivery that has no risk factors, one person trained in NRP is sufficient. But if there is some risk factor, then you need minimum 2 people. Right? So remember, minimum 1 person that is trained in NRP is required. But if it is a high risk delivery, you need 2. High risk delivery, you need 2. Right? So this was the pre-birth questions. Now when the child is born, you will move towards the post-birth questions. What are the post-birth questions? TTC, term, tone, cry. Right? Is the baby term? Is the tone of the baby good? Did the baby cry? If answer to any of these is no, then you have to do initial steps of resuscitation. What are the initial steps of resuscitation? Remember the mnemonic pads. Position, airway, dry, stimulate. Right? Position, slightly sniffing position to open up the airway. Dry the baby and stimulate. How do we stimulate? Flicker the soles of the baby, rub the back of the baby. This all has to be done. After initial steps of resuscitation, if the heart rate of the baby is less than 100, then you have to start ventilation. We go for positive pressure ventilation, जिसको अभी नई NRP में सिर्फ ventilation बोला है ना. तो positive pressure ventilation हम पहले बोलते थे, अब नया NRP बोल रहा है कि ventilation बोलो इसको सिर्फ. Right? So we'll start with ventilation. After 30 seconds of effective ventilation, if the heart rate is less than 60, you're going to start with now stimulating the heart. So we will start chest compressions along with the breaths. After 1 minute, that is 60 seconds of this chest compressions and breaths, if the heart rate is still less than 60, then we give epinephrine. If after 3 to 5 doses of epinephrine the child is still not responding, then you have to rule out 2 things. First thing is pneumothorax. Firstly, rule out pneumothorax. Right? You will auscultate the child, look for the breath sound. If breath sound is decreased on one side, this could be pneumothorax. You do needle thoracotomy. On the other hand, if no such thing is there, you can and you are suspecting blood loss, then you give volume expanders. So this is the flow of NRP. Term, tone, cry. If answer to any of these questions is no, you do initial steps of resuscitation. After initial steps of resuscitation, if the heart rate is less than 100, start ventilation. After 30 seconds of ventilation, if the heart rate is less than 60, you give chest compressions and breaths. You give that for 60 seconds. If after 60 seconds or 1 minute of this, if the heart rate is still less than 60, you give epinephrine. After 3 to 5 doses of epinephrine, if the child is not responding, you rule out two things, pneumothorax and blood loss. Pneumothorax है तो needle thoracotomy करना है, blood loss है तो volume expander normal saline देना है, right? So this was the basic concept. अब one liner करके हम पूरा NRP खत्म कर देंगे, right? So firstly, what did I told you? What is the most important step in neonatal resuscitation? What is the most important step in neonatal resuscitation? Remember, जब भी हमारा ये less than 60 more than untamed movements का ये doubt है, what about after giving CPR more than 60 हो गया तो क्या करना है? More than 60 हो गया तो अच्छी बात है ना, whatever you are doing is working for the child, continue that, shift to ventilator, resuscitate कर लिया आपने बच्चे को. हम तो ये worst scenario देखते हैं ना फ्लो चार्ट में कि ये नहीं हुआ तो क्या करना है आगे. स्टेबलाइज हो गया बच्चा तो ऑब्वियसली उसको फिर निकू शिफ्ट करो, वेंटी पे डालो. ये सेम चीज़ आप पीपीवी के बाद भी बोल सकते हो कि अगर मोर देन 100 हो गया मैम तो क्या करना है, कुछ नहीं करना है, फिर बच्चे को मॉनिटर करो, स्टेबलाइज हो गया बच्चा, राइट? ये तो वर्स्ट सिनेरियो हम डिस्कस करते हैं ना रिससिटेशन में. तो बेसिक कॉन्सेप्ट्स पे आते हैं. आई टोल्ड यू व्हाट इज द मोस्ट इंपॉर्टेंट स्टेप इन न्यूनेटल रिससिटेशन. मोस्ट इंपॉर्टेंट स्टेप वाज वेंटिलेशन, दैट इज इफेक्टिव वेंटिलेशन, दैट इज द कॉर्नर स्टोन ऑफ एनआरपी, राइट? देन कम्स द गोल्डन मिनट. गोल्डन मिनट क्या है? बर्थ के बाद से आपको इफेक्टिव वेंटिलेशन कब स्टार्ट कर देनी है. रिमेंबर दिस इज द गोल्डन मिनट. गोल्डन 1 मिनट है. विद इन 1 मिनट ऑफ बर्थ अगर बच्चे को वेंटिलेशन चाहिए तो वो स्टार्ट हो जानी चाहिए, राइट? दैट मीन्स आपका ये जो इनिशियल स्टेप्स थे ये सब कुछ विद इन 1 मिनट हो जाना चाहिए. अगर आपने डिले किया तो देयर कैन बी डैमेज टू द ब्रेन ऑफ द बेबी. दैट्स व्हाई इट इज नोन एज गोल्डन 1 मिनट. देन इनिशियल स्टेप्स के बाद, इनिशियल स्टेप्स जो आप इनिशियली करोगे उसमें क्या क्या पॉइंट्स हैं आपने रिमेंबर? पैच, पोजिशन, एयरवे, ड्राई, स्टिमुलेट, राइट? कौन सी पोजिशन में रखते हैं ताकि एयरवे ओपन हो? इट इज अ स्निफिंग पोजिशन. कि सक्शनिंग सब में करनी है. डिड आई टोल्ड यू टू सक्शन? नो, आई टोल्ड यू पोजिशन, एयरवे, ड्राई, स्टिमुलेट, राइट? सो रूटीन सक्शनिंग नहीं करनी है. नो रूटीन सक्शनिंग unless the baby is non-vigorous or obvious secretions दिख रही है, routine suctioning नहीं करनी. Normal heart rate in the newborn. What is the normal heart rate of a newborn? What is the normal heart rate? It's 120 to 160. 120 to 160 per minute. Positive pressure ventilation कब start करेंगे? If heart rate is less than 100 per minute. Chest compression कब start करेंगे? If heart rate is less than 60 after 30 seconds of effective positive pressure ventilation. What is the compression to ventilation ratio? It is 3:1. That means 3 compressions and 1 ventilation breath. तो 1, 2, 3 breath. 1, 2, 3 breath. क्या साइट होगी इस compression की? It is lower 1/3 of the sternum. Remember जिफी sternum पे नहीं करना, lower 1/3 of the sternum पे करना है. और डेप्थ कितना होना चाहिए? इट शुड कवर अगेन 1/3 ऑफ द एंटीरियर पोस्टीरियर डायमीटर ऑफ द चेस्ट. बेस्ट इंडिकेटर ऑफ इफेक्टिव वेंटिलेशन, हर जगह हम हार्ट रेट ही देख रहे हैं ना, तो इफेक्टिव वेंटिलेशन का क्या इंडिकेटर होगा? अगर वेंटिलेशन इफेक्टिव है तो हार्ट रेट बढ़ना चाहिए. इंक्रीज इन द हार्ट रेट, वेरी इंपॉर्टेंट वन लाइनर आपके एग्जाम में. बेस्ट इंडिकेटर ऑफ इफेक्टिव वेंटिलेशन इज इंक्रीज इन द हार्ट रेट, राइट? ऑक्सीजन कॉन्सेंट्रेशन पूछते हैं कि कितनी ऑक्सीजन कॉन्सेंट्रेशन से स्टार्ट करेंगे. फॉर टर्म न्यूनेट वी स्टार्ट विद 21%. फॉर प्री टर्म्स यू कैन स्टार्ट विद 21 to 30%. अगर बेबी का हार्ट रेट मोर देन 100 आ गया है आफ्टर इनिशियल स्टेप्स बट द बेबी हैज़ लेबर्ड ब्रीथिंग, देन वी गिव CPAP और वेंटिलेशन एज नीडेड. अब सर्कुलेशन वाली बात करते हैं. जब वेंटिलेशन हो गई उसके बाद एपिनेफ्रिन कब देंगे? I told you if the heart rate is less than 60 after 1 minute of coordinated ventilation and compression we give epinephrine. What is the preferred route for epinephrine? Remember intravenous route is the preferred route. हम umbilical vein के through देते हैं, right? So intravenous route is the preferred route. We give through umbilical venous catheter. The dosage is 0.2 ml per kg of 1:10,000 dilution of epinephrine. अगर IV एक्सेस नहीं मिल रहा है तो इंट्राऑस्टियस रूट या एंडोट्रेकियल रूट हम यूज़ कर सकते हैं. वॉल्यूम एक्सपैंडर कौन सा यूज़ करते हैं? नॉर्मल सलाइन. व्हाट इज द इंडिकेशन फॉर वॉल्यूम एक्सपेंशन? इफ देयर इज अ सस्पेक्टेड ब्लड लॉस और ब्लीड. नाउ कमिंग टू सम स्पेशल सिचुएशन. ये थोड़े पुराने कॉन्सेप्ट है, राइट? पहले क्या बोलते थे, अगर मेकोनियम स्टेन्ड लाइक करें, मतलब एमनियोटिक फ्लूइड अगर मेकोनियम स्टेन्ड है, तो इन बेबीज़ को, इन MSL बेबीज़ को दो कैटेगरीज में डिवाइड करते थे. फर्स्ट इज़ द विगरस बेबी. विगरस बेबी कौन सा बेबी है? विगरस बेबी वो बेबी है जो अच्छा एक्टिव बेबी है, गुड एक्टिविटी, हार्ट रेट इज़ मोर देन 100, एक्टिविटी इज़ गुड. दिस इज़ द विगरस बेबी, राइट? एंड व्हाट इज़ अ नॉन विगरस बेबी? नॉन विगरस बेबी हार्ट रेट लेस देन 100 होगा, एक्टिविटी पुअर होगा. तो अब NRP बोलता है कि चाहे बेबी विगरस हो या नॉन विगरस हो, हमें कुछ डिफरेंस नहीं है, दोनों को ही जैसे हम नॉर्मल प्रोटोकॉल फॉलो करते हैं वैसे करना है. अगर नॉर्मल बच्चा के भी हार्ट रेट अच्छी है, एक्टिविटी अच्छी है, तो हम जैसे पाथवे में जाएंगे वैसे यहाँ पे भी पाथवे में जाएंगे. हार्ट रेट कम है, एक्टिविटी पुअर है, नॉन विगरस है, अगेन PPV करेंगे, नॉर्मल पाथवे में जाएंगे. इन बच्चों को स्पेशल तरीके से ट्रीट नहीं करना है. मिकोनियम की विगरस सक्शनिंग नहीं करनी है, ट्रिकियल सक्शनिंग नहीं करनी है, वो सब माना है, ठीक है? डिलेड कॉर्ड क्लैंपिंग वेरी इंपॉर्टेंट है ना. क्यों करते हैं डिलेड कॉर्ड क्लैंपिंग? ये थोड़ा एक्स्ट्रा अमाउंट ऑफ ब्लड बच्चे को चला जाए, वो लेटर लाइफ में अनीमियाज के चांसेस कम हो जाते हैं. सो रिमेंबर, डिलेड कॉर्ड क्लैंपिंग अगर बच्चे को रिससिटेशन की ज़रूरत है तब नहीं करना है. इट्स नॉट डन इफ द बेबीज रिक्वायर इमीडिएट रिससिटेशन. मूविंग टू नाउ कॉन्जेनाइटल इन्फेक्शंस. अगर NRP में कोई डाउट है तो बताओ. NRP में डाउट? अनटेम्ड मूवमेंट्स, ये आपको मैंने बताया तो कि हम जो कर रहे हैं, वट एवर वी डिड, हमने रिससिटेट कर लिया बच्चे को, तो ऑब्वियसली अब आप उसको वेंटिलेटर पे शिफ्ट कर दोगे ना. वाई विल यू कंटिन्यू गिविंग CPR? एक बार रिससिटेट हो गया तो अडल्ट में भी ऐसे करते हैं, एक बार रिससिटेट हो गया तो CPR बंद कर दोगे ना. ये तो नॉर्मल सी ही बात है. We won't continue giving CPR. We will shift the patient to ventilator or any other supportive measure if required. बाद में हो सकता है आइनोट्रोप्स भी स्टार्ट करने पड़े. Okay, so that was all about NRP, and I think there's no further doubt. Let's move to congenital infections. Congenital infections में ये तीन infections बहुत important हैं: toxoplasmosis, congenital rubella syndrome and congenital CMV infection. तीनों में triad दिखता है. सबसे पहले toxoplasmosis की बात करते हैं. सबसे पहली चीज़ दिखती है यहाँ पे eye में. What do you see? Chorioretinitis. Chorioretinitis. Second thing you see in brain, we see diffuse calcifications. And third thing you see again in brain, hydrocephalus. Hydrocephalus, right? ये बहुत कंपेरेबल है, टॉक्सोप्लाज्मोसिस बहुत कंपेरेबल है कॉन्जेनाइटल CMV इन्फेक्शन से. कॉन्जेनाइटल CMV में क्या दिखता है? यहाँ पे भी सबसे पहले आपको दिखती है कोरियोरेटिनाइटिस. वहाँ पे क्या था? हाइड्रोसेफलस, बिग हेड था. यहाँ पे छोटा हेड दिखता है, माइक्रोसेफली. वहाँ पे कैसी कैल्सिफिकेशन थी? डिफ्यूज कैल्सिफिकेशंस थी. यहाँ पे पेरीवेंट्रिकुलर कैल्सिफिकेशंस होते हैं, अराउंड द वेंट्रिकल कैल्सिफिकेशन होती है, पेरीवेंट्रिकुलर कैल्सिफिकेशन, राइट? टू रिमेंबर CMV, आप CMV निमोनिक ही लगा सकते हो यहाँ पे, है ना. देखो, C इज फॉर कोरियोरेटिनाइटिस, M इज फॉर माइक्रोसेफली एंड V इज फॉर द पेरीवेंट्रिकुलर कैल्सिफिकेशन. सो ये दोनों कंपेरेबल हैं, टॉक्सोप्लाज्मोसिस एंड कॉन्जेनाइटल CMV. बस ये याद रखना, टॉक्सोप्लाज्मोसिस में बड़ा हेड हो रहा है एंड डिफ्यूज कैल्सिफिकेशन है. CMV में पेरीवेंट्रिकुलर कैल्सिफिकेशन है, छोटा हेड है. कोरियोरेटिनाइटिस तो दोनों में ही है, राइट? अब बात है कॉन्जेनाइटल रुबेला सिंड्रोम में. यहाँ पे क्या क्या दिखता है? यहाँ पे भी ट्रायड दिखता है, हार्ट डिफेक्ट, दैट इज PDA, कैटरैक्ट्स एंड सेंसरी न्यूरल हेयरिंग लॉस. सो ये 3 इम्पॉर्टेंट कॉन्जेनाइटल इन्फेक्शन हैं जो आपके टिप्स पे होने चाहिए, ये तीनों ट्रायड चीज़ें। अब मूव करते हैं डायरियाज पे। डायरिया इज ऑल्सो वेरी इंपॉर्टेंट टॉपिक फॉर पीडियाट्रिक्स। रिमेंबर पीडियाट्रिक्स में डायरिया का मोस्ट कॉमन कॉज इज एक्चुअली वायरल डायरियाज आर मोर कॉमन दैन बैक्टीरियल, राइट? Viral diarrhea are more common in bacterial. If you talk about viral diarrhea, then it is the rotavirus diarrhea that is the most common cause. और बैक्टीरिया में मोस्ट कॉमन कॉज इज ETEC, एंटेरोटॉक्सिकोजेनिक इक्वलाई। व्हाट अबाउट डायसेंट्री? डायसेंट्री क्या होता है? डायसेंट्री में लूज टूल्स के साथ साथ ब्लड होता है, देयर इज ब्लड अलॉन्ग विद द लूज टूल्स। यहाँ पे मोस्ट कॉमन कॉज इज अ बैक्टीरिया, दैट इज शिगेला, राइट? सो जैसे आपको पता है कि वायरल इज द मोस्ट कॉमन कॉज ऑफ पीडियाट्रिक डायरियाज, तो कोई भी डायरिया का पेशेंट आता है तो आपको ऑब्वियसली एंटीबायोटिक्स नहीं स्टार्ट करना है बिकॉज द मोस्ट कॉमन कॉज इज वायरल। So management of diarrhea has two aspects. Firstly is the dehydration management and second is the administration of zinc. Zinc helps कि डायरिया की फ्रीक्वेंसी कम करने में, रिकवरी बेटर करने में। अगर आपको भी डायरिया होता है you should take zinc, right? So let's start with dehydration first. So whenever you encounter a child with loose stools, vomiting, the very first step would be dehydration assessment. राइट? डिहाइड्रेशन could either be no dehydration, some dehydration और severe dehydration। अब देखो नो डिहाइड्रेशन नाम में ही है, ये बच्चा डिहाइड्रेटेड नहीं है, तो कैसा होगा ये बच्चा? ये बच्चा आपको बिल्कुल अलर्ट दिखेगा। अगर आप इस बच्चे को वाटर ऑफर करोगे तो ये बहुत आराम से जेंटलमैन लाइक वाटर पिएगा, तो मतलब इसकी थर्स्ट नॉर्मल है। इसका स्किन पिंच करके अगर आप देखोगे तो वो इंस्टेंट रिकॉयल कर जाएगी, इंस्टेंट रिकॉयल। आईज ऑल्सो लुक नॉर्मल, ओरल म्यूकोसा भी मॉइस्ट होगा, ठीक है? तो इस बच्चे को नो डिहाइड्रेशन है, इस बच्चे को हम देंगे प्लान ए। देन यू हैव सम डिहाइड्रेशन। अब इस बच्चे को सम लेवल ऑफ डिहाइड्रेशन आने लग गया है, तो कैसा होगा ये बच्चा? बहुत इरिटेबल होगा, वेरी इरिटेबल, चिड़चिड़ा बच्चा। इफ़ यू ऑफर वाटर टू दिस चाइल्ड, बहुत जल्दी जल्दी पानी पी जाएगा, वेरी ईगरली विद द चाइल्ड ड्रिंक, बहुत प्यास लगी हुई है इसको, थर्स्ट इज इंक्रीज्ड, विल ईगरली ड्रिंक वाटर। यहाँ पे अब स्किन पिंच बिकॉज सम डिग्री ऑफ डिहाइड्रेशन आ गया तो स्लोली जाएगी, राइट? सो स्लो रिकॉयल होगा, बट रिमेंबर इट विल बी लेस देन 2 सेकेंड्स, लेस देन 2 सेकेंड्स। आईज विल लुक sunken, ओरल म्यूकोसा विल बी ड्राई। यहाँ पे हम देंगे प्लान बी ऑफ डिहाइड्रेशन ट्रीटमेंट, राइट? देन यू हैव सिवियर डिहाइड्रेशन। अब डिहाइड्रेशन बहुत ज़्यादा सिवियर हो गई है, तो नाउ द चाइल्ड विल बी फुल टन कोमाटोस, वेरी लेथार्जिक कोमाटोस। अब लेथार्जिक कोमाटोस पानी को पी पाएगा क्या? नहीं पी पाएगा, तो यहाँ थर्स्ट चली गई, अनेबल टू ड्रिंक। नाउ द स्किन पिंच वुड बी वेरी स्लो रिकॉयल, more than 2 seconds. Eyes will look very sunken, mucosa will be very dry। यहाँ हम देते हैं प्लान सी ऑफ डिहाइड्रेशन, ठीक है? तो हमने अब देख लिया बच्चा नो डिहाइड्रेशन में, सम में या सिवियर में, और उस हिसाब से हम प्लान ए, प्लान बी, प्लान सी देखेंगे। नाउ लेट्स अंडरस्टैंड व्हाट इज प्लान ए, प्लान बी, प्लान सी। राइट? प्लान ए, प्लान बी एंड प्लान सी। सो प्लान ए की बात करते हैं। प्लान ए में हमने पढ़ा था कि अभी कोई डिग्री ऑफ डिहाइड्रेशन नहीं है, नो डिहाइड्रेशन इज देयर। सो इफ नो डिहाइड्रेशन इज देयर, मुझे बस लॉसेस जो हो रहे हैं वॉमिटिंग्स में या लूज स्टूल में, उसको रिप्लेस करना है, राइट? और ये बच्चा बहुत आराम से पी सकता है, थर्स्ट इज नॉर्मल। सो व्हाट डू यू थिंक, मैं यहाँ कौन सा फ्लूइड दूंगी? ओरल फ्लूइड दूंगी या IV फ्लूइड दूंगी? बच्चा आराम से पी सकता है, तो वी कैन गिव ओरल रिहाइड्रेशन solution, ORS, right? And we just have to do replacement of the losses. So usually we say 10 ml per kg per loose stool, 10 ml per kg per loose stool we give, ठीक है? 10 ml per kg per loose stool। अब आते हैं प्लान बी पे, जो था सम डिहाइड्रेशन के लिए। ये सम डिहाइड्रेशन वाला बच्चा भी ओरली ले सकता है, इरिटेबल था लेकिन थर्स्ट बहुत बढ़ गई थी तो ओरली ले सकता है। तो अगेन मैं यहाँ पे ओरल थेरेपी दूंगी, ओरल रिहाइड्रेशन सोल्यूशन। बट यहाँ पे सम डिग्री ऑफ डिहाइड्रेशन आ गया है, तो पहले मुझे रिहाइड्रेट करना है बच्चे को, साथ साथ उसके जो लॉसेस हो रहे हैं उसको भी रिप्लेस करना है। तो रिप्लेसमेंट ऑफ लॉसेस तो सेम रहेगा, 10 ml per kg। Rehydrate कैसे करेंगे? We give 75 ml per kg over the next 4 hours. तो अगर 10 किलो का बच्चा है तो यू हैव टू टेल द मदर दैट यू हैव टू गिव 750 ml ऑफ ORS ओवर द नेक्स्ट 4 hours. और साथ साथ अगर बच्चा लूज टूल जा रहा है तो 10 ml per kg, दैट इज 100 ml आपको और देते रहना. एंड अलॉन्ग विद दैट नीडलेस टू से मेंटेनेंस फ्लूइड्स तो जाने ही चाहिए बच्चे को. देन वी मूव टू प्लान सी. अब प्लान सी में बच्चा कैसा हो गया है? एकदम सिवियरली डिहाइड्रेटेड हो गया है, बिल्कुल लेथार्जिक है, पानी पी ही नहीं पा रहा है, अनेबल टू ड्रिंक. सो यहाँ पे वी विल गिव IV रिहाइड्रेशन थिंग, दैट इज रिंगर लैक्टेट. यहाँ रिहाइड्रेशन कैसे करते हैं हम? 100 ml per kg, 100 ml per kg. ये 100 ml per kg फर्दर डिवाइड करते हैं 30 ml per kg बोलस एंड रिमेनिंग 70 ml per kg. तो अगर छोटा बच्चा है, लेस देन 1 year है, तो ये 30 ml per kg हम देते हैं ओवर 1 hour स्लोली स्लोली, और उसके बाद बचा हुआ ओवर 5 hours. लेकिन अगर बड़ा बच्चा है 1 year से ऊपर है तो विद इन हाफ एन आवर यू विल गिव दिस 30 ml per kg एंड रिमेनिंग 2.5 hours में आप रेस्ट 70 ml per kg दोगे. रिप्लेसमेंट ऑफ लॉसेस सेम 10 ml per kg. ऑब्वियसली ये IV होगा एंड वी विल इंश्योर मेंटेनेंस फ्लूइड. अब ये मेंटेनेंस फ्लूइड क्या है? Maintenance fluid is something that you, me, everyone needs on a daily basis. ये normal आपकी bodily function के लिए आपको लेने ही चाहिए, right? So needed to say ये तीनों ही plans में हमें ensure करना है कि इतना तो मिलता ही रहे. ये maintenance fluid है. कैसे calculate करते हैं maintenance fluid? We calculate by the holiday cigar method. Holiday cigar method कहता है for the first 10 kgs we have to give 100 ml per kg. For the next 10 kg, you give 50 ml per kg. And thereafter for every subsequent kg, 20 ml per kg. So for example, अगर मैं आपको बोलूँ एक 22 kgs का बच्चा है, उसका maintenance fluid calculate करो, तो कैसे करोगे? First 10 kgs would be 100 into 10, that is 1000 ml. Then for the next 10 kg, it will be 50 into 10, that is 500 ml. And lastly, बचे 2 किलो का 20 into 2, that is 40 ml. So the total maintenance fluid requirement of this child would be 1540 ml. इतना तो maintenance fluid उसको लेना ही है. उसके अलावा replacement of losses, rehydration you have to give, right? So this was all about the maintenance fluid. So this completes your diarrhea and the management. Zinc, I told you everyone should get for at least 14 days, right? Dosage की बात करें तो less than 6 months में you give 10 mg per day. After that you give 20 mg per day, right? So this was all about diarrhea, dehydration and management. Now moving to a next very important topic, that is pneumonia. So pneumonia की जब भी बात करेंगे pediatrics में, you need to know about these IMNCI guidelines that divide pneumonia into no pneumonia, pneumonia and severe pneumonia, right? जैसे dehydration में था ना, no dehydration, some dehydration, severe dehydration. तो ये some pneumonia जैसा कुछ नहीं होता, या तो pneumonia है या तो नहीं है, right? So no pneumonia, pneumonia and severe pneumonia. Before we move on to this IMNCI guidelines, आपको ये 3 चीज़ें पता होनी चाहिए. एक तो what are the fast breathing, what are the danger signs, right? So what is fast breathing? कब बोलेंगे कि बच्चा तेज तेज सांस ले रहा है? So remember, less than 2 months में more than 60 breaths per minute, 2 to 12 months more than 50, and after that more than 40. So 60, 50, 40, right? And you should also know about the danger signs. Danger signs क्या है? If there is stridor in a calm child, that is a danger sign. If there is severe respiratory distress, बहुत ज़्यादा retractions दिख रहे हैं, cyanosis हो रहा है, if the child is unable to drink, if the child is abnormally sleepy, if the saturation is less than 90, if there are seizures, convulsions, ये सारे danger signs हैं. इनमें से कोई भी danger sign हुआ तो ये severe pneumonia है straight away, right? So very simple सा logic. अगर फास्ट ब्रीथिंग नहीं है और कोई डेंजर साइन नहीं है, सो दिस इज नॉट निमोनिया, राइट? दिस इज नॉट निमोनिया, दिस इज जस्ट सम अपर रेस्पिरेटरी इन्फेक्शंस, कोल्ड कॉफ है बच्चे को, सपोर्टिव ट्रीटमेंट देनी है, राइट? सेकेंड इज निमोनिया. अगर फास्ट ब्रीथिंग है या रिट्रैक्शंस हैं, बट कोई डेंजर साइन नहीं है, दिस इज निमोनिया. And lastly, जैसे ही कोई danger sign आया, this is severe pneumonia. तो very simple concept, right? So remember, no pneumonia, what will happen? The child will have cough, cold, upper respiratory tract infection like symptoms. There will be no respiratory distress, no retractions, no tachypnea, no danger signs. So यहाँ पे कुछ नहीं करना है, बस supportive treatment देना है. राइट, सूथिंग एजेंट्स आप दे सकते हो, अगर वीज है तो नेबुलाइज करा सकते हो, फीवर है तो पैरासिटामोल दे सकते हो. व्हाट विल हैपन इन निमोनिया? अब निमोनिया में देयर विल बी ईदर टैकिपनिया, फास्ट ब्रीथिंग, and or retractions. But remember, there will be no danger signs. No danger signs. तो दो यहाँ बच्चे को निमोनिया बट कोई डेंजर साइन नहीं है, इस बच्चे को एडमिट करने की ज़रूरत नहीं है, हम घर पे ही एंटीबायोटिक्स दे सकते हैं. तो आई विल सेंड दिस चाइल्ड with amoxicillin for 5 days, tell about danger signs and ask about follow up after 5 days, right? Then you have severe pneumonia. जैसे ही कोई danger sign आता है, this child is severe pneumonia. तो यहाँ पे आप डायरेक्टली इंजेक्टेबल एंटीबायोटिक दोगे. वी गिव 1 shot of ampicillin and gentamicin and send this, refer this patient to higher center. So this is about the IMNCI guidelines for pneumonia, right? रेस्पिरेटरी सिस्टम में येट अनदर इम्पॉर्टेंट टॉपिक आपके एफएमजी एग्जाम के लिए सिस्टिक फाइब्रोसिस. बहुत बार क्वेश्चन पूछे हुए हैं, इसलिए ये डिटेल में अभी हम पढ़ेंगे. सो कैसी कंडीशन है, कैसा इनहेरिटेंस है सिस्टिक फाइब्रोसिस का? ऑटोसोमल रिसेसिव है. एंड विच जीन इज इन्वॉल्व? CFTR जीन इज इन्वॉल्व. कौन से क्रोमोसोम पे है CFTR जीन? क्रोमोसोम नंबर 7. The most common mutation is delta F508. बहुत सारी mutation हो सकती है. This is the most common, that is deletion of the phenylalanine at 508 position. और कौन सा प्रोटीन टाइप का डिफेक्ट है? CFTR प्रोटीन है, हमारा चैनल है, that is a chloride channel defect. अगर पैथोजेंस की बात करें, मोस्ट कॉमन बाय एज इन इन्फेंसी एंड चाइल्डहुड इज द स्टैफ ऑरियस. अडल्ट्स में यू सी सूडोमोनास. ये सारे वन लाइनर्स हैं जो आपके एग्जाम में पूछते हैं, राइट? सूडोमोनास. देन यू ऑल नो सिस्टिक फाइब्रोसिस में थिक सिक्रीशंस हो जाती हैं, उसकी वजह से पैनक्रियाटिक इनसफिशिएंसी, मेकोनियम, इलियस, रेक्टल प्रोलैप्स, लिवर इन्वॉल्वमेंट, मेल इनफर्टिलिटी इज देयर. व्हाट इज द गोल्ड स्टैंडर्ड टेस्ट फॉर डायग्नोसिस? इट इज द स्वेट क्लोराइड टेस्ट. स्वेट क्लोराइड टेस्ट, राइट? कब बोलते हैं डायग्नोस्टिक? अगर स्वेट क्लोराइड में आपने नोटिस किया कि स्वेट क्लोराइड के लेवल्स आर मोर देन 60 मिलीमोल पर लीटर इन 2 सेपरेट ओकेजन्स, दिस इज डायग्नोस्टिक. एंड कंफर्मेटरी टेस्ट क्या होगा? जेनेटिक टेस्टिंग, जिसमें आप CFTR म्यूटेशन रखोगे. ऑब्वियसली कोई परमानेंट क्योर नहीं है अभी, वी जस्ट हैव टू कंट्रोल द सिम्टम्स एंड कॉम्प्लिकेशंस. एयरवे क्लियरेंस के लिए फिजियोथेरेपी, ड्रग्स दे सकते हैं म्यूकस को थिन आउट करने के लिए, एंटीबायोटिक्स फॉर इन्फेक्शंस, पैनक्रियाटिक एंजाइम रिप्लेसमेंट, फैट सॉल्युबल विटामिन्स, CFTR मॉड्यूलेटर्स आप फार्मा में पढ़ते हो, ईवा कैफ्टर, ल्यूमा कैफ्टर. वन लाइनर्स जो आपके लिए इंपॉर्टेंट है, इनकी मैनिफेस्टेशंस. रिमेंबर, अर्लीस्ट GI मैनिफेस्टेशन इज your meconium ileus, right? Meconium ileus. If you talk about the earliest pulmonary pathogen, I told you staph. Earliest मतलब infancy में staph aureus, लेकिन most characteristic is your pseudomonas. And lastly they ask कि most lethal कौन सा है? Most common तो हो गए, most lethal मतलब fatal infections कौन से हैं? So remember, that's Burkholderia, Capaccia, right? So with that we cover the respiratory system. Let's move to the कार्डियक सिस्टम नाउ. कॉन्जेनाइटल हार्ट डिसीज, उसमें सबसे इंपॉर्टेंट है ये टेबल, एसोसिएशन ऑफ द कॉन्जेनाइटल हार्ट डिसीजेस विद जेनेटिक सिंड्रोम. कुछ तो हम कवर कर चुके हैं, जैसे हम डाउन सिंड्रोम में पढ़ चुके हैं, वीसी एंडोकार्डियल कुशन डिफेक्ट्स, टर्नर नूनान में पढ़ चुके हैं, लेफ्ट साइडेड, राइट साइडेड. सो ये एक कंपाइलेटेड टेबल है जो आपको बिल्कुल रिवाइज करनी है एग्जाम से पहले, क्योंकि बहुत फ्रिक्वेंटली पूछते हैं, राइट? सो डाउन सिंड्रोम वी जस्ट डिस्कस्ड. कहाँ क्या देखते हैं? मोस्ट कॉमनली एसोसिएटेड कॉन्जेनाइटल हार्ट डिसीज, endocardial cushion defects, endocardial cushion defects. Then you have Turner syndrome. टर्नर सिंड्रोम में हमने पढ़ा था कौन से साइडेड दिखते हैं, लेफ्ट साइडेड हार्ट डिफेक्ट्स दिखते हैं, जैसे बायकस्पिड एओर्टिक वाल्व, कोआक्टेशन ऑफ aorta. Noonan में right sided defects like pulmonary stenosis. Then we have Edward and Patau. Edward and Patau क्या है, ये भी trisomies हैं. Edward में you have trisomy 18, Patau you have trisomy 13. In both of these the most commonly associated congenital heart defect is VST. Then we have Digeorge syndrome. I told you कौन सा common होता है यहाँ पे, conotruncal defects, TOF जैसे, conotruncal defects जैसे TOF. Then you have Williams syndrome. यहाँ पे most commonly associated is supravalvular aortic stenosis, supravalvular AS, right? Congenital heart disease में ये table बहुत important है, commonly associated congenital heart defects with their genetic syndromes. विद दैट एक और टेबल बहुत इंपॉर्टेंट है कि मदर में कोई कोई ऐसी कंडीशन जिसकी वजह से बच्चे को हार्ट डिफेक्ट्स हो जाते हैं, राइट? मेटर्नल कंडीशंस एंड एसोसिएटेड हार्ट डिफेक्ट्स. फर्स्ट इज जेस्टेशनल डायबिटीज. अगर मदर को जेस्टेशनल डायबिटीज है तो देयर आर चांसेस कि बच्चे को हार्ट डिफेक्ट हो सकते हैं. विच हार्ट डिफेक्ट? रिमेंबर मोस्ट कॉमन इज VST and the most specific one is transposition of great arteries. If mother has rubella, baby can have congenital rubella syndrome. And what is the commonly associated CHT in congenital rubella syndrome? We just discussed, it's PDA. If mother is an alcoholic and is taking alcohol throughout the pregnancy, baby can have fetal alcohol syndrome, right? And also if the mother is on phenytoin and continues to take phenytoin throughout the pregnancy, that can lead to fetal hydantoin syndrome. इन दोनों ही conditions में VST बहुत common है, right? If the mother has bipolar disorder and is taking lithium for the same, बच्चे को क्या होने के chances हैं? Box shaped heart, that is Epstein anomaly. If mother has SLE and anti-Ro antibodies, there are chances that the child can have heart blocks, neonatal heart blocks, bradycardia. Right? With that, it's very important to recognize X-rays. Right? पहला X-ray देखो कैसा है, snowman appearance, snowman appearance, also known as figure of 8 appearance. कहाँ देखते हैं आप ये figure of 8 appearance और snowman appearance? Yes, correct. We see in this supracardiac TAP. We see supracardiac TAP. We see. Remember, supracardiac में दिखता है, infracardiac में white out दिखता है. Then you have this boot-shaped heart. Where do you see this boot-shaped heart? TOF, tetralogy of Fallot. Then you have this box-shaped heart. Where do you see this box-shaped heart? We see this in Epstein anomaly, atrialization of ventricle. Then you have this egg on string appearance. Where do you see this egg on string appearance? This we see in transposition of great arteries, right? Transposition of great arteries. ये X-rays, pictures बहुत important है, बहुत frequently exam में पूछते हैं, right? With that बस एक छोटा सा topic रह गया, वो करके हम कवर करेंगे, रैप अप करेंगे सेक्शन को. न्यूरो में टॉपिक है, दैट इज पीडियाट्रिक एपिलेप्सी सिंड्रोम्स, राइट? तो पहला पीडियाट्रिक एपिलेप्सी सिंड्रोम वेस्ट सिंड्रोम है. तो रिमेंबर जब भी हम ये सिंड्रोम्स की बात करते हैं ना, 3 चीज़ें आपको पता होनी चाहिए. एज ग्रुप, किस एज ग्रुप में दिखता है, किस टाइप का सीजर दिखता है, EEG फाइंडिंग क्या है, एंड देन वी विल डिस्कस अबाउट द ट्रीटमेंट. सबसे पहले वेस्ट सिंड्रोम. व्हाट इज द एज ग्रुप? लेस देन 1 ईयर. कैसा सीजर दिखता है यहाँ पे? टिपिकल सलाम स्पेल्स, राइट? सो रिमेंबर यहाँ एक ट्रायड दिखता है आपको. व्हाट इज दैट ट्रायड? फर्स्ट कंपोनेंट ऑफ दैट ट्रायड इज द सीजर टाइप. कैसा सीजर टाइप है यहाँ पे? वी सी सलाम स्पेल्स, दैट इज इन्फेंटाइल स्पैसम. Second aspect is a developmental finding. We see developmental regression. That means loss of previously attained milestone. मतलब पहला जो बच्चा बैठ पा रहा था वो बैठ नहीं पाएगा. Developmental regression. And third finding is the EEG finding. What is the EEG finding? We see a very chaotic pattern, high voltage chaotic pattern. This is known as hips arrhythmia. Hips arrhythmia. What is the drug of choice over here? देखो जो recent गई है वो बोलती है drug of choice is steroids और ACTH, मतलब दोनों का ही नाम ले लेती है, स्टेरॉयड और ACTH। लेकिन अगर आपको एक चूज करना हो तो चूज स्टेरॉयड्स, क्योंकि एम्स में तो स्टेरॉयड्स ही देते हैं, राइट। और दूसरा पूछते हैं कि अगर ये वेस्ट सिंड्रोम ट्यूबरस स्क्लेरोसिस के साथ एसोसिएटेड है तो ड्रग ऑफ चॉइस क्या होगी? देन द ड्रग ऑफ चॉइस इज विकापैट्रिन, 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 राइट। सेकेंड इज ड्रावे सिंड्रोम। अब ड्रावे सिंड्रोम का एज ग्रुप इज 1 to 2 years। यहाँ क्या दिखता है, यहाँ क्या क्लिनिकल फीचर्स दिखते हैं? इनिशियली क्या होगा, बच्चे को फेब्राइल सीजर होंगे, फिर लो फीवर के साथ भी सीजर आने लगेंगे, फिर विदाउट फीवर भी सीजर आने लगेंगे, दैट इज ए फेब्राइल सीजर। एंड आफ्टर 1 year ऑफ एज मल्टीपल डिफरेंट टाइप्स ऑफ सीजर्स आएंगे। अब मल्टीपल डिफरेंट टाइप्स ऑफ सीजर्स आते रहेंगे बच्चे को, डिफिकल्ट टू ट्रीट सीजर्स आएंगे, तो देयर विल बी अ डेवलपमेंटल डिले, राइट। यहाँ ईईजी में भी देखोगे तो आपको, बिकॉज डिफरेंट डिफरेंट सीजर्स आ रहे हैं, एक एबनॉर्मल ईईजी पैटर्न दिखेगा। What is the drug of choice over here? The drug of choice here is valproate. We give valproate. Right? After Dravet, we have LGS, that is Lennox-Gastaut syndrome. यहाँ age group is after 2 years of age. यहाँ क्या दिखता है? यहाँ पे भी आप ट्रायड की तरह याद रखो। फर्स्ट सीजर टाइप्स, कैसे सीजर टाइप दिखते हैं? मल्टीपल टाइप्स ऑफ सीजर्स, फोकल, जनरलाइज्ड, अलग अलग टाइप के सीजर्स। देर विल बी डेवलपमेंटल डिले ऑब्वियसली, क्योंकि ये डिफिकल्ट टू कंट्रोल सीजर्स है। और एक ईईजी फाइंडिंग दिखती है। व्हाट इज दैट ईईजी फाइंडिंग? रिमेंबर here we see 2 to 3 heart spike wave complex, 2 to 3 heart spike wave complex. Here the drug of choice again is valproate. Then you have Jan syndrome, that is juvenile myoclonic epilepsy. ये किसमें दिखती है? adolescent girls में, adolescent girls। and remember कैसे सीजर्स होते हैं यहाँ पे? वी हैव मायोक्लोनिक जर्क्स, मतलब शॉक लाइक कॉन्ट्रैक्शंस। मायोक्लोनिक जर्क्स जो किस चीज से प्रोवोक होते हैं? दे आर प्रोवोक्ड बाय स्लीप डेप्रिवेशन एंड अल्कोहल कंजम्पशन। यहाँ टिपिकल कैसा दिखता है आपको? 4 to 6 hearts polyspike wave complex। Here drug of choice is again valproate, but a safer alternative we have today, that is levetiracetam, levetiracetam। Lastly we have absence seizures। क्या होता है absence seizures में? School going child में there are brief episodes of vacant staring, right? So school going child, brief episodes of vacant staring look, and this is provoked by hyperventilation, provoked by hyperventilation। Here you see a typical EEG pattern of 3 hearts spike and wave complex, 3 hearts spike and wave complex। Here the drug of choice, remember, is ethosuximide. If ethosuximide is not available in the options, choose valproate, choose valproate, right? So this is about the epilepsy syndromes. With that we end our marathon session. If any doubt regarding anything of this session, please drop down that in the comment section. If not, we can wrap up and have our dinners. PDF तो आपको ऐप पे मिल जाएगी, PDF would be shared soon on the app। Okay, I think no other doubt is there. We can wrap up the session. All the best for your exam. Do well, revise these high yield topics, and I know you all will pass with flying colors, right? जैसे responses आ रहे थे, most of you are responding very right. I wish you all the best for your exam. Do well, and we will meet on the other side. Thank you. Have a good night. Have dinners and sleep well.